Welcome our moderators and the attending experts and all the staffs on site. So today marks the official start of the Taipei Valve Summit 2024, a 3-day event packed with exciting live demos and the discussions. Whether you missed out yesterday's JE Valve activities, there is no need for regret, because today Taipei Valve Summit promised to offer you insight and strategies for management of valve-related disease from both cardiovascular surgeons and the cardiologist perspectives. So without further ado, let's dive into this gathering of further expertise and experience. But before this, let's welcome Professor Wei give us an opening remarks before everything. Thank you.
Okay. Dear guests, and also coming from all the international countries, and also Taiwan, and I'm delighted to say some words before great opening tomorrow, since many distinguished guests is coming from New York Valve, so they are flying to Taiwan probably today. So so the grand opening will be tomorrow. So, but anyway, I welcome everybody coming from different countries to attend this meeting, and this is the 9th year of our Taipei Valve Summit. So, and you know, nowadays the treatment for the valve, it's evolving, and I think there are many new strategies and new devices for the treatment for the heart valve disease. So I think that there's a very good chance for our staff and also our guests coming from different countries to share the experiences with each other. So let's start our program. Thank you.
So welcome our first section's moderators and experts.
Dear colleagues, I'm Dr. Yin from Taipei Cheng-Hsien General Hospital. It's my great pleasure and honor to open the first session of this meeting. As we know, recently there is a hot topic regarding the hemodynamics performance of the valve and the so-called patient-prosthesis mismatch issue. As we extend the indication of TAVR to younger population with longer life expectancy, I think the valve durability and the performance will be a big issue and the concern of the patient and their families. So the first topic will be cover this issue, and we will also have 2 live demonstrations in this session. The first case will be conducted by Dr. Tsao and Dr. Lee from our hospital. And the second case will be transmitted from Shanghai Fudan Zhongshan Hospital by Professor Junbo-Ge, Zhou Daxing, and Pan Wenzhi. The other issue we want to cover in this session briefly is the TAVR in rheumatic aortic stenosis, because in this part of the world, rheumatic heart disease is still an issue, especially in South Asia and Southeast Asia. So let's get started. And the first presentation will be delivered by Professor Michael Reardon. The topic will be patient-prosthesis mismatch, hemodynamics, and the durability for the self-expanding TAVR valve and the clinical implication.
I'm Dr. Michael Reardon. I'm professor of cardiothoracic surgery and the Allison Family Distinguished Chair of Cardiovascular Research at the Houston Methodist Hospital in Houston, Texas. Today I'd like to talk about patient prosthetic mismatch, hemodynamics, and durability for the Evolut self-expanding TAVR valve and the clinical implications. I have a number of TAVR conflicts of interest, having led a number of the national and international trials, but I'm also a cardiac surgeon. We'll start off by talking about patient prosthetic mismatch. Patient prosthetic mismatch was first brought to us by Rahmatullah, a cardiologist at Cedars in Los Angeles, when Rahmatullah said that if a surgeon puts in a valve that has an effective orifice area, an EOA, that's inadequate for the patient's physiologic needs, that patient has mismatch. Unfortunately, that applied to most of the surgical valves done in the days of Rahmatullah. We've moved forward. Pibro and Dumasile looked at 68 patients, and they looked at maximum exercise gradient versus index orifice area and looked for bends in the curve. And they used these 68 patients in this study to define what we now use as the definition of patient prosthetic mismatch, being severe if it's less than 0.65 centimeters squared per meter squared, between 0.65 and 0.85 centimeters squared per meter squared, moderate. And then there is a factor built in for obesity also. We actually looked at the 1500 Paragon trial, which is the valus pericardial valve, and did the same thing. And what we see is there really aren't many elbows in the curve, but the smaller index orifice area, the higher your initial gradients are. Now, does this really matter? Well, this is Howie Herman's work from the TVT registry in the U.S., looking at patients that have TAVR, and what Howie showed us is if you had severe patient prosthetic mismatch, even by 12 months, it was a marker for increased mortality. This is Fallon's work using the STS database. Fallon looked at almost 60,000 patients that had isolated aortic valve replacements that were 65 or older. What Fallon showed us that any level of patient prosthetic mismatch, whether it was moderate or severe, was a marker for increased mortality and increased readmission rates both for heart failure and aortic valve reintervention. So patient prosthetic mismatch matters. It affects your mortality and it affects your recovery. Now, this is Fleming's work from Germany showing that patient prosthetic mismatch was also a marker for early structural valve deterioration. And in fact, we see there's a lot of markers for structural valve deterioration: female gender, small body surface area, small valve size, small index EOA. But there's only one that's a marker for increased mortality and structural valve deterioration, and that's patient prosthetic mismatch. Now, if you were in the low-risk trial and you got assigned to the surgical arm, by 1 year you had a 5 times higher incidence of moderate to severe patient prosthetic mismatch than if you had an Evolut valve in the low-risk trial. It's clearly going to have some important implications. If you compare the Evolut low-risk trial versus the PARTNER 3 trial, you see the rate of patient prosthetic mismatch is much lower in the Evolut self-expanding valve than it is for the intraannular balloon-expanded SAPIEN valve. Another thing that's very interesting about the self-expanding valve, if you compare against surgery and we go from a large annulus to a small annulus based on CT sizing, as you go to a smaller annulus, the surgical rate of patient prosthetic mismatch soars, but doesn't change in the self-expanding valve. And I think that's because of the way the valve is constructed and how it sits in there as basically a stentless valve. Now, if you have patient prosthetic mismatch, Blythe-Sliver has also showed us that you cannot reach maximum exercise capacity. So patient prosthetic mismatch affects your ability to get better. So let's talk about hemodynamics. If you remember from the PARTNER 3 low-risk trial, this is the first time that surgery actually won hemodynamics, having better hemodynamics than the SAPIEN 3 valve at 1 year. If you go to the Evolut low-risk trial, the Evolut valve had superior hemodynamics compared to surgery at every time point tested, same way it's been in every randomized trial. Now, this is Becky Hahn's work. Becky published this in JACC Cardiovascular Imaging, and what Becky did was take the core lab echo data from the PARTNER trials and the CoreValve Evolut trials and use that to show that the mean EOA for SAPIEN 3 was 1.66 and the mean EOA for an Evolut was 2.01. We'll talk a little bit about why these particular numbers might be important. She also created these charts. We don't use SAPIEN or SAPIEN XT anymore. We use SAPIEN 3. If you notice, the EOA goes up as you go to bigger valves, starting at 1.22 for a 20 SAPIEN 3. That's really moderate to start with, even at a nominally expanded valve. I don't ever use a 20 S3. And you know, the mean gradient starts at 16 for the 20 and it drops to finally single digits for the 29. But really, EOAs are hard to measure and gradients are dependent upon flow. But what isn't is Doppler velocity index, DVI, about 0.42 across the board. And we'll talk a minute about why that's important. Same thing for the core valve evolute. If you look at the evolute, the EOAs are bigger, the mean gradients are lower, but the Doppler velocity index is about 0.61. So why is that important? Well, Doppler velocity index comes from the continuity equation that says the flow below the valve equals the flow at the valve opening. And the flow below the valve is the LVOT area times the LVOT velocity times index, that echo envelope showing instantaneous gradients across systole. And that equals the aortic valve area times the aortic velocity times index. If we rearrange those and divide the LVOT VTI by the aortic VTI, which is the Doppler velocity index, that equals the aortic valve area divided by the LVOT. So this is flow independent because the ratio of flows, and it's size independent because big people have big LVOTs, little people have little LVOTs, and what it represents is the ratio of that individual patient's EOA to that individual patient's LVOT. So do you want an EOA that's 42% of your LVOT or 61%? Clearly, if that was your only determining factor, you would always choose 61%. Now, the other thing I often hear about the fact that SAPIEN has higher gradients is that, well, there's more pressure recovery with an S3 than there is with the evolute, so that makes a difference. So what is pressure recovery? Pressure recovery comes from the first law of thermodynamics, says energy can neither be created nor destroyed. The ventricle squeezes till there's more energy, more pressure in the ventricle than there is in the aorta. That's potential energy. As the blood has to accelerate through the aortic valve, that becomes kinetic energy, and so you have to take away potential energy as you change forms and your pressure goes down. Once it gets through the valve, it hits non-laminar flow or the sides of the aorta and small aortas, and that gives up kinetic energy, so you regain potential energy and the pressure comes back up. That's why in the lab, when you do instantaneous pressure gradients with a catheter, it's different than what you see on the echo the next day. And some people say, well, one's right and the other's wrong. No, they're both right. One estimates the pressure at the aortic area, at the orifice. One estimates the pressure in the descending and the aorta downstream. They're both correct. The question is does this rise in pressure actually help? And the answer is no. It's actually something that hurts. What the heart cares about is the amount of work it has to do to get the blood out of the heart and around the body. And work is force over distance, and force is mass times acceleration. I can calculate the work for each volume of blood to get through the aortic valve. Once it gets through the valve, that work has been expended. You do not get it back, no matter what happens to the pressure downstream. In fact, if the pressure goes up downstream, that just adds to afterload, and afterload is actually bad and creates more work on the heart. So more pressure recovery is just a marker of more stenosis to begin with. I always tell my cardiology colleagues that ask about this is if I give you a box that weighs 50 kilos and say carry this up 20 steps, I can calculate the work you did to get up those 20 steps. Now walk back 5 steps, get some height recovery. How much work did you get back? Absolutely none. So pressure recovery really is not a helpful thing to your heart. They're just two different pressures. Now this is some Gorlein's work from the 1950s when Gorlein was working out the flow across fixed orifice in the Gorlein formula. And what Gorlein did was look at aortic flow on the vertical axis versus mean gradient on the horizontal axis at fixed orifice areas, the blue lines. The red lines represent fixed cardiac work, as if your heart can't work any harder, which of course it can till you get to the upper levels, but this just shows you what happens if the heart's stuck. We go from normal flow at about 220 cc's a second to high flow about 550 cc's a second. What you can see if you pick the line for 1, an EOA of 1, it's about 40 at rest, but when you really exercise, it goes up to 140. Of course, that's why these people die when they have to increase cardiac output. It is not linear between 0.2, 0.4, 0.6, so it has to do with the square. And in fact, until you get to an EOA of about 2, you really can't increase your flow without increasing your gradient. Remember the mean OAs that Becky Hahn showed us, 1.66 for S3, 2.01 for evolute. You want to get to be 2 or above. Now, does it make a difference? Well, in CERTAVI, we did a 6-minute walk test before and at 1 month, at 1 year, and 2 years. And what we found is that by 1 month, TAVI, of course, did much better than surgery because the surgical people were still recovering. In fact, their 6-minute walk went down. But by 1 year, you would expect them to catch up. They don't. And by 2 years, TAVI's still superior. And it may well be that because the DVI, the average DVI of surgical valves in this trial was about 0.5 versus 0.61, that maybe they have better exercise tolerance. So how about durability? What do we know about durability? Well, when we talk about bioprosthetic dysfunction, there's really 4 buckets. This is David Capodanno's work. Structural, something wrong with the valve. Non-structural valve deterioration, something wrong around the valve. Thrombosis and endocarditis. Now, we have a number of trials where we have hemodynamics through 5 years, but then these were high and intermediate risk. High risk mean age was 84, intermediate was 81. That really doesn't help us. But we do have some randomized data. This is the partner 2. This is Philip Pibereau's work. looking at the partner 2A, which was a SAPIEN XT randomized against surgery. And what they showed us is that for the SAPIEN XT, there was actually statistically more moderate or greater valve dysfunction than there was in surgery. But then they looked at the non-randomized S3 and did a propensity matching and showed that the biologic valve failure for S3 was 2.6, and then for surgery it's 1.3, which is a p-value of 0.083, so not statistically significant. This was considered actually a win for TAVR. But if you read through the paper and go actually into the supplement, what you see, the last figure in the supplement, they did an inverse probability treatment weighting, which is a better way to account for the non-randomized comparison and a better statistical method. And at 4 and 5 years, S3 actually has statistically more failure than does surgery, which is somewhat worrisome. Now, this is from Dan O'Hare's work. I presented at this ACC, and what we did was we took the high and intermediate risk Evolut core valve trials, and we looked at the randomized surgery versus TAVR valve, which is over 2,000 patients, and looked for moderate or greater structural valve deterioration, defined as a mean increase of 10 millimeters or more and a final gradient of 20 or more from your discharge echo to your current echo, or new or worsening intraprosthetic AR to moderate or greater. And what we showed was that at 5 years, there was more moderate to greater structural valve deterioration in surgery than there was in TAVR. And in fact, if we looked at it as a small annulus, it widens even further, and it loses statistical significance as you go to a large annulus, but still trending in that direction. And in fact, most of these are due to stenosis, not regurgitation, both for moderate and severe. Does it make a difference? Well, we took the non-randomized arms of these, which got us to over 4,700 patients, and used that to look at clinical outcomes. And what we showed is whether you had TAVI or surgery, if you had moderate or greater structural valve deterioration, it doubled your risk of all-cause mortality. It doubled your risk of cardiovascular mortality. It doubled your risk of being rehospitalized for heart failure or aortic valve reintervention problems. So patient prosthetic mismatch and valve durability, both of these affect your mortality and your ability to recover from surgery. Now, there are certain things that go along with getting structural valve deterioration. If you're older or you're male, you have less, not a surprise. Valves deteriorate more slowly as you get older, and men have bigger annulus. The bigger valve you start with, the better you do. Percutaneous previous PCI or AFib, we don't know if that's due because these people are anticoagulated, or these are both markers for cardiac disease, and death is a bigger competing risk. And if we then look at the Notion 10-year data, what we see in the Notion 10-year data is that for moderate SVD, we numerically better for TAVR, but lost statistical significance at 0.3, but for severe, still statistically better for TAVR than it was for surgery. And if we look at then severe biologic valve dysfunction, overall valve dysfunction versus moderate, we see that surgery does worse than TAVR. And this is driven mainly by severe structural valve deterioration and severe patient prosthetic mismatch in the surgical arm. And if we look at mortality, all-cause mortality at 10 years, absolutely no difference. And if we look at the composite of all-cause mortality, MI or stroke, which is the primary endpoint of this trial, absolutely no difference for first-generation core valve versus surgery. This trial had a mean age of 79 and a mean STS of 2.9. Now, there's been a number of early surgical valve failures. The first paper I wrote on early trifecta failures was in 2017, one of the first papers about early failure of this valve. And the thing that's important about this is that this is not a class effect. Different valves, both surgical and TAVR, will fail at different rates because structural valve deterioration is based on valve design and tissue science, and each will be different. So are there clinical implications to this? Well, this is the Partner 3 trial out at 5 years. The primary endpoint was all-cause mortality, all stroke, or hospitalization. Statistically positive, very positive for TAVR in year 1, no longer positive in year 5 as these curves come together. How about mortality? Well, we actually see the curves cross, better for TAVR to begin with, better for surgery at the end. It's not reached statistical significance, but this is the same pattern we saw in Partner 2A, where TAVR started off better and ended up worse. And this trial will be followed for 10 years, and of course these curves follow this current trend. It may be worrisome at 10 years. And for all stroke, started off statistically positive for S3, now no longer positive. Not statistically negative, but no longer statistically superior for TAVR. And this may be because in Partner 3 there were 13 thrombosis episodes in the TAVR arm and 1 in surgery, whereas in the Evolut trial, which we'll see in a minute, there was a very low rate of clinical and subclinical thrombosis in both TAVR and surgery. So the Evolute 4 low-risk trial, our primary endpoint was all-cause mortality disabling stroke, and what we see is that at 4 years, it's 10.7% for TAVR, 14.1% for surgery, a delta of 3.4. This represents a 26% relative reduction in the hazard of death or disabling stroke for a p-value of 0.05. We all know TAVR has an early advantage for mortality, stroke, and recovery. The question has always been, will this advantage hold up? Now for the first time, we see the advantage not only holding up, but actually widening every year in favor of TAVR. And this is driven mainly by better all-cause mortality in the TAVR arm. We notice that the stroke arms are parallel, not coming together like in P3, but it's parallel again because it's very low clinical and subclinical thrombosis rate for both TAVR and surgery in this trial. And we see mortality better numerically in the TAVR arm. Does not reach statistical significance, 0.07, but this continues out until we get to the 10-year mark. It probably will be statistically significant in favor of TAVR versus surgery for this self-expanding valve. And if we look at all-cause mortality, disabling stroke, or hospitalization, statistically superior at 1 year for TAVR and statistically superior at 4 years, again, widening every year over 4 years. And we just recently saw the SMART trial presented by Dr. Howie Herman at ACC. SMART trial was to look at Evolute versus Sapien in a small annulus defined as an annulus less than 430 square millimeters on CT scan. We have about 355, 360 in each arm. We have a co-primary endpoint of all-cause mortality, disabling stroke, or heart failure embolization that was powered for non-inferiority with a margin of 8%. And the second one was bioprosthetic valve dysfunction, looking at hemodynamic structural valve dysfunction, non-structural valve dysfunction, clinical valve thrombosis, endocarditis, and aortic valve intervention, powered for superiority. Now, these being primary endpoints, both had to be met. And if we look at this, the endpoints actually cross over in favor of the Evolute valve about halfway through the trial. It does not reach statistical significance. This is mainly being driven by the better mortality in the Evolute versus the S3 valve. And if we look at the secondary endpoints, the hypothesis testing, since our co-primary endpoints were positive, what we see is for mean gradient, EOA, hemodynamic structural valve duration, biologic valve dysfunction in women, and moderate severe patient prosthetic mismatch, all superior for Evolute over S3 through this trial. And if we look at other instances, Doppler velocity index, remember we talked about Doppler velocity index, very important, 0.63 for Evolute, 0.44 for Sapien. Again, would you rather have an EOA that's 63% of your LVOT or 44%? If we look at severe patient prosthetic mismatch, much more common statistically in S3 than it is in the Evolute, not a surprise, we've seen the hemodynamics. If we look at total aortic regurgitation, actually statistically superior for the Evolute versus the S3 valve. So in conclusion, patient prosthetic mismatch, hemodynamics, and durability all influence your survival, all influence your recovery. The younger and more active your patient, the greater this importance. And patients with small annuli are at a greater risk of this, and we should think very carefully about which valves we use. Thank you for allowing me to talk again at Taipei Valves. I'm sorry I'm not there in person since I'm at New York Valves in New York. I wish you a great conference.
Okay. We thank Dr. Michael Reardon from Houston. And his topic, as I said, is cover the performance of self-expanding valve, especially supraannular valve. So the data seems to be really attractive, I would say. And would that affect our clinical practice? We will discuss that later. And the second topic will be presented by Dr. Andrei. Dr. Andrei is our good friend in the US. He's an interventional cardiologist, cover PCI and structural heart. He's very experienced operator and has many, I personally think he's a very thoughtful operator because he will consider all the procedures and structure things in advance before any procedure. And we have many good discussion during the past few years in many meetings. So I think he's on the balloon expandable side. Dr. Pop, would you start your lecture?
Yes, thank you so much for having me. I will share my screen. Thank you for the very kind introductions as well. So sharing the screen. Can you see my slides?
Not yet.
Not yet. Okay, give me 1 second. Share screen. There we go. Can you see them now?
No. Are there any technical problem?
Share. Okay, now you can see them?
Okay, we can see that. Please.
Okay, perfect. Okay, so thank you very much for having me. I truly appreciate the invitation to such a prestigious conference. So I was planning to talk just about patient prosthesis mismatch, but following Dr. Reardon's excellent talk, I will throw in a couple of words on durability as well. So this is the classic paper that Dr. Reardon also quoted. This is going back to the 70s, which is amazing. This is the original definition of patient prosthesis mismatch, which is amazingly contemporary. Really, we have made a lot of progress, but when you look what was said in the 70s, this is right on. It's also amazing to see that Dr. Rahimtullah was acknowledging the fact that some patients may have patient prosthesis mismatch at a dimension that others do not. For instance, if somebody is very old or not very active, patient prosthesis mismatch is different than in a younger, very active person. This is Dr. Becky Hahn's paper, which I think is absolutely essential. It shows you how to properly calculate an EOA. And I think one of the essential things to realize here is that the EOA calculation in vivo is determined very much by the LVOT area. And LVOT area is frequently underestimated on echo, and that's why sometimes we have to use CT to get a proper LVOT area. This is really required reading if you're thinking about patient prosthesis mismatch. This is a few of the things that we're going to talk about. And this diagram shows you that basically the geometric orifice area, which is the smallest area of a stenotic valve, is always larger than the effective orifice area, which is the area where you have the largest pressure drop. But it is also very different from the net pressure difference, which is affected by pressure recovery. So these are very important things to realize. It's very important to understand these concepts. So how do the invasive and echo gradients correlate? My good friend, Dr. Abbas, has published this paper in American Society of Echo, and he showed that echo and invasive gradients correlate well in native aortic stenosis. That's why we don't recommend crossing the valve if echo says there's severe aortic stenosis. And in degenerated structural valves, in transcatheter or surgical valves that are degenerated. However, there's a large discordance between invasive and echo gradients in TAVR valves in native annuli when the valves are functioning normally, and in valve-in-valve TAVR. And when you're comparing the different types of TAVR valves, the self-expanding valves have lower echo gradients, higher invasive gradients, and the balloon expandable valves are the other way around. This is the paper with a central illustration from Dr. Abbas, again, an excellent publication. This is Dr. Abbas's conclusion, which I think are words to live by. High residual echocardiographic mean gradient should be confirmed before you try to correct this. There's nothing wrong than trying to correct a valve that's actually functioning normally. And we're treating patients, we're not treating gradients. How do we assess patient prosthesis mismatch? This is the formula. There will be a quiz at the end, but basically the EOA is proportional to flow, inversely proportional to the square root of the pressure gradient. There are actually two ways of looking at patient prosthesis mismatch. Measured PPM, where you do the measurements in vivo, and this has been shown repeatedly to be highly sensitive to flow, highly sensitive to errors in the measurement of the LVOT area, which influences your stroke volume. You can correct for that by using CT measurements, but that's not routinely done. And then there's predicted PPM, which is basically what you have in Dr. Becky Hahn's paper and are the numbers that we use. This is not influenced by flow. Interestingly enough, surgical valves have used traditionally the predicted PPM, whereas the TAVR valves have used traditionally the measured PPM. And we will see why that is an issue. There is a clear relationship between flow and patient-prosthesis mismatch after balloon expandable valve. Again, this is Dr. Abbas, who has published a lot of the essential literature in this area. They looked at data for PARTNER 2A, and they showed that severe PPM is more common following SAVR than TAVR. And severe PPM only impacts mortality if you also have low flow and low ejection fraction. Severe PPM in normal flow is not associated with poor outcomes. This is the editorial, which is asking whether this PPM concept is basically an epiphenomenon of low flow. And the conclusion, I think, is a good one, which is use predicted PPM rather than measured PPM, predicted EOA rather than measured EOA, just like we do in surgical valves, and rely on CT to get a true LVOT area. This is an essential paper from Dr. Turnacle. This is really, I don't think there's many more papers that are more important than this, showing you what the different effects of measured versus predicted PPM. And it shows you that really predicted PPM wins the day. Predicted PPM is reclassifies the majority of the cases that are deemed abnormal on measured PPM. If you're looking in the same paper at all-cause mortality, heart failure admissions, cardiovascular mortality, there is no difference based on PPM. Interestingly enough, if you're using measured PPM versus predicted PPM is actually much more accurate at identifying a high pressure gradient across the valve. So that tells you that it's clinically more meaningful than the measured PPM, which is so sensitive to flow. This is from Dr. Pibarot's paper that he introduces this concept of pseudo-severe PPM, where basically in low flow conditions, this is why flow comes into the discussion, the valve leaflets don't open, just like in low flow aortic stenosis, the valves don't open. And he recommends that we use dobutamine stress echo when the flow is low to augment flow before we make a diagnosis of PPM, and potentially use CT to clarify the LVOT area. This is data again from Dr. Pibarot. He looked at the PARTNER trials, the core valve trials, the TVT registry, a large meta-analysis. And basically what he shows you is that for surgical valves, there is a link to mortality. Interestingly enough, for TAVR valves using SAPIEN, there is really no risk. With core valve, there is a risk. And that is a matter of how the measurements are obtained. And I think this is important data to remember looking at this very, very large data set. How about the dimensionless index? Dr. Reardon mentioned the dimensionless index, and it would make perfect sense that if we don't want to care about LVOT area measurements, which we know introduce a lot of error, we should look at the dimensionless index. Well, in this paper from Dr. Hahn's lab, looking at PARTNER trials, it shows you that death, stroke, or rehospitalization were not affected by the dimensionless index in TAVR population, but in the SAVR population, the dimensionless index was predictive. So this is, again, very important information. The dimensionless index is meaningful in the surgical population, not in the TAVR population using the SAPIEN platform. So what are the clinical implications of PPM? Severe PPM in surgical valves increases your mortality. Moderate PPM increases only perioperative mortality. These are the predictors of PPM in surgical valves: older age, female sex, hypertensive, diabetes, renal failure, large body habitus, all make sense. If you're looking at this paper from Okuno, comparing self-expanding with balloon expandable valves, again, this is measured PPM, which we've established that it's not really that accurate. And it looks like the balloon expandable valves have somewhat more PPM than the self-expanding valves. However, in this paper, again, neither moderate nor severe PPM significantly persisted mortality or New York Heart Association functional class. So this tells you that the measured ppm is not really that significant. This is a large paper originating in Texas that looked at a link between ppm and mortality and found no link. This is in 3,000 patients from a large hospital system in Texas. Another paper from Deharo looking from France TAVI, a large nationwide registry in France, and they found as predictors of ppm higher BMI, higher BSA, younger age, all the stuff that you'd expect, small annulus area, predictors of PVL, lower BMI, high BSA, use of a self-expanding valve, again, stuff that we know. At 6.5 years, moderate and severe ppm was not associated with an increased risk of mortality. Severe ppm was not associated with an increased risk of mortality, but PVL more than 2 was associated with increased risk of mortality. There's also this concept that I hear all the time, put the biggest valve in, that's what you really need for these patients. The problem with that is best exemplified if you look at a 23 trifecta. We see a lot of failed trifectas. A 23 trifecta has a 21 inner diameter. You can put a 20 sapien, which you can stretch. You can put a 23 sapien. You can put a 23 evolute. You can put a 26 evolute in there. The geometric orifice area for all of them is going to be about 20 millimeters because the ring of the trifecta does not expand. However, your risk plane is going to be considerably different depending on what you put in there. Therefore, we always put in 23 trifectas, we put 20 millimeter sapiens, overexpand them. It works great. It facilitates coronary access. So again, geometric orifice area is something that we have to think of, and EOA is always smaller than the GOA. When the SMART trial came out, I looked at my last 10 patients that fit the inclusion criteria in SMART, area less than 430, and I looked at valve to coronary distance and valve to aortic distance to see how repeatable the valves are that I'm putting in. As you can see, in the sapien population, one valve had a problem with the RCA, and the same valve had a problem with the left main, which wasn't a big deal, 3.1. Pretty much every single valve, if I had put in an evolute, would have had issues with repeatability. And the ability to repeat TAVR in a evolute is not going to be affected by DFX. Coronary access maybe. The notorious 20 millimeter valve that Dr. Reardon mentioned, this is data from 8,000 matched pairs from the TV3 registry from my friend Dr. Abbas. Basically, he looked at outcomes depending on whether you put in a 20 valve or a 23 or larger valve. No difference in death, or stroke. So it makes no difference the size of the valve that you put in. You put a valve in that the patient needs. The size of the patient is what dictates the valve size. This is data from Dr. Stenosis showing you that if you put a Resilia valve in, the gradient is actually slightly lower. Why is that? Because the leaflets are mounted differently. On the left, you have a traditional Ultra. On the right, you have a Sapien Ultra Resilia. The Resilia will have lower gradients. Durability, I wasn't planning to talk about this, but I'm going to say a couple of things. Gradients are not the same thing as durability. TAVR valves generally have lower gradients than surgical valves. Lower gradients for the surgical valves were Medtronic Freestyle, homografts, and the trifecta. This is what the marketing material was for trifecta. Hemodynamics matter, increased EOA, increased cardiac output, and my favorite, hemodynamics determine valve durability. We all know how well that went. Durability equals durability. Durability means valve has failed, we have to replace it. This is another great valve. Few people remember this one, the 3F valve, a Medtronic valve. This is what they were saying. They were saying basically, it has been postulated that improved hemodynamics will correlate with durability. It's probable that we don't see this valve anymore because it lasts forever and the patients live forever. But I think that the real relation between durability and gradients is not well established. So in conclusion, measured ppm is highly flow dependent and sensitive to LVOT mismeasurements. Measured and invasive gradients are often discordant after TAVR and after valve-in-valve TAVR. Predicted ppm should be used for both TAVR and SAVR assessment. The impact of even severe post-TAVR ppm on hard endpoints remains unclear. Small patients have small annuli, but also small roots. TAVR repeatability is essential as we treat younger and healthier patients. High gradients and ppm should be put in context clinically. High gradients must be confirmed, and structural valve deterioration must be distinguished from ppm. Significance of ppm after TAVR, multiple studies have shown no association between severe PPM with mortality in sapien valves, just a couple of the papers, and the conclusion is valid. Severe PPM is rare. We should focus on patient-oriented outcomes, mortality, heart failure, pacemaker placement, PV leak, rather than hemodynamics. None of my patients ever came to me and said, hey, doc, I have a high gradient. Thank you very much.
Okay, thank you. Well, it seems that both valves have their lovers, believers, and opponents. And how about you, Dr. Tse, at your hospital? We have Dr. Tse from Seoul National University, Bandung Hospital. He's a very experienced operator. So what's your comment on these two talks? And do you have any question for Dr. Andrei?
Yes, thank you for very nice presentation of both the cerebral expander and balloon expander valve. I think PPA is still is a major concern about the little clinical practice, but Dr. Pop, you said there's nothing worry about the PPM because of the recent balloon expandable, after following balloon expandable valve implantation, the PPM, severe PPM doesn't matter because there's a very low incidence of severe PPM after BBB. And the moderate and then mild PPM, it is not concerned. Do you think it's really nothing or worry about this? And then I'm asking about the gradient is not really matter of concern. What do you think about this? Your opinion, please explain about your opinion.
So I think the data on PPM is a little bit all over the place. We have good data that shows that in TAVR valves, PPM does not impact mortality. We don't have direct evidence that it does. We have association. We also have no evidence that it impacts durability, no credible evidence. And we have good data going out to 5 years in the randomized trials that shows no impact on durability. So even though the surgical valves have, the sapien valves have a slightly higher gradient, we don't see early failure. And that is very reassuring. Gradients, however, are annoying. When I'm in clinic and I have 15 minutes to see a patient and the patient has an increased gradient, I have to look myself at the stroke volume, I have to look at the dimensionless index, I have to look at the acceleration time, and it takes time. So gradients are annoying. But there's a big difference between being annoyed and outcomes. And I think that when we're looking at younger patients and we're putting valves in, we have to think about the fact that all valves fail, whether they're surgical, whether they're mechanical, whether they're biological, they all fail. And just like I don't ever put a stent across the touchdown of a graft, I always like to keep options open. So we recently treated a 43-year-old man who had had chest irradiation, had had Hodgkin's lymphoma, had had 3 or 4 different surgeries, including last time a mechanical valve, 13-hour surgery. They could not fix his moderate aortic stenosis, and several years later, he came back for us to fix his TAVR valve. I put a 20-millimeter sapien. I post-dilated it with a 20-millimeter balloon. At 1 month, he feels great. He has a gradient of 6, and I have plenty of room to put another valve in there and maybe another valve in the future. Had I put in a 26 Evolut, I would not have had that option. That is, to me, a big concern. And as was mentioned in the beginning, I always try to think about what the options are for my patients going forward. And am I worried? I'm worried about everything. I watch PPM literature, I watch gradients. I'm always worried for my patients. However, I'm a clinician and I try to deal with the things that I can control. And the things that I can control are clearly the ability to put another valve in the future and the facility to access the coronaries. And I think that's where, my patients can get in trouble. Because if I do something that commits a 78-year-old or 80-year-old to surgery for a valve explant, that is not a good thing.
Thank you. Okay, because the live is ready, will you please keep online, Dr. Pop? Later we may have other questions. So let's move to the CAS lab.
Okay.
Dr. Tsao and Dr. Lee, you are on the air. So please introduce the case and show us the procedure.
Okay, good morning, Professor Yin and all the experts. And today we are doing the case of TAVR. And before the procedure, the introduction of the case, I would like to introduce our team. And the one left to me is Dr. Kuo-Chen. He's a cardiosurgeon, experienced cardiosurgeon, and also one of our TAVR team's members. And this one is our chief cath lab technicians. She's also very experienced in doing the TAVR procedure, and nurse Jie Li. Okay. So Dr. Liu will present the case. Dr. Liu, please.
Good morning, doctors. I will be presenting this case. So this is a 71-year-old female who has had dyspnea on exertion for months. She was diagnosed with critical aortic stenosis and moderate regurgitation, with a medical history of progressive rheumatoid arthritis treated with tocilizumab. She also has insignificant CAD. Her STS score is 5.9% and case fragility score is 0 out of 6, low HCT level of 24% and creatinine of 0.69. She's a small Asian lady standing at 151 centimeters tall and weighing 55 kilograms. Next. Her cardiography revealed critical AS with pressure gradient 47/80 millimeter mercury and AVA of 0.7 centimeters square, normal LVEF. Next. Pre-procedure CT show annulus area of 375 millimeter square, diameter 21.9 millimeter, and perimeter 69.5 millimeter. And LVOT is of 22.8 millimeter. Sinus of Valsalva diameter is about 27 millimeter, and STJ diameter is about 24 millimeter. Next. The left main coronary artery height is about 12.3 millimeter above annulus, and RCA is 12.3 millimeter above annulus as well. When we simulated the right cusp leaflet is 2 millimeter thick. When we simulation a 26 millimeter Evolut FX transcatheter valve on the CT, the thickened leaflet might impact the VTC of right coronary artery, reducing it from 4 millimeter to 2 millimeter. This might take into consideration when we do the pre-procedure planning, but intraoperative angiography also be considered. Next. The membranous septum is 3 millimeter. We will use 3 cusp view and the non-coronary cusp isolated view during the procedure. Next. The femoral access is anatomically normal and sufficient for the TAVR procedure. Next. So this is our plan to do. We use right femoral artery as the main access for TAVR delivery sheath and left femoral vessel for temporary pacemaker. We might consider to do the coronary protection. We use the left femoral artery for pigtail catheter, and we use right radial artery for cerebral protection device. No pre-dilatation will be used, and the Medtronic Evolut FX 26 millimeter valve will be used, and the ideal implantation depth would be 4 to 6 millimeter. And that's all.
So this is a patient with a typical small annulus and not only annulus, but also a small artery root. So there is some concern regarding the coronaries. So Dr. Jie, will you choose balloon expandable in this scenario?
And this patient is very small and then small annuli, so I think the future pressure gradient is very important. So from the smart trial, I think the self-expander is good for this patient. And then the concern is about the coronary obstruction, but the SOV diameter is, I think, big enough to not to occlude the coronary ostium. So I think it's just a very, very typical type of case for using the self-expandable.
Okay, so your first priority is to consider the hemodynamics. Also for this patient, her coronary is okay. So maybe in the future there would not be a big issue. So Dr. Lee, would you comment on this case?
For the case, I think we simulation the SEPIN also because of thickness of the valve tissue. And if we over dilate the SEPIN, maybe that's a risk parent for the SEPIN is more than the CoValve because you know the CoValve has the waste. Sometimes it has some protective issue.
Okay. Dr. Tsao, what's your consideration in this patient with small anatomies?
Yeah, the patient has some interesting point. The first one is this is a small lady, 150 centimeter, and the other thing is the possibility of a coronary obstruction, and besides that, the patient has the aortic valve is very low calcification. So considering of these factors, I think we tend to choose the self-expanding valve because the smaller aortic root and less aortic valve calcification. And for the issue of coronary obstruction, because the VTC is above 4 millimeters, even the leaflet thickening is 2 millimeters, then we tend not to use the coronary protection. We can probably just put the 26 millimeter valve territory. Yeah.
So I think the lack of calcification is also a consideration in this particular case because you need a little bit more oversizing. I think 26 is a good option. And the other thing is that how do you determine the implantation depth? This patient have a membrane septal length of 3 millimeter, and you want to put the valve in at 4 to 6 below the annulus. Would that cause a conduction disturbance issue?
This is also very challenging because the calcification is very low, and if you put the valve too high, the possibility of valve embolization is increased. Therefore, I think we decide to implant the depth as our usual way. We aim to 3 millimeter depth of implantation, because this is Evolut FX. This is the newest generation of the CoValve. There are 3 radio opaque gold markers on the distal end stent frame. So the gold markers to the end, the edge is about 3 millimeters. So I think we probably aim for 3 millimeter implantation, but this is a little bit challenging because of less calcification. So we would adjust the implantation. Maybe it won't be exactly 3 millimeter. We will try our best to aim for 3 millimeters. Yeah.
Yes, I totally agree with you. Because of there's a little calcium, so that means there is a higher chance of a pop up of the self-expandable valve. the first. And second, the coronary height is a little bit high, but the relatively high, but the valvular thickening is a high risk. So I think the deep implantation more than 3 is a good option for this patient.
So your style is cost overview.
Yeah, cost overlap, yeah. Okay, so this we routinely put the Sentinel protection device. So before this procedure, we have done that, and
So I think that do you always think about when you have a risk plan of the coronary, do you implant deeper or just as high as possible because of a commission alignment?
140好了。
Depends on the patient because the coronary arterial obstruction is not just a height matter. So there are a lot of things to predict coronary obstruction. So in this patient, I think the little bit deeper implantation is good. Yeah.
Patient area. So what do you think, Professor Yin? How about the depth?
To me, I think it's too high.
Too high. Okay. But from this, we make a picture.
Please align the button.
Okay.
Yeah. Don't you think so?
It should be 2 millimeters deeper. Yeah.
Oh,
no,
it's too high.
Almost 0.
Maybe I just push. Let me just try to push a little bit.
You think there's no calcium, so you can push downward?
Yeah. Gently. Okay, so we retrieve the part. It's very hard to push.
I still think it's too high.
Yeah. I think the aortic is not completed into the aneurysm.
Yeah. When you see there is some bullet shape of the distal portion, that will pop out easy. Okay, I think that's much better.
Okay. Okay, 照相。So what do you think, this depth?
Yeah, I can accept that.
Yeah, could you decrease the screen, the size of the screen, because I think some tension in the distal curvature. Yeah, so that's I think the finally should be at the 4 or 5.
Yeah, 4 or 5.
Yeah, so probably we deploy this position, okay?
So please show us the LAO projection.
This is the area.
This is LAO?
Yeah.
This is the area, yeah, a little bit caudal, yeah.
So release the wire tension.
Please release the tension. Release the tension, please.
Okay.
Why?
Wire tension.
Or pull back.
Pull back wire.
Yeah. Okay. Okay. So with golden marker, I pull off the PTL caster during the implantation.
Sure.
Okay.
Okay.
好，我们这先出来哈，那中间出来。二留着。Okay. Can you show us the T finding?
Okay.
The ECG, the ECG pattern still narrow QRS.
Yeah.
So I think the conduction
no newly developed LBBB or something.
Yes.
No paralytics. Really good.
Do you show the coronary flow? The VTC from echo?
Okay. Okay.
How
Can you
do
see
you
this is the short axis view where it evaluates about the VTC of the right coronary cusp. Because of the a shadow of the transcatheter valve is not so clear, but you can see in my a little bit coronary artery flow showing here and left coronary flow here. The VTC is about
2.
Yeah, it should be 2. Yeah. The
be
left is more. Yeah.
yes, the VTC of the left coronary about 3 and the right yes, it's properly 2 to 3 millimeter.
What's the leaflet length of this patient?
Leaflet length. It should be 13. It's
shorter than.
It's just about the same.
The coronary high, shorter than coronary high. Yeah.
Shorter. I think you told us the left coronary high is 12, and you implant the valve at about 4, so that should be safe.
Yeah. Yeah. The outer skirt is 13 millimeters.
Yeah, in our center, we usually aim to keep the inner skirt high below the coronary orifice, the lower margin of the coronary orifice.
Could you show the coronary, the alignment of the valve here?
From LAL view, or from the echo, show axis. Can you show the alignment of the commissure?
Of course, wait a minute.
So do you mind if I ask a question?
Yes, sure, please.
So let's say the patient is 71. Let's say this valve fails in 10 years from now or 15 years from now. What sort of valve are we going to put in there to fix this? Because your valve to coronary distance right now is 2 to 3 millimeters. You have a 26 millimeter evolute that you could put a 26 millimeter in, and then you're occluding the coronaries for sure. Or you could put a 23 millimeter Sapien in there, and that will expand the waist of the valve from 22 to 23 millimeters, which will result in valve to coronary distance of about 1 millimeter on each side. Should we be worried about that or not?
So for the second valve, Dr. Lee, will you choose a balloon expandable one?
The second valve is already this one because it should be the Sapien inside because of the near skirt problem. And now we try more and more deep data modification in previous degeneration THV valve. And because the commission alignment is quite important. After deep data modification and if you dilate the cobalt stent, still have some room for the VTC. However, if you did not do the deep modification, sometimes it got very dangerous for the neosinus sequestration at this moment. So that's we try more and more deep data modification with the Basilica method.
So, Dr. Pop, do you routinely do leaflet modification in patients with small anatomy or high risk of coronary access in the Redo TAVR? Yeah.
My center did the first leaflet modification in the state in Illinois. We do it only on patients who are high risk for surgery because we think that the technology is not mature enough at this point. There is always a risk with leaflet modification, especially if you're doing balloon expandable valve inside a self-expanding valve. At this point with the current technology, you're actually not quite sure that one of the commissures of the balloon expandable will not land in front of the newly created cut of leaflet modification. So as much as I think leaflet modification may be in the future, I don't think that we can fully rely on it right now, and I don't like to rely on hope for the care of my patients, that hope it will work in the future. The other thing to remember is on a 26 valve, the angle of risk around the commissures of the evolute, I think, is 32 degrees for each commissure. So unless the valve is perfectly aligned, you may not be able to do leaflet modification. Also, leaflet modification is not going to help you through the outer skirt of the evolute. So it's a good technology in the right patient, but I think the cases where you can successfully do it are not a lot. And I also think that the centers that do it well are very few, even in the US, where I think we see a lot of failed valves.
And how about this case? Dr. Liu, can you show us the commissure alignment?
Of course. You can see on the screen, our commissure alignment angle is about 50 degree. It's perfectly aligned.
Okay. So maybe in the future, he need a leaflet modification. How about the data of shortcut? Dr. Pop, do you have any comment on the shortcut device? Because this year's EuroPCR, they show that shortcut has a 100% success rate.
Well, the next time I see a technology that's 100% successful, I'll invest in it. I think all technology is doomed to failure at some point. So I think I haven't had my hands on the shortcut yet. It's not yet approved in the US. I'm excited about Telltale. I'm excited about shortcut. We'll have to see how it works. We'll have to see it clinically, and we'll rely on it when we see how reliable it is.
Yes, you have mentioned a very important point about the commissure alignment, because if the commissure is misaligned, there's no way even leaflet modification was done. Okay, thank you.
Okay, so we check the pressure gradient. The grade, there's only two. So I think the result is quite good. Then we will pull out the LV catheter, PTL catheter, and do the aortic root angiogram to see the perfusion of the coronary arteries and the degree of AR. If
Okay.
there.
Thank you. Congratulations for your excellent case, Dr. Tsao.
Okay, thank you. We just shoot the angiogram.
Okay, let's move to Shanghai.
So can see the coronaries are well patent. I think there's no issue of coronary obstruction. Yeah.
什么东西开开了？好
Okay.
，Hello，慢，好，好，
开了，他们没转过来。
刚才响了，刚才叶院长说是转到上海。
对，但是他没切。
哎，切过来喽，文字。
哎，
好，
是
院长，
周教授吧？周教授。
啊，对，文字在跟你说话。叶院长好，我在操作这个。
好，OK。
那个
You are on the air, Dr. Pan. Yeah, we have Dr. Che from Korea and all the distinguished guests, overseas guests from South Asia.
Good morning. This is from Dongsan Hospital, Fudan University. We will give a live case about the TAVR and plus PVMA. Let's introduce the case.
要来车这个
放大啊。
那个我先给您。
This 73 male. He has exhaustion complex for blessed for 4 years and diagnosis aortic stenosis and mitral stenosis. So today we will do TAVR and PVMA for this patient. Next. 下一张。 And the echo shows this patient have severe aortic stenosis and moderate to severe aortic regurgitation. And the aortic all rise area is 0.9, and he has severe mitral stenosis with the mitral valve area 0.9 centimeters. And the LEF is this the ECG for the patient. He has the atrial fibrillation. And then he has the sinus rhythm. This is the CT scan. You can see this rheumatic heart disease. So the aortic lead is thickening. The thickening is big, and the lead disc is long for the rheumatic aortic lead disc. This the annulus perimeter annulus is 75, and aortic perimeter is 72 millimeter, and is the tricuspid lead disc. 下一张。And the coronary height is high, so no risk for coronary obstruction. Next. The aorta is no enlarged. Next. Then the cuts over left view and the lung cuts low view was calculated. Next. Okay, and the access is acceptable for this patient. Next. So this is the patient summary. He has perimeter 24 and LVLT 23 millimeter, and we calculate the release degree CAU and IO, and use the right femoral artery as the access road, and use the 20 millimeter for the pre-dilation, and select 29 epidural floor, and also we did do PUME for this patient. And Professor Tsao has do the mitral balloon for this patient just now. Let's change to the DSA screen. Okay, this is the case information. Now, Professor Tsao is to balloon dilation for the mitral valve for this patient. Just use the 刚才是多少了？20的是吧？20啊，来测。现在24是吧？对，现在25。答案1、2、3，测。李老师。
Okay, you are doing PTMC, yeah.
Yeah.
哦，26。27。好。
Yeah, we today was dilation for this patient just from 22 to 24. Now we use 26 balloons for dilation.
26多点没事啊，行。好，扩1、2、3，测。好，不扩了。让李老师测测放口面积啊。
压差下来了嘛？
压差哪看出来？没测量。
测这个嘛，测这个左房压力。
左房压。
对，左房压术前平均压是21。
哎呀，刚才是主动脉没扩之前测量的。
Now we measure the left atrial pressure. The atrial pressure is 21 for the mean pressure.
抽有细哎。
对，是因为前面顶壁了。
Seems that the liquid commission have been split.
Yeah.
哦，李老师啊，放流专门增加，半口面积。啊，院长好。
好。
我们现在刚刚把那个，因为这个病人呢，刚刚文字也跟大家汇报了，是风湿性心脏病人，阿基曼狭窄，有左动脉狭窄，左动脉呢，这半口面积是0.56， 那么阿健曼呢是1.2，这是半口面积。这是我们到底是先放主动脉，还是先做阿健曼球囊扩张，还是怎么个顺序去做这样的病人？我们希望大家能够讨论一下。
Okay, the patient have both mitral and aortic stenosis. I mean, in this scenario, will you do the downstream valve first or the upstream? In some patient, if you do the mitral first, that might cause acute pulmonary edema after that because the volume to the LV suddenly increase. And so some experts recommend to do TAVR first. You open up the downstream flow and then you do the mitral. That will be much safer. How do you think?
Yes, I think the TAVR-first is the best option for both valvular heart disease because if after the TAVR procedure, if the LVEDP comes down to the normal pressure, I will re-evaluate the mitral stenosis degree and then so whether to treat the mitral disease at the same time.
Another issue is about when you use the self-expanding valve, the implanter always worry about when you do the self-expanding first and then PTMV, and sometimes it causes a balloon that the valve still pop out. It's a risk, or I think that sometimes it's okay for that moment because the angle for the LVOT and the mitral angle is somehow different. However, the people always worry about the inflate balloon push out the new self-expanding valve. I think that's the actually is really concern for this kind of procedure. We don't know that China have more experience about rheumatic heart, so that's how about the Zhongshan's idea about the procedure. So very critical point you pointed out. So if we implant the aortic valve without touching the aortoventricular junction, so it will not. I think it's safe to do the mitral valvular procedure after TAVR. Yeah.
是周教授，我们刚刚在讨论说，两个可能啦，一个就是如果主动脉瓣先放，可能怕在做二尖瓣的时候会影响到它的位置，造成位移。那但是另外一个考量就是说，如果你主动脉瓣后做的话，你把二尖瓣打开，进到左室的血流大量增加的时候，会不会造成急性的肺水肿？听听你们的经验。
我们呢是这样想的，这个如果说先做主动脉瓣，就是这个会导致呢这个二尖瓣二尖瓣呢万一扩张的时候出现大量反流，如果是需要外科干预的话，就相当于画蛇添足了。那如果说先做二尖瓣一下子这血流冲到主心室了，主心室没有得到训练，主动脉瓣口呢又狭窄，那么可能会呈现循环崩溃这种情况。所以呢，我们呢考虑呢，在做之前用小的球囊把主动脉先扩开来。我的经验是18毫米以下的球囊很少会引起主动脉严重的反流的这种现象。所以这个病人呢，首先我是用18毫米的这个球囊呢，把这个主动脉口呢扩了一下，使他的压差呢下降了。那么这个病人呢，现在这个主动脉呢有反流，他的反流是跟术前没扩张时候是差不多的，压差呢主动脉上瓣下的压差大概在20个毫米汞柱，这样子呢，在这个循环方面呢就比较稳定。在这种情况下，我再去扩这个二尖瓣，二尖瓣扩了以后，如果没有明显增加的反流，瓣口面积瓣口也扩开来了，那么这样子呢，我再去做主动脉。那么刚刚呢，二尖瓣扩了，我从20、22、25、26扩了4次，就是说 step by step 逐渐扩张，扩好了以后呢， 这个跨阿基曼的压力呢，这有4的吧，李老师对吧？这有3毫米汞柱，从6跨阿基曼的压差从6下降到3个毫米汞柱。那么阿基曼的半孔面积呢，从1.2到了2.38已经扩到2.38这么一个半孔面积。同时呢，阿基曼的反流没有明显的增加。所以下面呢我就准备呢我们的按照顺序，我们就按照这种顺序去做这样的病人。所以呢下面呢，然后阿基曼也好，主动再去放这个做主动脉。我们的顺序是思考。我想大家有没有其他的一些讨论？
是，这是一个很聪明的做法。Professor Tsao used a balloon dilatation of the aortic valve with a 18mm balloon to predilate the valve to stabilize the patient. In case of blood flow from LA to LV increase suddenly, they won't cause any diaster during that condition. So I think it's a very safe way to practice in that particular case. And then he did the PTMC, which is a very successful procedure. The mitral valve orifice was opened up from 1.2 to 2.1 millimeter square, and the pressure gradient was reduced from 20 to 5. Yeah. Okay, now Professor Tsao is putting the stiff wire in the LV for TAVR. 周教授，请问您的瓣膜是选多大的瓣？
我选择呢29的美登利的那个瓣膜啊。
因为瓣叶很厚，为什么你没有考虑26的？
扩张过来。
它现在看起来瓣叶厚，但是那个交界都有点裂开了。
哦，是，
容裂开，
因为前扩的关系。
所以如果裂不开的那种，可能是要小一点。它已经看起来都裂得很开了。那个看瓣上的那个，你看那个超声的图能看到吧？
有看到了。Will you do? I mean, if this case have no mitral stenosis, will you routinely do predilatation for rheumatic aortic stenosis?
Yes. Most cases we do the predilation for the rheumatic aortic stenosis.
So predilatation may use a bigger valve afterward.
Yeah. But we also frequently commonly use the small balloon like 18 and 20. So also sometimes if the leaflet is tiny, we also use a small valve.
Yeah, rheumatic aortic stenosis, you know, the inner surface of the valve leaflet is a bit, I would say, slippery. So it tend to popping out or migration during deployment. So I think using a smaller balloon for predilatation might be a very good practice. Do we have many rheumatic in Korea?
We don't have a lot rheumatic disease. Mainly it's atherosclerotic, and the disease is mainly in Korea. So a little rheumatic diseases in Korea. So I don't have a lot of experience about the rheumatic aortic valve disease. But I'm reasonably, I think predilation is very mandatory for, you mean this, it's a very slippery of the rheumatic valve disease. So I agree with you. Thank you for your comment.
We also have done several cases of rheumatic AAS with the using of balloon expandable valve. It can still fit very well because the metal just impinge on the fibrotic tissue, and the result was also really good. Dr. Lee, do you want to comment?
Yeah, our strategy is do not dilate first, because
it depends on the classification.
Because it's every time when you pre-dilate, you must use a larger valve.
Larger valve.
And sometimes because you break all link, sometimes the valve got easy slippery, so that it's got very difficult when implant such as the valve. So for this is a wonderful case for the bottom-eye case and the pre-dilate, and you need to do a larger valve.
妈妈别急。
妈妈开始放啊，要放了。
你看这里再快一点。
很好。
就不停。
好。
可能
再放一点点。好。
记录了吗？
下面打齐。
记录好了。
下面没打齐。
赵颖。
觉得。
我觉得可以。
Yeah, if you lay over a little.
我觉得可以啊。
可以的。
我觉得可以。
他们觉得 think about。
他就觉得说。
Do you think this position is okay?
It is wonderful in the bundle.
Wonderful. Okay.
我因为上面没有捂起来，对吧？
那个
知道
周教授那个 wire tension 太大了。
那个导师可能要抽回来一点。
不，导师不用抽，一抽的瓣膜的位置会改变。可以，来，我们释放。
你要再照个眼。
再照个眼，好像啊。
你看看。
准备照眼。
没变嘛？
还可以。
还可以。
可以。好。
这个也，你看那边有内窝，也基本上有点无关都。
还可以。
点的感觉。
导师稍微抽一点。1.5
一点。
OK 好。
推一点。
稍微对面怎么样？
对。
来，给我看看刚刚的照影呢，给我回放一下。
对面深度有的呀。
有的，好的，可以。
可能推一点放。
不能太推，不能推，推了就有点窝了，会窝起来的。
推一点。
不能太推窝起来很厉害。好，这样就非常好。非常好。
OK。
好，来，车那个。
好，我来车啊。
好。
慢一点。
没事。好，走。
Okay. The result seems to be excellent. I would say. Maybe just 3 millimeter in depth.
Yeah.
来，帮我顶着下。
来，顶导师，来，顶导师。好，
准备抽了
啊。
OK 好。
Lung cusp.
来，把这个
剪掉。
把它剪掉，把那个片剪掉。
Opposite to zero. 待会我们再看一下。
好，我走了这是。
好。
中间哈。好。我撤了。
好。
How about the T finding? Could you show us?
Okay. 把那个食道放通大图，
有上来了。
好，
那个，那我来动一下。是。
I think the position and
当心导师。
flow is
当心导师。
very good.
I think the results is really good.
缝一下，把这个缝一下，进住尾巴，缝一下，先把这个鞘缝一下，把
Only
鞘固定下来。
paralytics.
我来。
我们准备再照个影。
好。
放一下，然后放下猪尾巴，再照个影。We will do the final angiograph.
Okay, thank you.
我现在把这个鞘再固定一下，大鞘，因为这个病人呢，他那个股动脉很细，股动脉很细呢，我们就没用鞘，就是用本身那个内连鞘，就是内连鞘，然后现在换了内连鞘以后呢，把鞘再固定下来。好 ，OK，
撤了啊，
好，这。我这个压力，轴心室的压力。好，谢谢。
挡到那个，好，无冠豆的那个体位。
无冠豆体位，无冠豆体位。
无冠豆最低点体位，就这右前斜加足，然后
对，右前斜加足，对。
那个，
对，
那老师拔掉。那倒没用了。
拔掉就拔掉，好，
拔掉不要，不像这样好看一点。
对。
拔掉吧。
15、20啊，可以。
要不要用左前斜看一下？
我们先做一个体位看一下，然后再
来。
哦，
慢点。好。哎。
好，
我打平，把那个底下打平，打平了吗？
平了
啊。
左前斜，您是要看什么啦？
左前斜主要是看左边的左冠了，还有就是深度，
这人左冠的高度是151，
都
很大。
对。
先照一下，
准备好了吗？
啊，好。
赵爷。
Very good，
很好。
没有反流
啊。
Almost no。
非常好的做。这个病人的冠脉的高度是15，左冠的高度是15，右冠高度21。
没问题。
他这个头是切线位是主心线22加头5，给他抓个抓个。主心22加头5。
Also the commission alignment is good from cross section of the T。
对 ，yes
啊。
commission alignment，
再往上换个。
准备好了吗？
廖老师，你抽一点点，他
现在是接近 NCP。
往前面走一走啊。哦，这个不行，这个位置在瓣膜外面。
挺大的。
挺大，都大。动作那么快。
等下还能转播还没结束。
好吧，就这里吧。
要在左前先照一次还是怎么？
左前先照一下。
好。
对。
左冠角
左冠角度嘛，左冠角度。
是左冠体。
好。
左冠角度。左冠切线位嘛。哎呀，这个好像。
真的。
给我弄个导师吧。导师放点位置。
就这样可以。
这样可以了，这样可以了。
对，刚好把那个松土也看了一下。
好，来往下拉一下。
好。
同时我们把松土动脉的情况弓的情况也看。
准备好了吗？
好。
打。
OK，really good。
对，就整个都
非常好，非常好。
那么下面我们就开始处理这个入路的问题。入路。
OK。
入路。
压力都记完了吗？
压力，这个压力。
我们再测个。
那个桡动脉压力。
桡动脉90，稍等，稳定一下吧。
92、51嘛。现在压力。
120 over
3。
林教授，就是现在台湾那边这种风湿病的病人还有吧？
有了，不多了。
不多了啊。
不过像你们这样，大陆可能比较多，所以你们经验比我们还要好。
我们这种 PBMV 一年还能做100多例，100-200例，还很常见。
我们大概2年做1例。
我们每个礼拜都会做个几例。
对啊。
大概在大陆上能够每年超过60例的中心也不多，中心比以前还是少了不少。
是。
那很多医院也都不开展了，所以都集中到个别医院了，很多人也都不会做了，所以就基本上都集中到少数的几个大医院。
大概上海就是我们中心
是
在做其他中心做的也
还是下降还是少了。
为了病人好，当然集中是对的。
那个达新教授，刚刚我们在讨论 这个小瓣膜跟大瓣膜的差别，你在这个 borderline case 的时候，你的选择都是选大瓣膜，还是说根据病人的体型去选，还是选说自棚瓣为主这样子？
我大陆呢，这个钙化的病人比较多，胸囊扩张瓣膜呢容易导致这个钙化的斑块，瓣环的撕裂，所以呢，我选择呢自膨胀的瓣膜会多一点。那么一般呢，我会根据主动脉根部的能够容纳多大的瓣膜，然后呢选瓣膜，不完全根据瓣环来选。因为如果像比如像这种风湿的病人，如果有的病人他那个瓣叶非常非常肥厚，那主动脉根部它没有体积没有容积能容纳比较大的瓣膜，那么我们只能选小的瓣膜。像这个病人呢，这个肥厚不是非常的严重，同时呢，它这个瓣环呢是75呢相当于24，那上面的瓣环上就是瓣环开口的面积那个部位呢，能够如果打开的话呢，这个病人呢能够达到21点几，21点几。如果26美德利的瓣膜，26呢，它瓣口的面积最狭窄部分是22，那么29的瓣膜呢，它瓣口面积是23，所以呢，这个病人呢，我就选择了29的瓣膜。所以我选择瓣膜是不完全根据瓣环，而是根据呢瓣上的结构、瓣膜本身的肥厚的情况，以及钙化的情况，以及呢预测这个瓣膜呢打开了以后能够达到什么样的情况来选择这个瓣膜。
因为风湿病人年纪都比较轻了，你有没有考虑说2次 TAVR 的时候的一些冠脉的影响啊，或者是 risk plan 会比较高啊，这些问题？
对的，会考虑这些。像这个病人，所以呢，我就选择了美德利的瓣膜。美德利的瓣膜呢，它是个收腰状的瓣膜，它呢有大网孔的，它把就是特别是commercial alignment 把这个冠脉呢，它就会让开来了，这样子为日后呢再做一次瓣膜，或者是冠脉介入呢留下了一条路。那么大陆的瓣膜呢，做这些风险的病人呢，可能这种的瓣膜呢，有可能特别是像那个微创的瓣膜，有可能呢更加稳定，更加稳定。但是呢，这个病人呢，因为年纪不是非常大，所以呢，美德利瓣膜也有它的优势，一个是 commercial alignment， 第二个呢，它这个柔韧性比较好，同时这个病人呢，他股动脉比较细，他对这个股动脉的要求呢会低一点，所以我们这个病人没有放股动脉的鞘，是直接用瓣膜的输送系统直接进去，因为他瓣膜本身有内连鞘，所以我们就选择了美德利的这个瓣膜，对他这个病人是最合适。
好，非常谢谢，非常谢谢。周达新教授跟潘文志教授为我们演示了一个非常成功的风湿的病例，而且是2个瓣膜在一站式的解决，谢谢，非常成功，恭喜恭喜！
非常感谢叶院长，还有我们在台上的在座的各位专家的指导啊，谢谢各位，谢谢各位，
谢谢，
好，谢谢
Congratulations, a very successful rheumatic case with both aortic stenosis and mitral stenosis have been successfully performed in a one-session operation with transcatheter approach. Thank you very much.
Thank you very much.
Thank you.
Okay, let's move to the next talk by Dr. Parma from Poland. Dr. Parma, are you online? Oh, thank you very much. Please, your microphone is mute. Please turn on your microphone.
Probably you can hear me now.
Yes, Dr. Parma is also a very famous expert in the TAVR, and he's also faculty of the Tokyo Valve, I think, also in many European meetings. Today he's gonna talk about long-term durability of transcatheter heart valve. Please.
I welcome you from Europe. It's it's a 3:45 here, but I really value your invitation and really support your conference. I would like to share actually the focus of the research we are doing on, I hope you can see it, the slides currently, the research on the durability of transcatheter heart valves as we also progress into Redo TAVI trials. Can you tell me that you see the slides?
Just appear now. Okay, thank you. We can see it.
Yes, good. So I will just, so this is the first slide, and we are focusing on the generation of transcatheter heart valves, as throughout the world, the focus is to treat the larger proportion of patients, and also a lot of discussions on whether we have sufficient data to treat younger population, which is expected to live longer even for as 10 years ahead, because as TAVI was introduced almost 20 years ago, we still have limited data on the durability. What we know is that based on the experience from surgical valves, we know that all bioprosthetic valves are going to degenerate and undergoing either leaflet calcification with the stenosis, or going towards regurgitation. And there is no class effect. We see different valves, surgical valves or transcatheter valves, undergoing different kinds of degenerations. So also learning from surgical experience is that we know that this degeneration may be either affected from the factors coming from the device or patient focused factors. So from patients, from surgical perspective, these are younger patients with hypertension, especially with renal insufficiency. We know it from patients being dialyzed, also from patients with diabetes and with dyslipidemia. Currently, there is an interest in LPA being a factor from earlier degeneration of TAVR and surgical prosthesis. For the device-related factors, we know that the crimping of the valve under an overexpansion leading to leaflet pinwheeling, and also implantation into smaller annuli, especially leading towards under-expansion of the valves, may be the factors which precipitate the earlier degeneration of the prosthesis, including Redo TAVI, which I will point to later on in my topic. This is the surgical experience we have coming from previous 20 years, which says that we can expect some device design to be more prone to degeneration. And this is why we should also focus on specific valves to know which kind of degeneration they undergo, whether it is earlier stenosis with calcification or earlier regurgitation. And I can tell you from the ReTAVI registry, what we observe is, for example, that the accurate transcatheter valves usually goes towards regurgitation, while Evolut R or Sapien are much more prone to stenosis. As you can see also that the evidence from the Hancock and the Edwards registries is that the usual durability of this surgical prosthesis is about 10 years. And after that, especially in young patients, these valves are degenerating. And as we progress to TAVI devices, from VARC3 definitions, it is established that the deterioration of the valve is divided between the structural valve deterioration, meaning the degeneration of the leaflets, and also of the stent of the strut fracture. The non-structural valve dysfunction is all the dysfunction of the prosthesis which is outside of the frame and the leaflets, usually defined by the paravalvular leak or patient-prosthesis mismatch, and sometimes also by some tissue ingrowth, which is a pannus and entrapment of the leaflets from the tissues outside of the device itself. And on the right, you can see that there is a specific clinical detection of the thrombosis, either subclinical or clinically significant, and endocarditis, which is useful for the observation of all these devices. So then we observe, according to VAC3, the hemodynamic changes, for the detection whether there is a hemodynamic deterioration of the patients, and also whether there are clinical consequences and sequelae, including stroke, peripheral emboli, which is which we see in patients with clinical thrombosis of the TAVI devices, and sometimes the thrombosis of the device leading to patient death. As we focus now on the degeneration of the devices, we know that if we do the CT follow-up, we can see the degeneration of the leaflets, subclinical thrombosis of the leaflets in a large proportion of patients. In Europe, we cannot do like a regular approach to the CT follow-up because of the radiation exposure of these patients. But in anybody with symptoms of or suggestive of valve dysfunction, and also with patients with increasing transvalvular gradients, we do the follow-up, and we see these hyperattenuations in patients, especially with underdilatation, underexpansion of the prosthesis, importantly in bicuspid aortic valves, which is problematic for patients at a young age with aortic stenosis because most of them have bicuspid valves. And also from my Chinese experience, unfortunately, I haven't been to Taiwan before, but I would love to. But what I know is that the patients are being operated at a much younger age, and a lot of them have bicuspid aortic valves. So meaning that we should optimize the TAVI outcome in these patients, otherwise they can experience the health. And also what we see from our patients in Europe, they quite often have stroke or peripheral emboli in these situations. So these are examples of patients which we observe in our department in Katowice in Poland with a thrombosis of the leaflets, either in evolute R or also with underexpanded sapien prosthesis in bicuspid aortic valves. So going towards the bench test prediction of the durability of TAVR devices, you can see a very beautiful paper which was published 3 years ago by Janar in JACC Interventions on sapien, which says that with the equivalence of 25 years, these devices should be durable. However, the bench test does not take into consideration any inflammatory response from the body, especially in patients with diabetes, chronic kidney disease, or with dyslipidemia. So in theory, these designs are tested to be durable to up to 25 years with good predicted outcome. However, these are probably the patient factors which limit the durability of these procedures, and also the bench tests are done mostly on nominal expansion. So there is also, from the same paper, what you can see here on the right is that there is proof that underexpansion of the prosthesis, especially large ones, leads to leaflet pinwheeling, which you can see here, which means that coaptation of the leaflets is suboptimal. And these devices are more prone to earlier degeneration, which you can see here. You can see on the left side of the slide that underexpanded prostheses have much worse prognosis, and this may happen especially in bicuspid patients. Regardless of the other inflammatory factors, the main clinical factor could be that either we choose a wrong size of the prosthesis, especially intraannular prosthesis, in a bicuspid position. So going towards the registry data on the durability of the valves, what we can see is that structural valve degeneration is not so frequent. As you can see that the follow-up of years between the 5 to 10, the severe structural valve degeneration is quite low. It ranges from 0.5 to 5% of patients, and especially in patients in whom we treated so far, these were elderly patients and patients with a high risk of TAVR implantation. From the randomized controlled data, what we see is that within 5 years of observation, also the SVD rate is not so frequent. It is less than 10% for TAVI, while in comparison, it is much more for SAVR, especially in the CoreValve US high-risk trial. The SAVR, in SAVR group, the SVD rate was up to 25%. While in lower risk scenarios, the TAVI SVD rate is in 5-year follow-up is less than 5%. The Notion 10-year data, which is widely cited, also gave the foundations to thinking that the SVD rate in TAVI patients is way less than in SAVR. You can see that in 10-year observation, the incidence of the severe valve degeneration was about 1.5% for the TAVI cohort against the surgical arm with a severe SVD present in 10% of these patients. So for the partner 5-year echocardiographic performance, what we also see is that self-expandable balloon devices maintain the integrity within 5 years, and this is from the high-risk cohort, leading to good clinical outcomes. Also, for echocardiography, as you can see that the mean gradient in partner 3, which is a low-risk cohort, is maintained, and there is no difference between surgery and TAVR in 5-year observation. And the SVD rate, as you can see on the right, in TAVI arm is 1.4% against 2.0% in the surgical arm, which is good, but we should also keep in mind that this partner 3 did not analyze bicuspid patients in this RCT. For the CoreValve, which was published years ago in the CoreValve, which is an old valve, self-expandable valve, was also heartwarming because we also saw that the mean aortic gradient in all the generation devices was maintained during the 5-year follow-up. And this is like a slide from all current experience of the registries saying that moderate SVT may be present in up to 14% of patients within the observation of 8 to 10 years. However, we should do more prolonged observation to establish, to make sure that the durability extends over 10 years. But still, from this registry data, what we know is that for 3-leaflet aortic valve stenosis, the SVD rate should be lower than 10% of patients included. And what I also wanted to show you is that current evidence for what is especially important for the Asian population, meaning for small annuli. Also, going towards women, the women feature is a small annuli. So I would like to show 4 registries which show the results of comparison between self-expandable versus balloon expandable. One information came from 2022, which showed that there is a significant difference between, first, the gradient between self-expandable versus balloon expandable, and also the durability in favor of self-expandable devices. And actually, this observation was including the echocardiographical observation of the patients, which showed that the gradient in self-expandable is lower than in balloon expandable. And this observation was not so much confirmed by the next publication in 2023, showing that in European perspective, the balloon expandable fared the same in small annuli as self-expandable devices, which gave a bit of a stir because still we did not know what was the outcome in these patients. The OPERA trial was also published in the same year. Again, was in favor of the self-expandable devices, which was driven by the difference in the gradient, and making us thinking that probably it is the era of the follow-up of the patients in small annuli and intra-annular devices, because still we think that there is a difference in echocardiography observation based on velocity, on how we define the patient-prosthesis mismatch in these patients, and also how we derive the gradients in small devices and large devices based on velocity and echocardiography. And also you can see the same in the most recent publication in small annuli, which was a publication from the SMART trial, which showed that in 30-day observation, the gradient was higher in balloon expandable devices, while in self-expandable devices with a higher position leaflets, the gradient was smaller. So this would lead all operators thinking that probably in small annuli, we should choose the self-expandable devices with a supraannular positioning of the leaflets, because they lead to smaller gradients and probably longer durability of these devices in patients with small annuli. However, I was just inserting these slides this night because just one day before at New York Valves, there was a presentation from the Partner 3 clinical trial within the 5-year observation, which actually showed that there was no clinical difference in patients with the mean gradient of less than 20 millimeters mercury and more than 20 millimeter mercury in balloon expandable SAPIEN 3 devices, meaning that also what you can see on the right, that bioprosthetic valve failure was not different between the SAPIEN 3 devices with high gradient and low gradient. And I think this is the longest duration of observation from the Partner 3 for bioprosthetic valve failure, which is quite heartwarming because it shows that for small annuli, we should not think that the high gradient echocardiography defined leads to earlier degeneration. Actually, is quite contradictory. And now we think that we should do invasive assessment of the gradient after every implantation of the SAPIEN device. And for the final part of this talk, I would like also to say that there are now trials of finding more durable devices. You can see this is an example of a surgical valve with the Resilia tissue, which is a novel tissue trying to prevent calcification of the leaflets. And this has been tested and observed for the 7 years in the COMMENCE trial, which shows that in comparison to other valves, the Resilia surgical device was extremely durable, leading to a very low number of structural valve degeneration. And also it was confirmed that by a registry coming also from my country in Poland. As you can see that the patients within 16-month observation experienced SVD in 1% versus 5% of patients in other contemporary surgical devices. And this improved performance of the leaflets is currently being observed in Resilia SAPIEN 3 Ultra TAVR devices, which is available in Japan, in the US, and also since this month in Europe. And what we also can observe is not only what we hope will be longer durability of these leaflets, but also what we can see is there is initial proof that these devices, because of the leaflet design and different suturing, may experience also lower gradients, so even better for small annuli. And while we observe these patients coming to all centers, but still in small quantities, small numbers of these patients for degeneration, we are trying to know actually how to treat these patients doing redo TAVI interventions. And my final message would be that currently we have no prospective data on how we should treat these patients if this degeneration occurs, whether it is SVD or non-structural failure. And just a small note that currently in Europe, but also in Canada and Israel, we are performing together with the Professor Giuseppe Tarantini, who has just left the New York Valves, prospective registry focusing on all patients who experience the generation of TAVI devices and are undergoing balloon expandable device treatment, because the SAPIEN is the only valve registered for redo TAVI interventions in Europe, but also it is mostly applicable to all other devices. So these are the countries which are included in the prospective ReTAVI registry, and we have currently exceeded about 30% of the recruitment in this prospective registry of 150 patients, and leading to probably recommendations on how to treat these patients if SVD occurs in them. So in conclusion, I would like to say that randomized and observational data with the criteria of the VARC3 support the use of TAVI in younger patients with severe symptomatic aortic stenosis, that the risk of SVD up to 10 years is quite low. So it is also supporting and encouraging for using TAVI devices versus surgical devices in younger patients. However, we should note that the data on bicuspid patients is very low, and probably we should call for larger prospective observational trials or randomized clinical trials to detect the SVD in these patients. And in case if the SVD occurs, there is a prospective redo TAVI registry underway, which will answer on how to treat those patients best. Thank you so much for your attention.
Thank you. Thank you so much for your excellent talk and very informative. And we know that we need more data in this field.
Yeah.
Thank you so much for joining this meeting. Thank you.
谢谢.
Okay, 谢谢. Let's move to the last talk of this session, which will be delivered by Dr. Li Jie from Guangdong. 李教授好。
殷教授好。我看见永在兄也在哦。大家早上好。
早上好。
那么今天很高兴能够到这里来。
谢谢。Please give us the last talk of this session, TAVR in patient with rheumatic aortic stenosis. 谢谢。
对，因为我现在在西藏这边，所以有一些材料可能不是太齐，所以我的讲课内容稍微做了一下调整。那么就是合并有其他疾病的主动脉瓣狭窄的 TAVI 的一站式的一个治疗的一个策略。那么我们知道，现在随着我们做的这个瓣膜狭窄的病人，这个范围越来越大，那么很多病人他并不是单纯的一个主动脉瓣狭窄，那很容易合并有其他的问题。那么最常见的当然是合并有冠心病。那么因为中国大陆风湿性心脏病的病人也比较多，所以我们也碰到了不少主动脉瓣狭窄合并二尖瓣狭窄的这些病人。那么还有一些呢，就是合并有肥厚性心肌病的那么我们还碰到一些合并有主动脉疾病的一些病人。那么就跟大家一起回顾一下，看看对于这种狭窄合并有其他类型疾病的时候，我们在做处理的时候，一站式的策略是怎么样的。我们知道了，随着人口老龄化，那么我们这种主动脉瓣狭窄的病人呢，最常合并的就是这种冠心病。那么冠心病呢，这种合并症呢，其实如何去处理，有很多不同的分类的一个方法。那么其中一个呢，就是使用 Syntax 评分去对他的这些冠心病的病人，合并有冠心病的病人，他的预后做一个分成。那么我们知道，这个如果 Syntax 评分大于22分的话呢，那么可能呢，这些病人的合并有主宰的这些病人呢，他的预后会比较差。 那么在治疗时机的选择呢，我们是选择 TAVI 加 PCI 呢，还是选择外科换瓣加搭桥呢？那我们可以看到是 TAVI 的一个亚组分析哈。那么它这里面呢，就是平均的入选了332例的一个AS 合并 CAD 的这个病人，那么随机分到 TAVI 加 PCI 还有外科换瓣加 CABG 的这样的2组去进行一个对照。好，那我们可以看到呢，不管是 TAVI 加 PCI 同期做也好，还是说我们是外科换瓣加搭桥同时来做也好，那么它的结果呢，预后呢都是差不多的，2组之间呢没有显著性的一个差异。那么具体就是说，在 PCI 和 TAVI 这2个的实际上的选择，我们是1次做还是2次做？那么目前呢没有RCT 的研究去对比这种 one stage 还是分期，哪一种策略更加有优势？那 TAVI 的这2个的这128例 TAVI 加 PCI 的这个病人里面呢，其中呢有76例呢是这个分期做了，那么也有52例是同期做的。那么这2个亚组呢，这个在它的全因死亡还有中风等终点呢，主要的一个问题就是造影剂的剂量，还有它的这个 CKD 这个发生率会稍微高一点。那么另外一个AS 合并 CAD 的问题呢，就是TAVI术后的这些 ACS 的这些病人，那么涉及到主要的原因呢，就是我们 TAVI 瓣膜，特别是国内使用肠瓣膜支架比较多，那么对于这种肠瓣膜的滋长瓣的话呢，多多少少的对冠脉开口的这种再介入都会有一个限制的一个作用。第二个呢，就是 TAVI 术后呢有一些像刚刚那个医生说的，它的会产生半夜的这些血栓，那么我们也有看到血栓脱落导致的这种 ACS， 那么这种种原因呢，导致这些 TAVI 术后的病人呢，他还是会有再介入的这种需求。那么再介入的需求的话呢，他们可能就是在做完 TAVI 术后跟没有做 TAVI 的这些病人，他在发生 ACS 之后，他的介入就存在的他的一个潜在的一个困难。那么主要的原因呢，大家可以看到，就不管是用球扣瓣也好，或者是用自粉瓣也好，那么我们新植入的这种生物瓣膜的这种支架呢，它就会干扰我们的这种术后的这种再介入。那当然现在呢，我们也有一些类似的方法去做一个调整。那么如何去识别呢？主要就是这种缝合区的一个高度会影响了左右冠的介入的一个深度。那么对于这种 AS 合并 CAD 的这些病人呢，大多数情况下呢，我们其实是会选择同期去处理的。那么当然也有例外，像比如说这个病人就特别特殊，我们这个病人呢来的时候，他并不是主动脉瓣狭窄的症状来的，他是因为 ACS 来的。那么造影一看呢，是一个严重的3支血管病变，那么右冠开口呢是一个严重的一个狭窄。然后左冠呢也是一个弥漫性的一个钙化和狭窄，那么3支血管都很重，然后同时呢又合并有一个主动脉瓣狭窄。那么鉴于来的时候是一个急诊的一个状态，所以呢我们就是当时把犯罪血管考虑是一个右冠开口的这个重度狭窄，就先把右冠开口的这个狭窄先给他做了一次急诊的一个 PCI 的一个介入手术。介入手术之后呢，再综合判断它的主动脉瓣狭窄和它的左冠的弥漫病变，去选择一个手术策略。那我们是当时因为这个病人做完 ACS 的右冠介入之后呢，仍然心功能非常的差，而且考虑到他的左冠呢是需要因为钙化弥漫的钙化和扭曲，所以需要使用到旋膜这个比较复杂的一个操作。所以呢，我们又分期在第2次做了一个同期的 ECMO 注下的一个 PCI 加 TAVI 的一个手术，是这样分成2次来做，就是既有分期又有同期合并，就是比较特殊的一个策略。对，那么做完旋膜之后呢，我们再做一个 TAVI 手术的一个植入。那么同时呢，因为他的这个病人的入路很差，大家可以看到我的大鞘是在深主动脉这里，所以我们当时还做的是一个经颈动脉的一个 TAVI 的一个手术。 对，大鞘是从颈动脉下来的。所以呢，就是说，对于这些 AS 合并 CAD 的这种病人的话呢，那么我们在日常处理中，多数情况下，如果他冠脉病变不是太复杂，那么我们都会使用TAVR加 PCI 的一站式的一个处理。但是呢，要根据病人来的时候的一个状态，到底是冠心病占主要，还是主动脉瓣狭窄的症状占主要啊？那比如说像刚才那个病人，他来的时候是 ACS， 所以我们会先处理急诊 PCI， 会先给他做一条血管，然后呢把复杂的血管再留下来跟TAVR一起，因为病人做完之后心功能的恢复并不好啊，所以呢，再如果说这个时候他左冠的 PCI 又比较复杂，所以我们会使用 ECMO 去辅助，去给他一站式把剩下的血管还有瓣膜一起给他处理，这样的话呢，达到一个比较好的一个康复的一个情况。那么如果心功能差的时候呢，我们也有试过，先做一个主动脉瓣的球扩，然后呢再做 PCI， 然后最后做 TAVR。那么主要为什么 PCI 经常会放在 TAVR 之前来做呢？就是因为它这个做完 TAVR 之后，对于冠脉的介入确实多多少少会产生一些影响，所以呢，我们会在同期手术当中先去做 PCI， 然后再做TAVR。那么，但是如果说合并有 ACS， 那我们可能会选择一个分期的一个情况。那么第二个呢，就是我们经常也会遇到的，就是风湿性的这些病。那么风湿性的这些病人呢，它的一个特点呢，就是通常会出现主动脉瓣狭窄，合并有一个二尖瓣狭窄的一个情况。那么这些病人呢，3%的情况会出现中重度的二尖瓣狭窄。那么这些病人到底需不需要去同时来处理主动脉瓣和二尖瓣呢？那么根据现行的一个瓣膜治疗的一个指南，对于这种重度的主窄合并重度的二窄的病人的话呢，那推荐呢首选还是外科手术，就2个瓣膜一起换啊。那么这些呢这个呢是最彻底的一个方案了。但是呢，确实也有临床上遇到一些高龄虚弱的这种高风险患者，那么这些病人确实耐受不了外科手术。那么这个时候呢，就怎么办呢？那么我们经导管的治疗呢，也提供了一种新的选择。那么直到目前呢来说呢，对于这种一站式的 AS 合并 MS 的这种联合瓣膜病变的介入处理的，经验呢还是比较少的。那么只是做一个个案的一些报道在国外。在国内的话呢，我们中心因为我们中心早期也是做一个二窄的 PBMV 球囊扩张的一个术式做的比较多，所以呢，我们也会尝试做一个TAVR 加 PBMV 同期手术，这样的一个术式。那么在做这个手术的时候呢，我们面临的第一个选择就是到底是先做PBMV 还是先做 TAVR。那么这一点呢，跟我们做 PCI 的时候也是会一样会面临这样的一个选择的。那么在这个选择当中呢，很重要一个就是跟你选择的这种瓣膜的型号，主瓣的瓣膜的型号可能会有一定的关系啊，这个是我们自己的一个理解。因为在国内的话，那么很多都是用这种自盆瓣，那么自盆瓣呢，它相对来说会在流出道的位置呢，会有更多的一个瓣架，会有瓣架支架的底端呢会突出到左室的流出道。那么这个时候呢，我们如果再来做先做 TAVR， 然后再来做 PBMV 的话，那么这个二尖瓣球囊在左室充盈后回拉的这个过程中呢，就有可能去影响到主瓣的这个瓣膜支架所以呢，会导致他们两者互相影响的这样的一个结果。所以呢，我们自己觉得就是先行，如果需要 MS 和 AS 先行做 PBMV 的话呢，那需要 PBMV 加 TAVR 的话呢，那么先做 PBMV 似乎是更为合理。当然，如果你的主瓣选择的是一个爱德华的一个短瓣膜的话呢，那么这样的话呢，可能风险会小很多。那么其实谁先谁后也没有绝对的一个顺序的一个要求。那么第三种情况呢，就是我们遇到的主动脉瓣狭窄合并这个肥厚梗阻性心肌病的这些病人。那么我们都知道，其实主瓣的狭窄呢，它会导致左室的一个肥厚。那么极度的左室肥厚呢，其实会出现这种类似肥厚梗阻性心肌病的这种病变。 那当然我们也有遇到过真正是肥厚心，然后合并有这个主动脉瓣狭窄的情况，但比较少。那么多数情况下其实都是主宰导致心肌肥厚，导致出现这种类似的流出到梗阻、血流速度增快的这种情况。那这种情况的话呢，其实标准的做法呢就是外科手术。那么外科呢，他们一般会做主瓣的一个置换加时间隔的一个切除。那么这种呢是一个标准的治疗方案。但是呢，对于一些高龄的外科手术高危的这些病人的话呢，那么我们也可以考虑做介入。但是呢，这个也是比较少的一个做法。那么在我们中心呢，有遇见过流出到速度加快的，但是我们并没有很积极的去处理这个消融的情况。那么我们也是在网上查了一些资料哈。那么国内呢是有做过 TAVI， 同时做一个时间隔的一个化学消融这样的一种做法。那么这个呢是一个77岁的一个老年男性，就是他的彩超诊断呢就是主动脉瓣狭窄合并左室的一个流出到一个梗阻。那么他的做法呢是先行做过了化学消融的急性期之后，我们再来做一个 TAVI 的瓣膜。那么他的考虑呢就是对于主宰合并流出到梗阻的这些病人的话呢，那么治疗呢它确实是很紧迫的。但是呢，因为我们做化学消融的过程中呢，会造成这种心肌的损伤。那么如果在心肌损伤的急性期去做 TAVI 手术的话呢，可能也会对 TAVI 手术的安全性造成一定的影响。所以他们的选择呢是在先做消融之后观察心宫酶，在酶学恢复之后 ，CKMB 恢复到基本基线之后，大概7天左右，那么再去做一个 TAVI 的手术。同时呢，他们因为考虑到这种时间隔的这种本身消融对时间隔的这种刺激，再加上瓣膜对人工瓣对时间隔的这种影响，所以他们选择了一个短瓣架的 S3的一个瓣膜来进行植入尽可能的减少对这种传导阻滞的影响，减少这个术后起搏器的一个发生。我觉得这个也是一个很好的一个方案。那么另外一个呢，就是国内原创的这个立文术式我们知道这个我们国内这个西京医院的刘立文主任，他创造的这种对于肥厚梗阻性心肌病的超声引导下的时间隔消融那么这种立文术式呢，来联合 TAVI 手术来做呢，其实也是非常好的一个想法。那么这个呢是华西医院报道的，我们的陈茂教授，他们也是联合了西京医院的刘立文教授，他们做了一个 TAVI 加立文术式这样的一个治疗方案。那么这个呢，它也是并没有一次性去完成一站式去完成，而是这个先做了 TAVI， 在 TAVI 之后呢，观察药物治疗，发现这个病人的流出道的流速并没有下降，所以呢，在半年之后呢，再做了一个立文术式这样的一个处理。那么最后呢，就是讲讲合并主动脉疾病那么因为主宰的病人的他的年龄他一般都是很高龄了，所以这一类病人呢，他也经常会合并有主动脉疾病的一个发生率。那么文献报道呢，他们合并腹主动脉瘤的这种发生率呢，最高可以去到6%。那传统的方法呢，就是先外科，然后呢再先外科换瓣，然后呢再做腹主动脉瘤的一个介入治疗。那么我们也是尝试过 TAVI 加 EVA 的这个一站式的一个做法。那么这种做法的优势呢，主要就是因为我们知道做 TAVI 的入路，还有它常用的这种支撑导丝，其实和做腹主动脉瘤夹层，那么这一类大支架，它使用的同一类的支撑导丝和同样的一个大腔径的一个入路，所以呢，我们其实是可以考虑一站式去把这个外周血管的问题，还有瓣膜的问题一起去解决的。同时呢，可以减少患者的这种麻醉剂量和放射剂量，还有造影剂的一个剂量。那到底是先做 EVA 还是先做 TAVI 呢？目前呢是没有定论的。那如果说先做 EVA 的话呢，那可以防止这个瓣膜的输送系统在通过的时候对血管引起的一个损伤，以及在 TAVI 手术当中血压的这种波动引起的主动脉病变的这种变化，疾病的一个变化。 但是呢，如果说我们是先做 TAVI 的话，那么可以降低瓣膜输送系统来通过腹主动脉支架带来的风险。我们知道，如果说我们腹主动脉放了支架，那么在 TAVI 系统再通过的话，其实是有难度的哈，有难度的。那这个是在查到的巴利的 TAVI 加 EVA 的一个报道，我们可以看到，就是其实都是不是同期做的啊，都是分期做的。这些病人都是先后，要么先做 EVA， 要么先做 TAVI， 那么并没有同期做的一个报道。那么我们是在2019年的时候，当时正好遇到一个病人，是主动脉瓣狭窄，合并有降主动脉的一个大的透壁溃疡啊，我们可以看到右下角这个图，就是产生一个大的透壁溃疡。所以呢，当时呢，我们是选择了同期来做 TAVI 加 EVA。那么因为它这个降主动脉的溃疡对于 TAVI 的入路并没有太大的影响，所以呢，我们当时选择的是先做 TAVI， 做完 TAVI 之后呢，把导丝撤回来，放到深主动脉，然后就是用同一条导丝和同一个入路，然后给它植入了一个降主动脉的一个腹膜的一个支架。那么这个是 TAVI 加 EVA。那么最后呢，还有多瓣膜的一站式的一个治疗啦。现在因为我们国内外科也有很多同行在做这种瓣膜的介入，那么他们有很多经心间的经这个房间隔的各种各样的这种瓣膜可以选择。所以呢，我们可以看到这是我们国内报道的一站式的多瓣膜的一个介入治疗的一个探索。3个瓣，主动脉瓣。原来是做了2间瓣和3间瓣的生物瓣置换，然后生物瓣衰败了，然后同时呢又出现了新发的主动脉瓣狭窄，所以他们一次性就做了 TAVI 加2间瓣加3间瓣的这种介入瓣，一次做了3个瓣啊，非常的厉害。然后总共是5个瓣膜啊，然后就是也有做这种TAVI 加 TIA 加这个3间瓣的 TTVR。这个是我们上海中山团队做的哈，也是在我们网上有报道。那么经心间呢，它是经心间做了这个 TAVI 加 TIA， 因为国内我们有经心间的这种 TIA 的器械，然后呢再通过右心房穿刺植入了一个介入的一个3间瓣，这个也是一次性的把3个瓣膜全部给它处理完。对，那么还有4个瓣的，4个瓣呢，这个是我们武汉协和的董念国教授他们那边的团队经皮治疗4个瓣，就是主动脉瓣包括肺瓣我们可以看到主动脉瓣、2间瓣、3间瓣，包括肺瓣，一站式放4个瓣，这个也是非常的有挑战非常有挑战。那么最后总结一下，就是对于这种主宰的病人呢，其实他合并症还是不少的，因为高龄嘛。那其实最常见的就是合并冠心病了。那冠心病的话呢，我们多数情况上临床是会一站式做处理的。那么在一站式的过程中呢，我们因为这个瓣膜支架阻挡的原因，我们会先做 PCI， 再做 TAVI， 这是最常见的做法。但是如果遇到合并有 ACS 的情况的话呢，那么我们还是会考虑先处理 ACS， 然后先 PCI， 然后再择期 TAVI。那么对于主宰合并2载的病人，目前呢是有逐步在尝试做 TAVI 加 PBMV。那我们的做法呢，一般就是先 PBMV 再做 TAVI。那么我看国内也有一些中心是先 TAVI 之后，再观察2载的一个流速变化的情况再决定是否做这个 PBMV， 也可以那我也看到他们 PBMV 就先 TAVI 之后，他放的就是质盆瓣的瓣膜，先 TAVI 之后再做 PBMV， 它的这个2间瓣球囊其实对主瓣的这个支架影响好像也不是太大好像也不是太大。那么还有呢，就是主宰合并左室肥厚流出道梗阻的。那国内呢，就是创新性的做法呢，就是有利文术式和 TAVI， 那常用的还有化学消融加 TAVI。那但是呢，其实多数情况下，我们觉得做完 TAVI 之后，它的流出道梗阻的情况都可以逐步缓解。有少量的病人缓解不了，那么这个时候呢，可能需要加做化学消融或利文术式 但是因为你们的 TAVI 瓣膜先放在那里的话呢，你要再去左灌去做化学消融，其实是有难度的其实是有难度的。所以呢，也有报道就是先做化学消融，再做 TAVI 这样的话呢似乎会合理一些，但是很少会一站式去做，因为化学消融之后其实就是人为的造成了一个心梗，那这个时候再去做 TAVI 呢，可能也会有一定的一个风险。那么第4个呢，就是合并有主动脉疾病的。那么这种的话呢，我们认为 TAVI 加 EVA 其实是安全可行的。我们有碰到不少腹主动脉瘤的那我们会先做 TAVI， 然后接下来呢直接做腹主动脉瘤的腔内隔绝，或者是降主动脉夹层的这种腔内隔绝都可以做都可以做。对，谢谢大家。
好，谢谢李教授精彩的演讲，也给我们很多启发。确实，病人越来越年纪大，共病越多需要更多的思考。但是transcatheter 的 approach 可能是真的应该要考虑的，因为病人或者是家属或甚至医生都会比较希望能够用这种比较没有侵犯性的一个 approach。Thank you, thank you all the panelists and guests and speakers. We have a very wonderful and fruitful session this morning. So I would like to invite the moderators and speakers and the panelists of the next session to come up to the stage. Thank you.
Thank you.
Proceed to the next session. This session will be the roundtable discussion for the surgical management of aortic regurgitation. And Dr. Jie Li will be my co-moderator. And the participating experts include Dr. Zhang Zhongyi. He is the Chief of Cardiac Center at Chun-Ting General Hospital, and Dr. Chen Bo-song is the attending surgeon of the cardiac surgery at Chun-Ting General Hospital, and also Dr. Chen Yi-cheng, also the attending surgeons of the Chun-Ting General Hospital. So the first topic will be presented by Dr. Jie Li. Let me give a brief introduction to Dr. Jie Li. Dr. Jie Li, Professor Jie Li is the director of the cardiac surgical program at the British Columbia University. And also he is the chief of chief cardiac surgeon at the university, at the also the director of surgical mitral and tricuspid valve program at St. Paul Hospital, and also the Vancouver General Hospital. He's an expert in doing valve repair, including tricuspid and mitral valve, and also the transcatheter valve therapies. And he actually people knows that he's the expert in, and also the pioneers in doing a lot of surgeries, including many procedures as the first human procedures in human, including transcatheter valve treatment for the aortic stenosis, and also for the failed bioprosthesis. And also he has done a lot of valve repairs, and he's a very good educator. And he has taught many procedures for many surgeons and also cardiologists that in the especially in the field of transcatheter procedures and also valve repair in the world. So let's give a welcome to Dr. Ye-Jian for his topic, first topic. And this topic will be the aortic regurgitation, the current status.
To be here again. This is I think it's 10 years, right? Almost 10 years. I think it's 10 years, right? So I'm so happy to be here now. It's 10 years in a row. So I'm really happy to see my old friends and the new friends, new faces. So thanks again for inviting me to be here again this year. So my topic, I asked to give a talk on the aortic regurgitation current status. So this is probably the first time I'm talking about the current status of aortic regurgitation, because there used to be the topic will be like transcatheter treatment for aortic regurgitation, and I never give a talk on the surgical method for aortic regurgitation, because everybody thinks the aortic regurgitation management is pretty simple. There's no really too much contraindication or these kind of things. But nowadays, I think with the more methodologies introduced in clinical in managing aortic regurgitation, I think it becoming more complicated in decision making, and maybe sometimes they're more confused. So I give a very simple, quick overview. Oh. Okay, this is my exclusion. So aortic valve, it's actually the regurgitation is pretty similar to the mitral regurgitation. So mitral regurgitation, you need to think about the mitral annulus, and the aortic valve, you also need to think about the aortic annulus. And the mitral leaflets and the tricuspid valve, so the abnormality. And the second, third one is for mitral valve, is you need to think of the mitral LV, the basic LV chamber, the morphology or any abnormality. But the aortic valve also aortic lute. So if you think about it, the aortic regurgitation and the mitral regurgitation actually is very similar. And in terms of how to treat this valve, and also very similar to the mitral valve in some aspect. So the etiology aortic valve also is quite complex. All different etiology, congenitals, rheumatic, and it depends on the region. The percentage can be quite a variable. So in terms of the diagnosis, regurgitation, sometimes the diagnosis can be quite a challenge. For the severe, I think it's easy. Everybody can make a diagnosis. Even you don't need a major, you just look at it, this is severe regurgitation. But for the moderate, severe, sometimes it can be very, very challenging. Actually, when I do any mitral valve surgery or any like a tricuspid valve surgery, the most part is when the patient has the moderate aortic regurgitation. So always follow me. I always say I don't like this kind of patient if patient has moderate aortic regurgitation, because it's so difficult to make a decision. Even you ask the echocardiology in the OR, spend like sometimes half an hour to make a decision whether this valve needs to be down or not be down. It's very difficult. So I found when the moderate, severe, it's very difficult. There's a lots of ways to measure the regurgitation, but when you have more way to measure the one thing, that means no single one is good enough. Because if one single can way to determine the severity, and then you don't need so many parameters. When you have 6 or 7 parameters, that means no one is the best for make a decision. So the aortic regurgitation is similar. You can have a semi-quantitative, a quantitative, or like just a visual determination, but no one is actually say this is based on this, you can say this is severe or this definitely is moderate. So sometimes it can be difficult. And nowadays, cardiac MR has been more increasingly used for assessing aortic regurgitation. This is actually quite accurate. If you look at it, we do a more MRI, but the most found is the MRI usually is compared to echo, MR usually reported more significant because they're based on the regurgin fraction. They are pretty accurate. So if the TE show there's a moderate severe, MR, majority situation, MR will report severe. So now say the difficult part is that we should base on the MR report or based on the TE report because there's no really solid data. We should follow the cardiac MR or the old way TE. So sometimes can be a challenge. And the CT is mainly for the aortic morphology. So here's a list about how to select the imaging. There's a few imaging you can choose, but of course the transthoracic imaging is the initial diagnosis. So you're trying to make it, if it's pretty clear, there's no contraindication. It's easy to say this is severe. But there's sometimes there can be difficulty. So you need to think about what's the next like a way to determine the trying to find the etiology or the ALV function or chamber size, you need to think about it. So general CT, if you need to think about the aortic, you need to assess the aorta, you need CT. If a patient is a potential TAVR candidate, I think a CT is a standard way to make the aneurysm measurement. And for the cardiac MR, usually if the equivalent TEE or echo finding, I think MR is probably the next step to determine severity of the aortic regurgitation. And another MR is good thing if a patient have a cardiomyopathy, dilated cardiomyopathy, but not consistent with the severe AI. And you want to determine is what's the potential other etiology cause the cardiomyopathy. I think cardiac MR is very useful, very useful. And in terms of TE, it's more like a more fragile assessment. And sometimes if eccentric jet, TE may be helpful. So in terms of grading, this is a grading, I think I will not go through, there's a lots of ways to determine severity of the AI. And currently the guidelines still, I think the guidelines are very similar to the aorta. It's very clear that basically you're based on symptom, based on the chamber size, based on the heart function. That's basically your three things that you determine the patient need a intervention or not. But the conditions have to be a severe aortic regurgitation, not less than severe. So when you have a moderate to moderate severe, and then will be difficulty to make a decision whether it's class 1 or class 2A. But when it's severe, it's really easy to make a decision. And in terms of management, so there's quite a few management. Of course, the monitoring, whether the patient should be continued monitored or should be early surgery. Second, the medical management, generally speaking, is not really effective, but some medication like a beta blocker, other things you can use it. And the surgery, of course, the few things, just like a mitral valve, you can have repair, you can have replacement, you have a LUT involvement, so you need LUT procedure, and also nowadays TAVI has been increased the use for the aortic regurgitation nowadays. And another thing, difficulty part is the palliative treatment. Palliative treatment actually is more difficult to make a decision for the physician to make a decision, because when you say the palliative, that means we are not going to give any definite treatment. So sometimes it can be really challenging, really challenging. So better to have a team to make a decision rather than one person to make a decision in terms of palliative treatment. In terms of replacement, I think everybody knows to replace it's generally speaking, you have a bento homograft. The homograft is sometimes be used more for the infection disease or the other reasons. But there's issues because of calcification and later on the TAVI maybe is a challenge. And in terms of other procedure, the Osaka's procedure, I think I call this one is not the repair. I call this a replacement because you replace 3 leaflets. Basically use a commercial valve, don't use a commercial valve, but use a native pericardium. So I think it's a replace the valve, it's not a repair the valve. So I think I will not go to so detail because Dr. Tsao will give a detailed talk on this Osaka's procedure. And the long-term reported, of course, it's difficult to comparison one to other because there's no any randomized trial to compare the one method to another method. But this is reported from Osaka is quite a numbers, over 1,000 patients. And reoperated is 90, freedom is 95.8 at 12 years. That's a pretty, very impressive actually is the outcomes with this procedure. I talked to Dr. Seki when he started. He said, "You want to start this procedure?" I said, "No, I don't want to. I really don't want to start right away because I want to wait for your result before I started this kind of replacement." So that was quite a years ago. He has started. So, but based on this data, I think that's very impressive. Very surprised to me is a native pericardium can be lasted that long because usually calcification's issue. So, and in terms of repair, just like a mitral valve repair, so you really based on the annulus, is there any annulus dilatation, is there any LV dilatation, this is maybe aortic root dilatation, or any leaflets abnormality. So based on this, you have a all different type of like a method to fix the aortic regurgitation, depending on the pathology or environment. And this I just found is that the repair of the aortic valves. There's lots of publications. Overloads repairs outcomes pretty good, but it also depend on the etiology. I think there's one paper says overload usually is the leaflets are retracted or prolapse. They are not really good outcomes if the combination, particularly as the leaflets, the shortening or retracted, as usually outcomes, the long-term outcome is not really great. But in terms of like a single prolapse or the fenestration or the perforation, they have excellent result. And in terms of involves the root, that's I think the Professor Wei is an expert in this area for the aortic root procedures. I actually watch him to do a surgery, and he's so quick to do this procedure. I probably like I need a double time to do a procedure. He just so quick. I watch it, and so there's a two long-term outcome. Actually, is a pretty impressive. You see the long-term outcome in terms of root procedure is up to 20 years. I think outcome is great. I think a David procedure probably is a little, because at least they don't have annular dilatation, this concentration problems. And in terms of Ross procedure, so Ross procedure now is actually regained interesting. Used to be Ross procedure many years ago, and then there's a lost the interesting. Now it's becoming more interesting. So the data is published data is pretty like impressive. So there's two ways. One is just a typical like a classic Ross procedure. Basically, you put the pulmonary valve directly into the aortic valve. But there's one is a use of rapid use Wasawa graft to wrap the pulmonary root first before you implant. I think that's a great idea because you prevent the complication from redilatation from a long-term, like a following long-term is a probable redilatation. So this can prevent the redilatation. I think a pretty good idea. So the contraindication, there's some contraindication, relative contraindication for the Ross procedure, but generally speaking, using the young patient, and it's a bicuspid valve, whether it's a pulmonary bicuspid valve, whether it's good or not good, I think it's a pretty small portion. But generally speaking, if a patient have a connective tissue disease, you try not use this procedure. And this is the reason outcome report. It's very surprisingly is actually the only things I think that the after repair or replacement they match the general population survival. This is a Ross procedure, and they match the general population age, and you see that the survival actually up to 20 years are pretty similar to the normal population. That's a very impressive result. So that's probably also another reason gain the interesting bit, because they feel that only the Ross procedure really can restore the people's life expectancy, normal life expectancy. So that's, but in terms of reoperation at 20 years, not that small. If you look at the right side, is up to about 40% at 20 years is a reoperation. So this is the overall comparison, there's one paper just published, but I don't think it's very easy to compare because it's so variable between each study and method, like a different treatment patient. So, but overall, this interesting paper is that they say is basically everything compared to Ross procedure. Seems like Ross procedure is better than other the treatment. But I think a very important is Ross procedure is a very select patient, and also, generally speaking, already young patient, and also the you when select patient, you always try and choose the relatively healthy and young patient for the Ross procedure. So I think that whether this is mean something, it's difficult to say because difficult to make a comparison between different method. But overall, in this meta-analysis, actually the Ross procedure very impressive. So that's why it's again more like an interesting Ross procedure recently. But I think the important thing is I think is one thing mistake is spread so in I think it's spread too widely because I should be concentrated in some experience center for this kind of procedure because everybody does a Ross procedure every year, only do 5-10 cases. I don't think it will be similar outcomes. So that's really important things I think it shouldn't spread it to all different hospitals because nowadays every surgeon trying to do a Ross procedure. In Canada, same. Every hospital should trying to do a Ross because they feels like I can do the Ross procedure. That's the best, like most difficult surgeon I can do it. So it's not a good idea because the surgeon probably only do very few cases. In terms of transcatheter procedures, now I will really quick go through it because I think it will be more a topic over there. But now it's because it's dedicated TAVR. I got not going through this because it will go. Okay, I only do the two trial. This is a Yen-Valve trial, 1 year, very good. Otherwise, everything good outcome except the pacemaker. Pacemaker is quite high in this study. So the Jie valve to TF system, and this is not available, but this is a very early North American compassionate treatment. So this including first in human study and also the first generation. So there's you see the outcome is pretty good, but if you see the reason of 15 is after this remodeling or basically revising the delivery system, and the success rate is almost 100%. So pacemaker about 13%, but that's including first in human experience. So for the AI patient now need a heart team. Why need a heart team? Because one is the decision making, when we should the intervention. Second is which is the best option for the patient. I think there's so many methods available now, and we need to make a decision which is the best for the patient. I think a heart team is now very important also for the AI. Thanks.
Thank you, Dr. Ye. We will have discussion afterwards. So the second topic will be presented by Dr. Chen Bo-song. He is talking about the surgical techniques of David procedure.
Okay, thanks for Professor Wei's introduction. I'm Dr. Chen Bo-song, and I'm glad to share this case in our hospital, which was conducted by Professor Wei. It's a VSRR case. This is a 66-year-old female who has hypertension and hyperlipidemia. This time, she visited our hospital due to chest tightness and for CAD survey. The transthoracic echo revealed aortic root ataxia and moderate AR accidentally. The CAT scan showed a huge ascending aorta with maximal diameter 57 millimeters, and the root diameter was 50 millimeters. Also, her aortic arch was dilated too. The preoperative echography showed at least moderate AR. And at the operation day, the pre-op TEE revealed the dilated aortic root with the sinus Valsalva diameter 51 millimeters, and the vena contracta was 7 millimeter, is severe AR. So the surgical plan including 3 parts. First, we reconstruct aortic root and aortic valve with BSR technique, and we perform a total aortic arch reconstruction for dilated aortic arch. Then we perform PV isolation for with F ablation. Let's see the video. This video focuses on VSRR and the total arch replacement. The VSRR is very important point in carefully dissect the aortic root and remain 4 to 5 millimeter tissue. Then we perform 3 anchoring sutures to commissures. Then perform a sub-aortic annulus suture. We perform 12 stitches, including 3 annulus commissure stitch. After sizing, we choose an straight graft conduit. And we use an HIGA dilator to prevent the purse string effect during tiding. Then we perform the anchoring suture by pulling up to check the AR geometry. If the AR condition becomes worse, converting to bento procedure need to consider. After 3 commissure position, we perform the continuous horizontal matrix suture. After the valve attached to the valve conduit, we use HTK solution to test the AR condition, valve competency, and use the venting to make a relative high negative pressure. When the AR condition is okay, we proceed to coronary button reconstruction. First from main button.
Correction, that's not the HTK solution for testing. Oh. We use iSealing for testing. Oh, okay. Otherwise, it's too expensive. Okay.
Thanks for Professor West.
Usually we don't put the right corner artery at this position. It should be a little toward to the right. But this is particular case, the right coronary artery is more toward to the non-coronary cusp. Okay, so usually it's not this position. The anastomosis should be a little bit on the right. Okay, but this is a particular case.
Okay, we will. This time is HTK.
Now this is HTK, yeah.
Okay, we will perform supraannulus procedure, including debranching of supraaortic annulus, supraaortic vessels. This is a end-to-end anastomosis of left subclavian and left common carotid artery.
This procedure is now our current, our routine procedure for the replacement of the aortic arch. So we'll connect the left carotid and the left subclavian together, then we will put another graft on the left carotid. This will be easier for, and more effective in hemostasis.
And connect the graft to CPB. And now we can ligate supraaortic vessels with 3-O-protein. And we proceed to reconstruction the distal aorta. We will use another straight graft with VRC ring. This method is Dr. Wei's method. We advance and guide wire from femoral
artery, from the femoral artery, yes.
Yeah.
Yeah. So the guide wire will come out from the aortic arch.
And we use this guide wire for a snare technique. Via this snare technique, we can snare the distal graft, so this graft can advance into the aorta smoothly.
By pulling the guide wire from the femoral artery, then the tip of the elephant trunk will be inserted into the thoracic aorta.
So then we tie down the nylon tape to fix the VRC ring and release the snare to open the elephant trunk.
In order to have a good shape of the conventional elephant trunk, we inserted another stent graft into the elephant trunk. So it become a frozen elephant trunk now.
And we complete the anastomosis of these two grafts and created a side branch for the branch supraaortic arteries. We use an white graft. During this step, we can rewound.
This graft is usually used for the surgery for open surgery for abdominal aortic aneurysm. This is an anastomosis between the graft and the innominate artery. while the heart resumed the beating, and we would do the anastomosis between the aortic graft, the branch of the aortic graft to the left carotid artery.
So this is a major part of this operation. We can see after the operation, the T showed minimal residual aortic regurgitation noted. So the valve function is very good. And the follow-up CAT scan showed the supra-aortic branch arteries and the TAVR branch and the distal aorta condition is good. This is my case sharing. Thanks for your listening, and Dr. Wei's.
Thank you. Thank you, Dr. Chen. So the next topic will be given by Dr. Gu Tianxiang. Professor Gu Tianxiang is the chief of the cardiac surgery at the first affiliated hospital, China Medical University. He's also a member of AATS. He has many positions in at the many official medical and cardiac surgical committees in China, and he has been doing open heart surgery for more than 30 years, and he's majored in various surgical fields, including valve, coronary bypass, and the big vessel surgeries, and also minimally invasive cardiac surgery. Now he's talking to us about the topic of David operation. I think he has done a lot of David operations in many patients in recent years. I think it's very worthwhile for him to share his experience with us. Thank you, Dr. Gu.
Good morning. Yes, the Professor Wei and Professor Jie. How long to see you? I think I remember last time I met you, Professor Wei, in Düsseldorf in Germany. I think that's it. Very nice to yes. Thanks you inviting me to my experience about the aortic valve repair in TAVR procedure. Let's say our clinical data. From that data, we can at present time we totally do over 500 patients and want a TAVR procedure. Yes, among them the over 400 patients with moderate to severe regurgitation. From that chart, we can find it the pathology of the aorta mainly is the root aneurysm also included the type A dissection. But recent years we focus on about the normal ascending aorta. That means isolated aortic regurgitation. Yes, the over the 200 cases. Other the pathology changes included the Warsaw sinus. Yeah, so the aortic regurgitation combined with the Takayasu disease, the Basset disease. About the condition of the cusp, yes, the mainly is the tricuspid, but sometimes the bicuspid. Also, yes, the tricuspid is the quadricuspid. Yes, the aortic regurgitation is the majority is the moderate to severe. Marfan syndrome in our data is the over 100 cases. Let's say yes, the chart is very familiar for the integrated vessel surgeon. I think from the severs is the classification we can find it. Include is the two kind of the aortic regurgitation. One is the centric is the regurgitation. Another is the eccentric regurgitation. I think it's belong to the different sub classification. I think it's the type 1 is 1A, 1B, and 1C. Yeah, so I think it's suitable so TAVR procedure. How about it's type 2 is the cusp prolapse. I think at present time is controversial. I think it's because of the many is the patient combined with the aortic regurgitation. I think we can do the one notch is the mimic is the mitral valve repair. I think is the included the three parts of them. I think the aortic valve repair is important, is the part. I think about is in our group is the over 400 cases. The centric is the made up to is the 20%. I think eccentric aortic regurgitation made up to is the over is the 80%. I think it's that's a pathology is the changes is included dilation of the aortic annular, the subtubular junction, the cuspal prolapse, the commissure detachment, perforation, thickness of the free edge. Yes, the bicuspid is the type 0, type 1. Yes, the quadricuspid. I think it's the made up to it over is the 60% is the multiple lesion. Yeah, it get together. Lastly, is the figure is very important. Is the we want to do the better is the TAVR procedure. I think that's a concept is critical things. Yes, so-called is the FAA, the functional aortic annular. It is similar to the mitral valve repair is the mitral annular. Yeah, included the Vasava sinus, ventricular aortic junction, and the stenotubular junction. I think that is the prerequisite is successful the final result. About the indication is the normal and near normal mobility, the mobility of the valve. I think is the control indication is included is the cup calcification, contractor is endocarditis, the severe is a leaflet damage. Yes, the aortic valve repair included remodeling of the aortic annulars, the Vasava sinus, subtubular, plus the valvular plastic. Yes, the mitral aortic valve repair. Remodeling of the aortic root annulars. A straight is the graft is used in TAVR-1 procedure, and the diameter of the graft is the key for the remodeling and aortic root and annulars. Pre-operative evaluation with the TTE of the T is very important. The sub-analyte is the parameter is very important. 1, 2, 3 is the VAG Vasava sinus size is stenotubular junction. Included the ascending aorta diameter is very important. I think for some patients, yes, the ratio, the 3 is the Vasava sinus, not symmetric. I think it's a majority is partially for the aortic regurgitation. Is the 3 sinus is unsymmetric. About the size of the sizing of the grafting, I think our experience is if the diameter is the larger in the 32 and not is the good is the option. I think is smaller is the 32 is the better. I think according to yes, the annular size, the Vasava sinus size, and the stenotubular size, and also combined with the leaflet is applied. What is the need to is application? We can choose the diameter about the artificial vessel. That's a determination of the size of graft. Is the multiple consideration. I think it's mainly based on the body surface area. If I think we can choose the different size. I think that based on is the measurement of annulars. I think usually choose the 19 to the 26. Yes, I think is about the thickness of the aortic valve made up to the 5 millimeter. The diameter graft, the annulars plus is the diameter. I think the such is the parameter is the BSA, the annulars, the effective and the geometry height, and the lesion of the degree aortic. The several is the parameter get put together. We can get the sweet support. There is a higher dilation. I think just the Taiwan is the certain the source is the use of higher dilator is the good method to is preserve the geometry about is the left ventricular outflow tract. I think especially for the smaller side is the aortic root. I think is the symmetry of the cusp should be guaranteed by the fixing the graft. We for the tricuspid is a 120, 120, 120. Bicuspid the aortic valve with the 180, 180. I think is this symmetry. Asymmetric the bicuspid valve is the booster is classification is very important. Is included is the type A, type B, and type C. I think for type A, type B, we choose the 180, 180. But it's the type C is subtype is much more challenged. I think it's followed. It's native the orientation, not is the modified to the 180, 180. Thus is asymmetric is a tricuspid aortic valve. At early time, we choose the bicuspidization restored is symmetric. I think it's also get is the good result. About the symmetric is a quadricuspid valve. I think from the echo we can find it is a symmetric. Yes, a quadricuspid as well. Yes, a severe aortic regurgitation. How to deal with that? I think is we still choose the David procedure. During the intervention, we can find that is the three the leaflet is symmetric. I think is we use the follow the routine is the suture line and do the type 1 the David procedure. From the echo, we can find it no regurgitation, no. I think is the flow rate is very good. Get the satisfied final result. I think the aortic valvular plasticity is very. I think included is the prolapse. How to treat the prolapse? I think that is a formula is very important. We can shorten is the free margin is the length is the. We can get the good cohabitate with the another is the two leaflet. I think is that is application about the cusp. Yes, use the majority patient is the central is the Atlantis is the node area is central application is very common. I think it made up to is the majority patient. That is for some patients, not is the one, it's just the one is the cusp is prolapse. I think two is the cusp application. Yes, also for Marfan patient, we can sometimes we can use the three is the cutter application we can use. This is the non-scientific is the free margin application. I think we can find that is between the Atlantis is the node and is commiserate. I think between them is the pathology is the change is significant. Is very thin. Maybe is a little bit is the dehiscent. I think use the pericardial plate to reinforce it. Yes, the metric is I think the matrix is application. Is also is a common used. About is the correction applies is a commissure area. Maybe we can also do the application. I think it's especially for the some is the commissary is fragile, is very thin. We use the small is the native the pericardium is the patch to in reinforcement get is a very good result. About is the prolapse. Whether or not is has the fenestration about PTFE suture is the suture. Seldom use that. I think his long-term result is the confirmed by the foreign is the doctor is not good. We stop use that. I think is the cusp is the detachment. Yes, we repair use the pericardial patch. Yeah, I think from that is a video we can find that yes, is the commissary is very thin and is the detachment is a rupture. We use the pericardium is placed to reinforcement by the commissary area. We can final echo. We get is a very good result. no regurgitation, yes, no is the stenosis, is the very good. About is the cusp of malcohabitation. I think for some the patient is the leaflet is the cusp, is the thickening. I think is the not is the flexible. We use the peeling of shaping technique to recover is the cusp flexibility. Yes, get the good cohabitation. Yes, sometimes we use the autologous percutaneous pads to repair is the defect about to recover is the cohabitation, the leaflet. This is the commissural area. We use the plate application. Get the two leaflet is the equal height. Yes, that also is very common used. I think sometimes is we choose relatively at early stage is the choose larger side. I think exists is a central regurgitation. We use the cover stitch to decrease the leave the triangle, decrease the angle, can get the better the cohabitation. I think maybe can modify the central regurgitation. I think this service is the manual. About the commissure is detachment. For type A dissection is very common. I think the one of the two is the commissure is the detachment. I use the Dacron is the 3 plate reinforcement to recover the retest is the detach the commissure. Get the very strong is the durable is the reconstruction is the use the David procedure is get. How about the chronic? Chronic is commissure detachment is a much more challenge. I think we use we can find it. Dacron is the path we can use. I think that is a chronic is the commissure detachment. I think the Dacron path is the 2 Dacron paths. I think from the is nadir is the sinus is the coronary sinus to reinforcement and is the pull out is the commissure detachment commissure. I think the actually equal is size with the another 2 commissure is the height. Can get the very is the good is the durable is the long-term result. About is reduce the cost of mobility, especially is very common for the bicuspid aortic valve for the RheumaticAortic is the procedure. I think is the release with the RheumaticAortic is very important. I think sometimes is do the RheumaticAortic resection. I think is that is RheumaticAortic. We use the very sharp is the coronary is the sharp knife to is the resect is the calcified. I think is the recovery the mobility is very important. How about is the test is the leaflet is the result. Do the water test through the direct observation. We can observe the cohabitation and is the effective the height. I think it's whether or not the 3 cuts is cohabitation is the equal in height is very important. If the not equal, we can give the further is a repair. The further confusion test is just the Dr. Chen is already used the crystal solution to testify the cuspal is the good. I think is we can not only is the touch in the tension of the graft. I think is a touch in the left ventricle is the feeling degree is very important. I think is a direct observation. Use the TTE observation is whether or not it has the aortic is regurgitation. The color Doppler is very important. If we do the echo, doctor find the significant the color Doppler signal, I think it's release the clamp and give the further is repair. I think at the dark area, no any is the color Doppler signal finding. I think is the good. That is echo is much more is better than the water test. I think about the cohabitation height. I think it is Germany is the safest is the height 1 is the height 2 is very important. But from the clinical is the practice we found that for some of the normal patient is the height of is less than that. I think is the no regurgitation. We think is the equal height above the 3 is the lift rate is very important. Not absolutely is the value is the higher than that is the 5 and 9 is the millimeter. I think we introduced this several is the special cases. The first one is the bicuspid asymmetric is the bicuspid is regurgitation, moderate to severe regurgitation. I think we use the TAVR-1 cuspid reconstruction. Yes, recovery is the 180. Yeah, get it very good is the result. This is type 0. Yeah, I think the commissure is thickening. We use the sharp knife is the cut off is the bulky is the tissue. Recovered is the leaflet is flexible. As use the plate, use the diaphragm pads to recover the commissure is the cohabitation. They should do the water test is the no regurgitation. This is case 2 is the Takayasu is the disease exists severe aortic regurgitation. We also use the TAVR-1 is plus the aortic the valve repair. Yes, I think we can find that the aortic root is frozen. We use the stopper is the cider to cut off I think is the bulky is the aortic valve. Use the Bovie to is the seeing is the secret is the aortic valve. I think is the get the deep the dissection onto is the annular. Do the routine is the suture is around is the aortic annular. Sometimes the commissure area may be thickening. I think is the existing commissure regurgitation. We use the autologous is the patch to recover is the good cohabitation. I think is the echo is the trees regurgitation. Yes, the pathology examination is the chronic is the inflammatory is the changes. About the result, 1 patient transferred to the bento procedure. 5 cases is the type A dissection die of the hospital due to the multiple organ is the failure. I think from the aortic regurgitation after operation, I found that majority is the patient is the no regurgitation. Yeah, I think is the maybe some of them is the trees and mild is moderated is not acceptable. I think I give the short is the discussion. I think the annular plasticity is the plus the cut repair. I think converse the TAVR procedure. We can find that any other is the modified is the method. I think it compared with the TAVR-1 procedure. I think the TAVR-1 procedure is the best. I think that is the dimension about the aortic root is the anatomy. I think it's a very deep is the understanding about the aortic root. We can get the deep understanding. Guarantee the long term is repair, durable is the result. This is the about is the modified is the simplified is the remoting is the method. I think it's the Germany is the safest. Use the zero is the suture is the suture line. Gore-Tex suture line. Another the Lancet from the France is also use the aortic vessel is the belt reinforcement is VAG. I think compared with the TAVR-1 procedure, I think it's the TAVR-1 procedure can get the long-term the durable result. This is the modified is remoting is the method. I think that is the indication operation is suitable for the aortic root is the less than is the 40 is a millimeter. we can use the simplified remodeling is the method. This is we can decrease the VAJ and SDJ. Use the artificial is the belt. We can reinforcement the VAJ. I think it's for majority patient is result is the good. About is the TAVR procedure indication. I think is at early stage just 1B suit for the TAVR procedure. I think we can through the practice we can broaden in the indication 1A, 1B, 1C. I think also is the type 2 is the Patient-Prosthesis is suitable for the TAVR procedure. So called is the one key can open is the different drugs. Okay, thanks, Professor Wei-Hsian's invitation.
Okay, thank you, Dr. Gu. So you're, I think you're very skillful surgeon, and you present so many different kinds of repairs. It's quite amazing, and we probably will have some discussion later on. So next topic will be conducted by Dr. Professor Zhang Haipo. He's the chief of cardiac valve surgical center of Beijing Anzhen Hospital. He also has done he has done a lot of surgery, different kind of surgeries, and he's very experienced cardiac surgeon, and also he is a specialized in valve repair, and also has done a lot of TAVI procedures and AF ablation. So the topic will be given by Dr. Zhang Haipo, will be the Ozaki techniques for aortic valve reconstruction. Thank you. Dr. Zhang Haipo. So are you able to start now?
Okay. Thanks a lot. I know that for the aortic repair, actually it's a little challenge, and Professor Gu just shared his experience about the TAVR-1 procedure plus some very hard cases for the aortic valve repair. But not every center, not every surgeon can do like the Professor Gu. So we all know that the aortic valve works and physiologically has some function. And almost 10 or 15 years ago, Dr. Ozaki from Japan has published follow-up data about the Ozaki procedure. And from that time, Europe and US started interested about the Ozaki procedure. In China, Anzhen Hospital is the first one to try to use Ozaki procedure. Just in 2016. 8 or 9 years ago, and we published some data about the follow-up, and also has organized some training program focused on the Ozaki procedure. The simple is the step is not complicated. Use the auto pericardium and use breathe very high, and use 10 minutes, and after use setting of water. And also remove all the 3 or bicuspid leaflets to measure annulus use a very special instrument by Dr. Zati. And also we use a pericardium to cut the outer pericardium like the leaflet. The next step is to use sutures to reconstruct the 3 leaflet. Reconstruct 3 leaflet, and when you do the annulus sutures, usually from start with 3:1 ratio and change to 2:1 ratio and 1:1 ratio. So that one we can put the pericardium leaflet and make the new sinus, and last to reconstruct the information 3 conditions. So finally, when you can get a very long gravitation of the three leaflet and with strong commissure. This case is a Andrei castrate case, and we use Ozaki procedure, and also we use the stenosis and the bicuspid, and after the operation, it's no regurgitation at all, and the velocity is very good. The measurement of the accuracy is important. This one is in our compare if you measure the too small or too large. The gravitation is enough. It's too big or too small. It's also not good for the proactive. And for the regurgitation, the velocity, if it's too small or too large, the velocity is not worse than the normal size diameters. From the Aortic procedure has followed up more than 10 years, and very impressive, very good result. After 10 years, freedom from the reoperation rate is 98%, and also the gradient within the normal, and very good long-term follow-up. And this is the 10 years, and right now, in the beginning, we tried to use just the reconstruct with one leaflet by Aortic procedure, but that's not good because pericardium is not as soft as the self leaflet. So right now, we also to remove all the three leaflets and to reconstruct with the three leaflets. And another follow-up is more than 10 years. Actually, it's more than 1,000 cases of Aortic procedure. The free of the reoperation is almost 96%. And the learning curve should be about 20 cases. And there is some other experiences Asian hospitals research about compare different kinds of pericardium. So why the long-term result is good and almost no cavitation? Because it's a very big orifice and a very good gradient and very good even a longer cavitation. And the leaflet, the mobility is very good and no sutures at the leaflet at all. And when we turn back of the aortic repair, especially for the pericardium patch technique. Actually, it's some it's still controversial because the patch actually get a long-term reduction not good because of the worry about the classification. For the Aortic procedure, it's different. It's used only the annulus has the sutures. But the leaflet do not have the mobility part, do not have the sutures. So this is Dr. Schubert. Dr. Schubert has a topic. They also cited believe the pericardium patch for the repair is should be careful. And for the aortic valve repair, it's actually it's different aspects that different. So that's why the guideline. We all know that aortic valve repair, the guideline suggests the level has changed because of some centers, some surgeons have good result. Some centers, some surgeons do not have the good result. For the aortic repair, some research about how to make the model easily, and from Charles Turin and some centers in Asia countries, China, Korea, and Japan. Also, 3 groups try to use pericardium to make it easily. Actually, in the history, in the 90s, Dr. Patista tried to use pericardium and get actually it's relatively good. And in his conclusion, make a very big gravitation can make a long-term result. And Professor Dubreuil has made some, actually it's a complicated one to try to compare. Use a pericardium, and it looks like something like the Osaki procedure. Use pericardium and to reconstruct the condition, and we also try some rheumatic and aortic stenosis. Osaki procedure has been used in not only in Japan, also in other countries. This is our synthesis result, and we can see the international published papers that increased in recent years about the Osaki procedure. And in Japan and also University in Vietnam and in Italy and Europe has 5 or 10, almost 8 years follow-up result. All the results show that the gradients remain stable, and also in America and in England, the Osaki procedure not so many, but more and more surgeons are interested about this easily used procedures, and the results is good. And also in Germany, Dr. Langer compared with the Osaki procedure with tissue valve replacement, and his conclusion is that Osaki procedure, the valve has a bigger orifice and better gradient, and it is in Cleveland Clinic with Japan. Also compared the tissue valve replacement with Osaki procedure, and if the Osaki procedure has more than 20 or 30 cases, the bypass time has decreased. And also some other research about that. And also, Osaki procedure can combine with other cardiac surgery procedures. And for example, in Boston, Dr. Del Nido tried to use a very young child aortic valve repair, and also can use the pulmonary valve reconstruction, and also bicuspid, and also can use sinus allocation and other procedures, and also can use for the endocarditis. So in summary, that procedure actually is very easy to use, and can use for the aortic regurgitation, aortic stenosis, can use the bicuspid liquid, and other proctology liquid. And after the Osaki procedure, no need for the warfarin. Aspirin is good, and for the young child and very small annulus, that procedure can do very well. And because it's very big orifice and a very good gradient, so it's a long-term follow-up is good. So I think that's a procedure should be used in some centers. So thank you.
Thank you, Dr. Yes, thank you for Professor Zhang. Now we have a short discussion for all these topics, and we have several panelists here, and Dr. also, Dr. Jie, you have any comment or questions on these topics?
So this question for Dr. Kuo. Excellent as a surgeon, and all the aortic valve repair so impressive. So I just wondering, so what's the cut of aortic root for David procedure, or just a simple aortic valve repair? Because your data, you say says quite a number of patients that you actually the aortic root is not dilated. So the 40 or 45, what's the cutoff for the diameter for the aortic root before you decide just do a simple aortic valve repair, or you do David procedure?
So Dr. Gu, are you still there? Are you on the line? Gu 教授，Gu 教授在吗？
Disconnected.
Yeah, I think it's okay. Okay, so maybe some other any other question from our panelists?
Professor Wei, do you think the Basava conducive for the David procedure or not?
Okay. In the early years, I used Valsalva conduit for these David procedures, but later on I found that maybe the so-called commercial Valsalva conduit is not very good, since I think that the part of the sinus is too high, too big, and so later on I discarded using Valsalva conduit and I used just straight conduit. Okay, Dr. Gu, you're here now. Oh, you're online now.
I'm
Yeah,
sorry.
but you know.
I'm sorry, Professor. Yeah, I disconnected. I missed your question.
Okay. Yeah, Doctor.
You speak again.
Yeah.
Just your data, you mentioned there's quite a number of patients. There's an aortic root actually the diameter is normal, right? But I think you do quite often the David procedure. So I just wonder what's your cutoff of the aortic root diameter in terms of to do a David procedure or just simple aortic valve repair?
I think that is a very good is the questions. How to is the confirmed what is the size above the aortic root is suitable for the David procedure. I think in our data, I think is over is the 200 cases is the normal aortic root. I think we can is the in China, it's partially in north of the China. I think is the isolation is the aortic regurgitation. Yes, one of the two cuspal polyps is very common. For that kind of patient, majority do the valve replacement for young patient, mechanical valve, or for old patient, tissue valve. But for my practice, we found use the David procedure to reconstruct the aortic root. I think get the better result. I think it's I just mentioned that is the FAA, VAG, STG, and Warsaw sinus reconstruct, maybe a little bit downside. Maybe I think is the we can plus the leaflet application get the good result. I think you may be worried about whether or not after operation exists the gradients. I think from my data, I think is the no significant gradients is the occur. I think do the David procedure. I think compare with the aortic valve replacement. I think is even the diameter is the maybe is the 26 and 24. I think the orifice is larger than the tissue valve and the mechanical valve. I think is this is our data. It's possible for the body size not very large. I think do the David procedure get the very good hemodynamic is the result.
Okay, Dr. Gu, I think that your suggestion of using the graft size of 26 to 30 is the most suitable for, I think, for Oriental people. I totally agree with you, since with the size more than 30 or 32 is probably is too big for Oriental people. This is my own experience. Now I'm using 26 and 28 as for most of my patients. So this experience is probably as yours, right? But you have so many cases. Your series is probably one of the largest, or even the largest series in the world, I think. Yeah, so you're very, very skillful in doing this. And also you have done a lot of repairs for the valve. I think it's also very amazing. I think your result is very good.
Thank you, your kind command. I think the smaller side about the artificial is the 24. I think I mean the largest number is the David procedure in China.
Yeah. Okay. Thank you. Thank you so much. And any other questions?
I have a question for Dr. Gu. Now we know that the graph over the time we will grow about 20%. So if you use a 30 millimeter graph over a year, then you will grow into a 36. Will not take it into account on your selection of the graph for the David procedure? That's the first question. My second question also consider that we know that the graph will use there's some elasticities. So when you put the post, the commercial sutures, do you pull the graph as far as you can, or how do you decide where you're going to put the commercial post? Because that will decide the height of the coaptations.
I think it's a very important question. So how much is the, I think different, how much is the height is the commissure, is the fixation, is very important. I think determine whether or not the three is level get the equal good cohabitation together. I think is the for different company product has the different is the character. For the I think we use the Boston is scientific is the I think that is the artificial is the vessel is suitable for the dive procedure. For the intergout is the front. I think is the very soft. Is the spring. I think elastic too much. I think it's very hard to determine is the height about the commissure area. I think we like to use the Boston type is the I think it's how to determine the concrete is the height commissure area. I think maybe get the equal according to the different is the cusp will get equal side. I think if the one of the leaflet is a little bit is the prolapsed, we can put the height of the commissure is higher, make suit together. I missed the first question. Can you
the first
speak
question
again?
is that the graph will grow about 20% over the time. So will that take into account in you choosing the graph?
I think it's about is the during the follow-up with some is the author is the have suggested during the follow-up is the artificial ratio a little bit is the dilatation, but I think is the for the straight graft is the dilated maybe compared with Wassermann sinus graft is the less. I think that is why is the Dr. Jie Wu from the Stanford he confirmed is the straight is the graft is better than Wassermann sinus graft for that procedure. I think is the even the artificial vessel a little bit is the dilatation. I think is enough the core evidence the height can is the mitigate is the dilatation. I think it also gets the good result. During the follow-up around is the artificial vessel. I think is the connective tissue is the figure is limited in the dilatation continuing. This is my consideration.
Okay, so well, since the time is already too late, but may I have only one short question for Dr. Zhang? When you do the Ozaki procedure, have you thought about the future? Once if it fails, like stenosis or anything else happens, then especially for the stenosis, since the cusp is a higher, right? It's a longer, and you think TAVI can be done for this kind of consequence?
I think it's a very good question. Actually, yes, it's a long leaflet. So in the future, to do the TAVI is a little bit higher risk of the coronary artery occlusion. But we all know, Professor Jie also here, we all know the Jie valve and the second generation of the TAVI valve has a very unique design, has used 3 grassroots, and it can work to avoid of the occlusion of the coronary arteries. So Jie valve works very well for this kind of situation in the future for this kind of patient. So what do you think, Dr. Jie?
I guess yes, Jie valve probably there's some protection for coronary obstruction in this kind of situation. The only things I think there's an issue is when the ST junctions are very small, probably still have an issue with the Jie valve potential. If a ST junction pretty good size, I think that's relatively safe. Definitely not to do another TAVI-in-THV, that's for sure. This won't work. And self-expand will definitely not work. So I think there's some risk for the future. Jie valve probably is the only valve probably can be used for this kind of situation.
Okay, thank you so much. I'm sorry for the late for this session, and we have to proceed to the next session. Thank you. Thank you, everybody.
Thank you.
Okay, let's proceed to the next section. This section is the important issues on valvular heart disease. And I'm Dr. Tien-Ping Tsao from Jiangxin General Hospital. And I would like to introduce our moderators, including Dr. Yung-Tsai. He's a Deputy Dean of Tri-Service General Hospital, also a cardiosurgeon. And the other moderator is Yohei Ono. He's from the Department of Cardiology, Tokai University School of Medicine. And Dr. Jie Li will be joining us online. Dr. Jie Li is from Beijing Anzhen Hospital Capital Medical University. And we also have our participant experts, including Dr. Wei-Hsian Butihari, and he's currently the president of a Cardiovascular Interventional Society of Thailand. And Dr. Kuo-Chen, he's from Jiangxin General Hospital. And Dr. Zhang Haipo, he's from Beijing Anzhen Hospital Capital Medical University. And Dr. Chen, he's from Jiangxin General Hospital. And Dr. Kensel, he's from Prince of Wales Hospital, Hong Kong. So I would like to introduce the first speaker. Our first speaker is Professor Bernard Prendergast. I think he will giving the talk online. He's the chair of cardiology at the Cleveland Clinic London and a consultant cardiologist at the St. Thomas Hospital in Westminster. Professor Prendergast is a national and international key opinion leader and in frequent demands as a lecturer and speakers. And he is the principal course director of PCR London Valves, the world's largest meeting dedicated to the percutaneous valve intervention. Today he's giving us a talk entitled Valve Choices for Younger Patients Undergoing TAVR. Professor Prendergast.
So hello everybody, and thank you for inviting me to provide a virtual lecture for the Taipei Valve Summit. It's a great sadness to me that I cannot be with you in person, but the proximity of your meeting to the New York Valves meeting taking place in the preceding days makes travel impossible. But I hope very much that one day we can be together to share our experiences and our knowledge. This lecture is about the choice of valve interventions that we face for our younger patients. And although TAVI is an increasing option in this population, my lecture is mainly based around some important precautions that apply in particular to this very important group of patients. It's not so long ago that surgery was the only option for our patients with aortic stenosis, and guidelines on both sides of the Atlantic deemed that surgery, particularly valve replacement, was a technically feasible option for any age and any cohort. Of course, in reality, there were many of our patients who were deemed unfit for surgical intervention on account of their advancing age and comorbidities. And we all know that TAVI has been an excellent option to replace surgery for these particularly old and iller patients in the later stages of their lives. For younger patients, however, we face a bewildering array of different options at various stages of patients' lives. And these become particularly important in younger patients as they become more informed of the various options available and wish to express opinions regarding their mode of treatment. And our duties as physicians and as clinicians and as cardiologists is to be mindful of the limitations of the data and our experience, particularly in this young group, in order to guide them through this network and this decision tree in partnership as part of modern healthcare. In doing so, we need to remember that bicuspid aortic valves are more common in younger patients, and our knowledge and our experience of treating bicuspid valves using transcatheter options is limited, as I shall discuss. Secondly, that the durability of our procedures are particularly important in younger patients. And in some of them, we need to plan for 2, 3, or even 4 procedures over the lifetime of their disease. And in doing so, we need to remember that the first intervention is arguably the most important because it lays the platform for future options. In broad terms, therefore, we have a choice of 4 different approaches for our younger patients with aortic stenosis. Valve replacement with a mechanical or biological valve, the technically challenging Ross procedure, wherein the patient's own pulmonary valve is autographed to the aortic position, and of course, TAVI, which is the main topic of this meeting and of this lecture. And all of these options have different pros and cons, as illustrated on this slide. In 2024, however, we need to face the reality that virtually no patient wants to have a mechanical valve, given the long-term implications for anticoagulant treatment. Furthermore, many patients are reluctant or will even refuse to undergo median stenotomy and are not prepared to put their life on hold for several weeks or even months while they recover from a major surgical procedure. And our decisions concerning the index procedure are therefore critical and need to reflect the fact that not every patient is the same and different options need to be considered in different scenarios. That's illustrated by the fact that the age of patients receiving a biological surgical valve has successively fallen in recent decades. And that has been largely driven by patient preference and particularly the wish to avoid long-term anticoagulation. Remember, please, that the evidence to support this transition is minimal and that these changes in clinical practice were affected beyond clinical guidelines at every stage. And this, of course, is relevant when we consider the growth of TAVI in the contemporary era. We also need to recognize that our experience from surgery is that bioprosthetic valves do not last forever. And even if we have the greatest enthusiasm for TAVI, it is inevitable that our transcatheter valves will fail at some stage. Therefore, we need to cautiously incorporate TAVI into the treatment decision discussions regarding this group of patients. And whilst we've all enjoyed the rapid expansion of TAVI and the explosion in growth and the clinical enthusiasm that has accompanied that, it's important that we take stock at every stage before we move forward with this evolution. We know, for example, that guidelines and randomized controlled trial evidence support strong recommendations for TAVI in younger and younger cohorts. Bear in mind, however, that there are different recommendations on either side of the Atlantic, and that's also been reflected in varying application in Asia. But of course, we do have a technology which in skilled hands is very amenable to patients associated with a very low risk of mortality or major complications, and which is extremely patient-friendly and very, very appealing not only to patients, but also to their families. This has resulted in rapid growth across the world, no more so than America, where, as you can see on this slide, that TAVI now accounts for virtually all aortic valve interventions in elderly patients, and as I highlight here, is rapidly moving beyond the guidelines, so-called indication creep, into younger patients lower than the age of 65 years, where in certain sectors of America, almost 50% of procedures are now performed via transcatheter approaches, way beyond the literature, way beyond the evidence base, and certainly outside current guideline recommendations. And this is important because if we return to the literature and examine precisely what we are doing here, we need to recognize that our knowledge is limited. Here are observational data published 3 or 4 years ago by the Cedars-Sinai group in the US, demonstrating that outcomes after bicuspid valve TAVI are broadly equivalent to those in tri-leaflet valves. However, a very important note of caution was sounded very recently when the Notion 2 study was presented at EuroPCR only 2 weeks ago. These are very fresh data, and I will focus on them for those of you who did not hear the presentation or have not had the opportunity to reflect on the findings in detail. This was a study targeting younger, low-risk patients in the Nordic countries of Europe with a mean age of 71 years and a low STS-PROM score of 1.1. These patients were randomized to TAVI or surgery in 1-to-1 fashion, and a pre-specified subgroup analysis was performed in the 25 to 30% of patients who were enrolled with bicuspid aortic valves. The important findings are shown here for the primary endpoint, suggesting that TAVI may well have a small disadvantage in comparison with surgery for the combined primary endpoint of death, stroke, or rehospitalization. This difference was not statistically significant, but nevertheless requires careful consideration. Similarly, looking at the combined endpoint of death or disabling stroke, there was a small numerical advantage in favor of surgery. And when we looked at the data broken down according to anatomy, i.e. subdividing the bicuspid and tricuspid cohorts, you can see that these small advantages favoring surgery were very aggressively driven by differences in the bicuspid valve cohort, where the difference in the primary endpoint was far more marked and very close to statistical significance, remembering, of course, that the number of patients enrolled in each anatomical subtype was relatively small. Similarly, if we look at the combined endpoint of death or disabling stroke, we can see a complete overlap of the survival curves for the tricuspid valve anatomy, but correspondingly an important difference for patients with bicuspid aortic valves, therefore providing a very important note of caution regarding the widespread application of TAVI in this younger bicuspid cohort. It's important to note that all bicuspid valves are not the same, and there are some anatomical subtypes that are more favorable for TAVI than others. And it will be an important goal of future research to explore these differences in greater detail and define the bicuspid valve cohorts where TAVI remains an appropriate treatment option. Looking at other uncertainties, we need to examine our information regarding the long-term durability of TAVI in comparison with surgery, and reflect on the fact that our clinical algorithm will need to be very, very different for patients in their 60s compared with those in their 80s. As I've already said, all bioprosthetic valves will fail for one reason or another. And we have very clear classifications and distinctions between the different pathophysiological mechanisms. This in turn has led to very clear and robust, highly detailed definitions of bioprosthetic valve dysfunction and deterioration, as illustrated here with the widely cited VARC-3 definitions arising from the US Combined Study Group. And as there is now a recognition that structural valve deterioration, like aortic stenosis itself, is a steadily progressive disease associated with intrinsic early changes to the prosthetic valve and its leaflets, ultimately culminating in moderate and eventually severe hemodynamic consequences, which lead to bioprosthetic valve failure and the need for a second procedure. These definitions and these algorithms were recently applied to the NOTION trial, one of the first pivotal randomized controlled trials comparing surgery with TAVI over 10 years ago. And reassuring information came from these investigators recently published in the European Heart Journal, demonstrating equivalent outcomes at 10-year follow-up, and if anything, a small advantage in favor of TAVI versus surgical intervention. Beyond 10 years, we still have very, very limited data, but important results are beginning to emerge from national and international data sets based upon the early clinical experience across Europe and beyond. We know that a second-time TAVI procedure is feasible. There are many registries demonstrating the relative ease of this procedure, but we need to recognize that successive layers of metal in the aortic root are associated with potential hemodynamic consequences, and our rather simplistic notion of repeated TAVI procedures one inside the other may be more simplistic than we originally conceived. We know from the surgical experience that patient-prosthesis mismatch is associated with poor outcomes, and there is no reason to consider that TAVI will be different in any way. We also already understand that access to the coronary arteries can be difficult after TAVI procedures, particularly with TAVI devices with a long stent graft structure. As illustrated here, where an operator was unable to access either coronary arteries selectively and subselective coronary angiography was the only option on account of these numerous layers of metallic scaffold within the aortic root and caging the coronary ostia. We also need to understand from our surgical colleagues that asking them to remove TAVI devices many years after original implantation can be difficult, challenging, and risky. And we therefore need to exercise caution when implanting these valves at early stages in patients' lifetime journey, expecting the surgeons to help us out many years down the line. We need to recognize, as I shall point out in a second lecture for this meeting, that the lifetime journey of the patient begins with the first intervention, when we need to ensure that we achieve perfect hemodynamics, where we leave the patient with a valve that is as good as a surgical valve replacement and allows the option for second valve interventions, protecting the coronary arteries at future stages of the patient's lifetime. We have an array of different procedures available to us that we need to apply in careful, stepwise progression. And it is important that we work together as a heart team to determine the appropriate technical approach for each and every patient. Thank you.
Thank you. I think that Professor Pendergrass is not online, so he's pre-recorded lecture. So probably we can have a discussion between the moderators and our experts. So any comments from our experts?
Yes. In
the old days when the surgeon put in a bioprosthetic valve in a 60 years old, perhaps. I'm not sure they discuss with the patient in terms of the second, third, fourth procedure. And I think most patients might require the second surgery. I mean, 2 procedures. Rarely one might need the third one. So if we can confine TAVI in the more elderly patients, for example, in the 65s or 70 ups, I think the redo TAVI may not be such a problem. In my opinion, 2 procedures would be okay, regardless of what the first valve might be, especially a few years from now when we get a newer generation valve. But you know, third and fourth valve, in valve, it's probably not something that will be easy to overcome.
I think Bernard mentioned a very important point that younger patients, when we tend to treat younger patients, the incidence of bicuspid disease should be higher. Still in Japan, we face majority of the patients are over 80 years old. So in our Ocean TAVI registry, the incidence of bicuspid disease is only around 5%. But we face a little bit younger patients, and if I have checked in the CT scan, if the patient has severe calcification with bicuspid disease, I still send to the surgery because underexpanded valves, although hemodynamically could be acceptable, has a chance of leaflet thrombosis, and eventually the valve durability could be a problem. So I think we still need to have a surgical option for bicuspid disease patients, as shown in the recent Notion 2 trial.
Thank you. Dr. Tsai, any comment?
I'm a cardiac surgeon, and in my opinion, I think the age is an issue, but the bicuspid is another issue. So in a younger patient with the bicuspid, in my opinion, I prefer the saver instead of the TAVI to prevent the coming often repeated intervention. Yeah, that's my opinion. Yeah.
We still have some participating experts online, and any question or comment from our experts online?
This is Kent from Hong Kong. I agree with Yohei's comment on the availability of surgery as one of the options, because there are a cohort of patients that's not doing good with TAVR, so surgery is one of the options. So surgical options should be included in the first valve choice. The other thing that I also want to point out is there is actually coming up with some tissue technology that could potentially expand the indication of TAVR, because some of the valve platform that we're using, they're bound to be having a longevity of around 10 years. But with improving tissue technology, the first valve being implanted either transcatheter or surgically could be expanded. So that's one of the things that we also need to think about. Thank you.
Thank you. Any comments? So I think there are more bicuspid valve patients in younger patients with severe aortic stenosis, and the TAVR for this group of patients, the technique is more challenging, and the valve long-term durability is uncertain. So for this subgroup of patient, I think still needs to be considered for surgery. Yeah. So if there's no comment, we proceed to next speakers. Next speaker is Professor Sam Dawkins. Professor Dawkins, he is the consultant cardiologist in Oxford University Hospital and NHS Foundation Trust and the Cleveland Clinical London. Dr. Dawkins is a cardiologist, is specializing in general cardiology, interventional cardiology, and structural intervention with remarkable achievement. Professor Dawkins will deliver a lecture with the title Best Practice of Transcatheter Tricuspid Valve Replacement, EVOKE. And let's welcome Professor Dawkins.
I'm delighted to be joining your conference. It's nice to see some friends on the panel and friends online. So thank you very much for having me. I'm actually in New York, so I'm at New York Valves, and we've had some very nice tricuspid cases here today. And so I would like to share some of my experience in my practice with this technology. So I will just share my slides for you. Okay, so hopefully you can see my slides. Just give me 1 second. Good. Okay, so just to give you some background, so I've trained in mitral and tricuspid intervention during my fellowship in the United States, which I finished 5 years ago, and I came back to the UK and set up a mitral and tricuspid program in Oxford. And we now do around 120, 130 TEER procedures a year, something like that. And around a third of them are isolated tricuspid, around 20% of them are concomitant, so mitral and tricuspid. So we have quite a lot of TEER experience. But as you will know, there is a cohort of patients where TEER isn't an option, and that's usually because of anatomical considerations. So issues such as very large coaptation gaps, pacing leads, for example. Pacing leads definitely do not preclude TEER, but if the pacing lead is actually pinning the leaflet open or is damaging the leaflet, is adherent to the leaflet, then TEER may well not be an option. And so what we have done is we have developed a program where patients are assessed for any transcatheter technology when they come to see us. When I get a referral or when any of my team get a referral, we have a discussion in principle at our heart team meeting. So that's before we've met the patient. And the reason we do that is because then we can have a technical discussion about what might be possible for this patient. And then we can make sure that they see the right person in clinic. So that may be me, that may be one of my surgical colleagues, and we can make sure they see the right person. What we do is after our initial discussion in principle, we then have a telephone discussion with the patient and just understand their burden of symptoms and also to understand whether they're euvolemic, which can definitely be assessed by phone. This is important because if we're going to screen the patient for a transcatheter tricuspid replacement therapy, it is very important that they are euvolemic when that happens, because if they're very overloaded, their tricuspid annular dimensions will be much larger than they really are, and they may well be inappropriately screen failed. So ensuring that they're euvolemic is actually very important. When they come to hospital, so patients in our region do come from quite a long way away, and in fact for tricuspid replacement they come from all over the country, and we don't want to bring them to hospital lots of different times, so we bring them once. So they come to the hospital for the day, they meet one of us, they have a transesophageal echo, they have a CT scan, and we go through the imaging and work out what options might be available to that patient. With transcatheter tricuspid replacement, the planning is detailed, and it requires quite a lot of 3D reconstruction, and we pass on the CT scan. In addition to doing our own analysis, we pass it on to the company who help us with that as well. So I wanted to present a typical patient. So this is someone who, you will have these patients too. This patient, 78, breathless, he's got peripheral edema. Really important to say that a lot of these tricuspid regurgitation patients, as you know, it's not just right-sided symptoms. Breathlessness is really common, and we have plenty of tricuspid patients who only have breathlessness, so they have no so-called right-sided symptoms. So as with many of these patients, they've had many other procedures done in the past. So this patient had a transcatheter aortic valve implantation, he'd had a pacemaker, he had a selection of comorbidities, and he's on the usual combination of medication. Liver function not too bad, he's got some renal impairment, and no great surprise here, his tri-score is high, and so isolated tricuspid surgery really not an option here. So these are his transthoracic echo images. So this is a parasternal long axis view of the tricuspid valve. And what you can see is that there is clearly a pacing lead, which is impacting on the leaflet here. This is the septal leaflet. You can see the pacing lead passing through the valve. And it looks like it's certainly pinning the leaflet, pinning the septal leaflet. Whether it's going through the leaflet or not is difficult to know, but it's certainly involved. And there is torrential tricuspid regurgitation here, as you see. In the apical views, you start to understand a little bit more. So you can see that the pacing lead is going through the valve. It probably is adherent to the septal leaflet. Right ventricular function, the right ventricle is dilated, certainly, but the function doesn't look too bad. And you can see this septum bowing because of pressure overload here from the tricuspid regurgitation. Here, there's quite a lot of shadowing. It's very difficult to actually see where the pacing lead is, but you can see something is fixed here. Probably partly the leaflet, partly the pacing lead. And you can see this is when I'm screening patients for TEER. If you see an eccentric jet, just think carefully about what the anatomy is, because eccentric jet means there is something structural wrong with the valve. This is not simply a secondary tricuspid regurgitation phenomenon. So if you see an eccentric jet, just think what's going on here. The TEE helps a little bit further. So this is a transgastric long axis view. You can see the lead passing through the septal leaflet. And in this short axis view here, you can see the pacemaker lead here. And if we explain through that, you can now understand what's going on. So you can see the lead is essentially drilling through the septal leaflet, and it's actually going through the papillary muscle as well. So for this patient, edge-to-edge repair is really not an option. It's not going to work. This is the baseline CT scan. What we're doing is spinning through the short axis. You can see that on the right, and on the left is showing the result of that spin. And so you can see the pacing lead here. You can see it's going through the papillary muscle, and it's pinning the septal leaflet. And we look at various parameters to understand whether transcatheter tricuspid replacement might be possible. By far the biggest reason for screen failure for this technology is annular dimension. And if you would like a simple rule of thumb, which is, this is not part of the IFU, but it's something we've learned. If any tricuspid annular dimension by TTE is more than 58 millimeters, they are likely to screen fail. And that's a useful thing to know. And so why did we think about transcatheter tricuspid replacement for this patient rather than edge-to-edge repair? Well, the TR is caused by pinning of the septal leaflet. The pacing lead is probably going through the septal leaflet, and it's a very broad jet. The reason TTVR is favorable is because the ventricular function is preserved, the annular size is within range, the pacing lead isn't under significant tension, and the RA height is enough to be able to steer down. And so this patient was sized for the 52 millimeter Evoke system. And I just wanted to run through, this is just a short recording, an edited recording of this case. So you can see the cath lab setup here. It's a 2-operator procedure, largely because of the length of the device. What we do is we take an Agilis steerable catheter. And so what you're looking at here in the left-hand view is a RAO view. And what we do is we push the wire down into the apex. And what it actually, in this case, has done is popped up into the RVOT. So what we do is we pull back the wire and actually hold the flex on the Agilis catheter. And that's the trick, because the Safari tries to straighten the Agilis catheter. So if you hold the flex on the Agilis, then it will go down to the apex of the right ventricle, as it is here. And we can check that in the transgastric long axis view here. So you can see the wire nicely at the apex. It's not interacting with any cords. And we roll the Agilis backwards and forwards just to make sure that the wire is truly free. We then back out the Agilis. We then use this Evoke dilator here to create some space in the access site. This is the Evoke system going in now. Hydrophilic coated, it's very easy to deliver, although it's quite large caliber. It advances actually very easily indeed. And as we advance it, what we're doing is putting primary flex on. So primary flex, if you use MitraClip, primary flex is the septal flex. And if you use Pascal, primary flex is the steerable. So if this is steerable, you're steering down with the primary flex pointing down towards the RV apex. Now the device looks quite large, obviously, as you can see, but actually it steers very easily, and it's just interaction between the first and the second operators steering down, gently shortening the wire to encourage the device around the corner. And much like Pascal or MitraClip, we're looking for that kind of position on fluoro, so pointing down and right. And now what we're going to do is set up the MPR, the multiplane reconstruction. This is really the key to these procedures. So we use multiplane reconstruction throughout to understand where the anchors are and to make sure that the anchors are on the right side of the valve leaflet. And if you can get your head around that, then you understand the whole procedure. And we'll talk through that in just a second. So the first step of this procedure is to reveal this gap here. So what we're doing is winding back the white knob here, which is the ventricular release, and revealing the capsule gap. So the capsule gap is the reason we talk about it is because it's the point at which you can still retrieve the device. We make sure that we've got enough height to deliver the device. Once we're happy with that, we do a timeout at that point just to make a full assessment. We then release the anchors. So that's what we've done now. You can start to see the anchors here. And what we're doing is using this view, which is AP, anterior on the right, posterior on the left. This view, which is septal lateral, septal on the left, lateral on the right. And at the bottom is a short axis view. And what we're trying to do is we're trying to reveal these anchors and have them just under the valve leaflets here. We don't want them too high because then you're risking not capturing the valve leaflets as you deploy the device. And we don't want it too low either, because if it's too low, you run the risk of entangling with cords. And so what we're doing here is just getting set up to assess exactly where we are to make sure that our position is right. And you can see that Jim Newton, my imaging colleague here, is just tweaking the multiplane reconstruction constantly just to make sure everything is where it should be. So as you'll see with this procedure, there are lots of points that you pause. And so what we're doing now is doing our first spin. So if you look at the crosshairs in the bottom left here, what we're doing is rolling it through each anchor. And then we're looking here at the right-hand side of the top left-hand view. And you can see the leaflet is captured here. And what we do is we roll round each anchor one by one, and we work out whether each leaflet is either captured, ready for capture, or pinned. And obviously, you're also going to have some leaflet or some anchors that are in a commissure, so there's no leaflet there. Having one anchor missing leaflet is fine, but having two in a row is not fine. And so you'll have to optimize the height or the trajectory to fix that. Once you're happy with the height and you're happy that the leaflet is on the right side of the anchor, you can continue the release. So this stage is called flipping the anchors. So now you can see the anchors are pointing up if you look at this septolateral view. This AP view here. So you can see the anchors are pointing up. And as you get to each stage of the procedure, you pause and then you spin again. So Jim is setting up for another spin. So he's setting up the MPR directly over the device. And once he's happy with that, he's going to spin around each anchor. And I've shortened this for the purposes of the video, but at each stage, we're doing another spin just to make sure that the anchors are on the right side of the leaflets. And here you can see the leaflet very nicely resting over the anchor. And what matters here is when you're doing these spins is that everyone is looking at the same thing. You get very easily disoriented if the communication isn't good at this point. So Jim is now rolling this crosshair through each anchor, and we're all looking at the same place. So we're all looking at the right-hand side of the left-hand image up here. And we're just looking to see each anchor one by one to make sure it's captured. And we're also looking at the height of the anchor relative to the leaflet. And what we want is we want the anchor to be nice and high. So we're continuing with the ventricular release now. So you can see that the majority of the device is exposed. And what is nice about this procedure is there's really no hemodynamic disturbance. It's very, very well tolerated by patients. Nothing much happens to the blood pressure. It's all extremely well tolerated. You have a little bit of ectopy from time to time if you're interacting with cords, but apart from that, there's really no hemodynamic issues whatsoever. And so we're just, once again, doing a spin. Again, I've shortened this one for the edit, but we're doing another spin to make sure that the anchors are where they need to be. And we're just gently tweaking. This is just to show you the controls. Primary bend here, so this is flexing AP. Secondary bend is here, the darker gray knob. Secondary bend is flexing septal lateral, so correcting septal hugging. And then the black is depth, so that controls the Z-axis. So it simply makes the device deeper into the ventricle or shallower into the ventricle. And so now we're just completing the ventricular release here. So I'm just continuing to spin the white knob there, and the ventricular release is continuing. One thing that sort of struck me when I was editing this video was during the procedure, I didn't even think about the pacing lead. It's interesting that, isn't it? You know, in TA, you think about the pacing lead all the time. In this procedure, it just goes where it wants to go. You don't have to give it any thought at all. I didn't think about it at any point during the procedure, which is quite a nice feature of this technology. So now we've finished the ventricular release. We're just checking our trajectories are still good, and we're checking that we're high enough. So you can see that the anchor is nice and high and touching the leaflet here. And we're now doing the atrial release. And if you watch here, it's all actually pretty anticlimactic. You know, you've done all the investment now. You've set the trajectories, you've set the height, everything is looking nice, and you just gently spin. And then before you know it, the device is released. And when it's released, you know, the hemodynamics are very, very, very stable, and you go from having torrential tricuspid regurgitation to having no tricuspid regurgitation. And that happens in a matter of seconds. And once you've finished the atrial release, you just generally take off your various bends and retrieve the device. What we tend to do is once we've got the device out, we tend to put a pigtail over this wire to retrieve it, because obviously we don't want that to interact too much with the valve. So we're now just centering up the nose cone because we don't want to interact with the valve as we retrieve the device, and then just generally come back and unflex everything, bend by bend. And so that's what we're doing there. So we take off secondary bend first, so the secondary bend coming off there. And then we take off primary bend and remove the device. And so just to show you the final result, this is the catheter going through the valve there. You can see the pacing lead pinned outside. You can see there's no tricuspid regurgitation, just a tiny, tiny paravalvular leak there. Here's a short axis view. Again, looks very nice. This is with the catheter across the valve. Patient stays, our policy is that patient stays in recovery for a couple of hours afterwards, and then we take out the arterial line, send them back to the ward, and this patient went home after 48 hours. This is the follow-up transthoracic echocardiogram, so you can see pinned pacing lead, no residual tricuspid regurgitation, and just to put pre and post next to each other, so spectacular tricuspid regurgitation on the left, no tricuspid regurgitation on the right. And so this is a really nice technology for patients where edge-to-edge repair or other technologies are not suitable. It's very effective. It's a very sort of structured algorithmic procedure, and our experience is that we've had some very nice results. So I will stop there. I'm very happy to take any questions, and thank you very much for the invitation to speak.
Thank you, Professor Dawkins, for your excellent talk and a good demonstration of the this procedure, TAVR. And because we are running late, and Professor Yin and Dr. Lee are ready for the lab demonstration. So can we just move to the hybrid room? Thank you, Professor Dawkins, for your excellent talk. Thank you. Hi, Professor Yin. Hi. You are online. And before your case, I would like to introduce our moderators and experts, including Dr. Tsai Lee and Dr. Yung-Tsai Lee and Dr. Jie Li and Dr. Wei-Hsian Budihari and Dr. Zhang Haibo and Dr. Chen and Dr. Ken So. So can you introduce your case?
Hi everyone, I'm Dr. Yin from Chun-Ting General Hospital. To my left is Dr. Yung-Tsai, who is also well known to you. And on my right-hand side is our technician, Shih-Hsien and Liao Jialing. They are also very familiar with the procedure now. Because we have many mitral surgical cases. So when this valve failed, in recent years, we tend to do a transcatheter approach, mitral valve replacement to fix the failed bioprosthetic valve or surgical bioprosthetic ring. We have done more than 100 of these cases, and recently we have been assigned as the teaching center of this procedure. Today, we will have a more complex case because the patient have both valvular and the paravalvular leakage of failed surgical bioprosthesis. Please show the case first, Dr. Liu.
Okay.
Dr. Lin.
Okay, thank you. Next will be the case introduction for today's mitral valve involved live demonstration. Next, please. So today our patient is an 81 years old man who has suffered from disc renin insertion for several months. He has history of he underwent mitral valve replacement with Medtronic Hancock 2 31mm valve and tricuspid valve repair in 2007. And from now on, he suffered from a mitral bioprosthetic failure with severe valvular and paravalvular leakage. His comorbidity including the right total hip replacement and several appendectomy operation history. His STS score is 7.7 and CAS frailty score is 0/6. His creatinine is about 2.1 milligram per deciliter. His chronic kidney disease stage 3 status. So next, please. We will see his echocardiography. Now you can see that the long axis view and the four-chamber view also confirm a flail leaflet and a severe para and severe mitral regurgitation. The mean gradient of the mitral valve is 8. The peak gradient is 22 millimeter mercury. So next, please. The pre-procedure CT analysis shows the mitral valve area is about 640 millimeter square. The diameter is 28.5. And the predictive near LVOT area is 204 millimeter square. And the stent strut to the LV septum length is 3.4 millimeter. And the patient aortic mitral angle for our patient is 115 degrees. Next, please. So today, according to the CT analysis, we estimate we will cross the interatrial septum about 3 centimeters above the mitral bioprosthesis. And next, please. According to the valve-in-valve mitral app, the Hancock 2 31mm valve, which true ID is about 26, and the stent height is 22. It's a non-fracturable valve. Next, please. So today, our plan to do our main access will via the right femoral vein. The temporal pacing wire will access by the left common femoral vein. And we will put a cerebral and body protection device via right radial artery. Because of severe paravalvular leakage, we decide to which west side is more than 5 millimeters. So we will put a vascular plug tube to occlude the paravalvular leak first. Then we will do the mitral valve procedure with a 29 millimeter SAPIEN 3 valve with full volume over. Thank you.
Okay, would you please show the echo, pre-procedure echo?
Okay. So can you see on the screen?
Please put on the main screen.
Okay.
Yeah.
So this is the 3D reconstruction before the procedure. We can see there's a defect over the 1 o'clock to 3 o'clock. And oops. So under color, we can see there's a paravalvular leak over 1 to 3 o'clock. So we use the multi-plane reconstruction to measure the diameter and the west of the paravalvular leak. So its leak is about 6 millimeter in west and 14 millimeter in length. So according to this measurement, we decide to choose a 16 VP2 occluder plug for this paravalvular leak. So
okay, let's show the procedure until now. Firstly, we implant the cerebral protection device via right radial artery. And then we did the coronary angiogram, which was normal. Next. Next. And then we use a safari wire for anchoring because it is a septal paravalvular leak. Even with the use of previous one, even with the use of Angelis catheter, it is still very difficult to overcome the angulation beneath the valve. So we use safari wire for anchoring, and then we use JR catheter through the Angelis and beside the safari, make the tip direct to the paralytics, and then we can get through the PVL easily. And then we did a AV loop by snaring the thermal wire up to the, which was up to the ascending aorta. Then through the AV loop, we advanced the delivery catheter next for the paralytic occluder. And then we deploy the occluder. To our experience, if the diameter or width of the PVL is larger than 5 millimeter, it is almost impossible after to seal the leak, even with implant mitral valve. Some operator will do break to increase the diameter so as to seal the PVL. But in this patient, because the surgical valve is Hancock 2, it is not fracturable. So we decide to deploy the occluder before the TMV. Here is where we are now. So next we will deliver the transcatheter valve.
Dr. Yin?
Yes.
Hello, this is Yo-Hei. Thank you so much for your beautiful case. So please proceed with the procedure. And can I ask you a quick question? So for patients like this case who has a valve failure plus paravalvular leakage, as for the procedure sequence, do you always prefer to close the leakage first and then for the valve replacement?
It depends on the size of the leak. Because it is much easier to do occluder before implantation of the valve.
That's right.
Because when you put the valve in, sorry, I assembled the device.
In this case, if we put valve first, and it's got very difficult to push everything into the paralytic cage. So that we decide to do the paralytic cage first. And also we talk about the previous, this Hancock 2 is non-fracturable valve. So it's, if we over-dilate the valve, it still have a paralytic cage over there. In our experience, that in this situation, even after break, the paralytic cage still have remain some. So we do the paralytic cage first.
So if the leak was less than 3 millimeter, saying 1 or 2 millimeter in size, you don't have to put a occluder in, because the expansion of the transcatheter valve will just seal the paralytics. Okay.
What size of the valve?
29.
So what is the balloon you use for the septostomy?
14.
14, okay.
OK， 好了，我退 push。push， 小心，还有一点 interaction。Yeah, we have to practice this very carefully because it is hard to.
Professor Yin, if this is not Hancock, the other flexible valve, would you do the occluder first, or you try to put the valve in and then see the result?
Was that pull back? Okay. Sorry, we just finished the procedure, then we do the discussion. Okay.
配线预备，配线哦。
那个要准备要逆时针，可能要上来一点，回来一点，逆时针。好，小心看 distal， 顺时针一点。好，看底下那个圆有没有在上面哈。再逆时针一点，逆时针一点，逆时针一点。好 ，all the way up。哦。OK。
配线哦。
OK。Yeah, sure.
Okay, perfect.
好。
配线哦。
踩啊。
Pacing off.
OK, pacing off.
收电。
OK， 小心，铺背的时候慢一点。
对，停，外，留这外。
Please show the result of on T, Dr. Lin.
Here will be his 3D MFAS view, array MFAS view of this patient. And okay, so there was no valvular, only minimal valvular MR because there's still, I think there's still wire in the
wire is not out.
Yes, and also there's the paravalvular key has a complete seal by the occluder and after the valve MR procedure. So I think it's a very good, excellent result for this patient.
Please check the pressure gradient.
Okay.
And the LVOT pressure gradient.
Yes, for 1 minute.
These two.
The mean gradient of the mitral valve is only 2 millimeter mercury. So the LVOT, just wait for a second.
OK， 再上去。好了吗？哈 ，OK。We measure the area pressure. As you can see from the T imaging, there has been only minimal, I would say, or even no valvular or paravalvular leakage left.
Can we show the LVOT?
Yes, now it's the LVOT color Doppler. I think there's no acceleration of the flow, and the LVOT gradient would be
Okay, no gradient in LVOT.
Yes, no obstruction, and the mean gradient is only 2 millimeter mercury.
2 millimeter.
Peak is 4.
Okay. Before the procedure, area pressure was 8, and now it was 2. So I think the result was really good. To our experience regarding the paralytics, if the size of the paralytics is below 3 millimeter, you don't have to treat it because the expansion of the valve, transcatheter valve, will reduce the diameter. Will expand. We expand the diameter to 1 or 2 millimeter. Just sear the paralytics during the procedure. However, if the size of the size of the paralytics is larger than 3 millimeter, it can only be reduced instead of being eliminated. So some operator, if the valve is fracturable, they will do balloon fracture to then to implant a bigger valve so as to sear the about 3 millimeter paralytics. However, if the size of the leak is larger than 4 or 5, it is almost impossible to do anything on that. So in that case, as this case, we will do occluder before the implantation of the transcatheter valve to treat both conditions simultaneously. That's our strategy up to now. We have done, I think, more than 15 such cases and all successful.
Dr. Yin, I am Dr. Tsai. Again, Dr. Yin, I am Dr. Tsai. Do you think the paralytic area is an issue for you to do such a procedure? I mean, if the paralytic area is too large.
Oh, you mean the paralytics is too large?
Yes.
You may have to put more than 1 occluders. The largest number we put was 4 occluders. If you want to do all the procedure transcatheterly.
Fantastic.
Dr. Yin, once in here, can you tell us how do you choose the occlusion device and how do you size them?
Well, in our center, we classify the paralytics into 3 types: the ovoid or elliptical size, but it is small and straightforward. Then 1 occluder can fix it. Usually, you choose an occluder with a diameter about 1.5 larger than the measured diameter of the PVL. Then usually 1 occluder can work. If the shape of the occluder is crescent shape, then you may need to use if it is not so large, then you can use a occluder about two times in diameter. Then because the occluder is a mesh, it will just expand to fit the anatomy of the crescent defect. And then you can probably finish the case with 1 occluder. However, if the gap is big, as mentioned by Dr. Tsai, more than the size, that's the usual size of the occluders, then you should plan to put 2 parallel occluders beforehand, because it is really dangerous to put the second one with the first occluder in place, because the second the device may push or dislodge the first occluder. So in that case, you want to put 2 occluders, then you just put 2 systems and the 2 delivery devices, and then parallelly you deploy 2 occluders. Then you can fix the large crescent defect. So this is our usual approach for your reference.
Thank you.
So, Professor Yin, this is Haibo Zhang,
Yeah.
Angel Hospital. Yeah, very good cases. I have a question about the, I noticed that you have do the post-dilatation after valve implant. So you routinely use the post-dilate for this kind of mitral valve? Thank you.
Sure, because SAPIEN valve to some extent will recoil after the first deployment. So usually, even with the same volume, we will do post-dilatation to make it more fit to the surgical bioprosthesis. You can get a even better configurations and better sealing of the valve or valvular leak.
Okay, maybe better the gradient of the mitral valve, right?
Of course.
Okay, so second question about the new LVOT. For this case, it's more than 200. It says okay. So which one is acceptable in your center? Is 160 or 150, 180? So different centers have different experience. Thank you.
Yeah, before we start with the Lapun procedure, usually we give up if the near LVOT measured pre-procedurally is less than 190. That's the measure from the stem frame, the distal end of the stem frame. However, after we apply Lapun procedure to all the so-called high-risk patients, we have done more than also 15 cases, and 8 of them were mitral valve in ring, and the 7 of them were mitral valve in valve. And all after Lapun procedure, we can implant the valve without compromise the LVOT pressure gradient. Only in one case, the near LVOT was 67 only. In that particular case, after the procedure or after valve implantation, the LVOT pressure gradient was 30. In that case, I think if we want to do more, maybe we have to treat the septal hypertrophy by such as ablation or sesame or Li-Wen procedure. Yeah.
Okay, so maybe after Lapun procedure, most cases can do this kind of procedure.
Yeah, we modified the Lapun procedure from the original version. That means the base to tip Lapun. Because surgical bioprosthesis protect ring to protect the AV connection. So it is safe to do procedure from tip to base. So with tip to base Lapun procedure, we can almost very safely to do the procedure without injury to the surrounding tissues.
Okay, thank you.
Thank you.
Okay, so congratulations to the exceptional procedure and beautiful results. So for the sake of time, we would like to move on to the next live case. Thank you so much, Dr. Yin, Dr.
Thank you very
Lee.
much for your participation to this meeting.
Thank you. So we would like to call Beijing Anzhen Hospital, Dr. Tsang.
Yeah, actually, I'm sorry it's not live, but some cases from a slide.
Okay, so thank you so much for joining, and please start your share your recorded case whenever ready.
Okay, so can you see my slide?
Yes.
Yeah, I'm going to share about the TAVI cases about the pure AR. I'm from Beijing Anzhen Hospital. We all know that in the beginning, actually for the artificial valve, transcatheter valve animal experiment, the valve is implanted in the aorta. It actually looks like a pure AR, no stenosis at all. And for the Medtronic valve, the core valve, in the beginning, it's also the same situation. It's not anchored in the stenosis part. After 2002, 8 years later, the pure AR cases was performed with transcatheter treatment with the TAVI and has a good result. But in the next decades, we can see that the first generation of the transcatheter valve, the result is not good. But the second generation has a unique design. It's different from the first generation, has a better result for the pure AR cases. And in Europe, the ENA valve, and in China, we have the J valve. These two kinds of transcatheter valve, it has different design from the first generation. Right now, both of this valve has a transfemoral version, and
the trial is I think finished, and maybe next year they're going to be commercial available in China. Last year, 2023, in China, we have organized expert conferences for the transfemoral artery for the pure AR in China, especially for the small annulus and the small aorta, small LVOT, and we can do something for the transfemoral, use the first generation of the artery. In our center, we tried some cases. It's not not good for the open heart surgery. First one is dissection. Old patient, this, the annulus is 25, the LVOT is 23. Usually, if the LVOT is smaller than the annulus, it should be okay. It should be safe to do the transfemoral TAVR procedure. That's it. How we did it with China made the water flow transcatheter valve, and that's how we do it. Actually, the result is good and almost no leakage at all. And the second case is also after dissection, stent implantation, and this one also very fragile, cannot accept for the open heart surgery, and we use and also there's still some dissection in the abdominal aorta, so we use subclinical method to implant the valve. Because the patient is serious condition with intubation, so cannot go into for the CT scanning, and we use the pre-dilatation with a balloon side, and the echo this side we use 30 size of the valve, and this is how we put from subclinical way to implant the water flow valve. These are pure AR cases, and the result is good. And another case is also very serious condition, very old patient with a pure AR, and cannot accept for the CT scanning. Also the same situation, how we do it. And in China, we have the Jie valve. The first one, some cases is the very big annulus. For example, for this one is the annulus is 29 millimeter, and the biggest size of the Jie valve in China is 29. So for this patient, the annulus is even bigger than the largest Jie valve. So we made some modification when we preloaded the valve into the shells. We use 3 patches, the metal patches, and so the stent, and then we preload into the cells. Because it's a transapical one, so we have some chances to get some modification. This is how we put the small patch on the surface of the stent, and then we load it into the cells and to do the TAVR procedure. The implantation is from the transapical one, and the procedure is same as a normal one, and the result is good. So another case is it's a very hard dysfunction. The airway EF is 30%, and the severe aortic regurgitation, and the annulus is even bigger. It's almost 32 millimeter. So we still had to use 29. So it's a big challenge. So for this case, we not only put the 3 patches on the surface of the stent, and also we use the 3 burning sutures to anchor in the stent, 3 sutures. And this is the photo after we preload the modification of the valve, and then we do the transapical procedure. After procedure, result is good. And this is how Professor Yung-Tsai in Zhejiang Hospital also do some cases like this. For Jie valve cases, we also do some very serious condition for the AR.
This is one we do for the from the transfemoral one, because the aorta has some angles is quite difficult. This is how we do it with a Landquest super stiff wire, and use transfemoral wire to finish the TAVR procedure. The result is good. But another one is super challenge, and we can see it as thickness angle is very difficult to do the transfemoral one. So we decided to use transapical one to do the Jie Li. This is how we do the pigtail. It's not easy. Transapical one, I use a Landquest, the super stiff wire, and only anchored as a arch, and not into the descending aorta. This is how we do the Jie Li for this pure AR cases. And also the second generation of Jie Li is transfemoral one. For this patient is a very old patient with AR, and we use and the annulus is 27, and the LVOT is almost 29. Actually, it's not easy to use the transfemoral with the first generation valve. We use Jie Li, the second generation, has 3 respirators valve to anchor the valve. This is how we did it. This is a transfemoral one, and going to the arch, and going into the annulus. And also use the 3 graspers into the 3 sinuses, and the valve down into the annulus, and deploy the valve, and no need for the rapid pacing. This is release the valve, and the result is good. So another hard case is it's a small old man with pure AR, and also for the thorax lung is very strange. So it's very hard to use the transapical one for the AR, and also for the aorta, very big angle, and not easy to do the transfemoral one. You can see it. The aorta is very strange. So finally, we after CT scanning, we decided to use a subclean way to do the second generation of the Jie Li. This is how we do it from the subclean way. This is the aortic root, and then it's also use a Landquest, the super stiff. Use sense here into the arch. This is a Jie Li. This is after implantation. And also in China, for the pure AR, also has some other valve. Finish the clinical trial, maybe in the next 1 or 2 years is commercial available. We call it it's a K valve. It's a transapical one, and also has the X-core. X-core is another very unique design from the transapical one. It deploys the big thin, and then the annulus and the LVOT. So for the pure AR, it's a challenge for the TAVR procedure. And if you have the second generation of the valve, for example, the Jie valve or King valve or inner valve, it's excellent better results. It's for the small annulus and LVOT, and you can use first generation valve, and but you should prepare for the second valve implantation, and also use the surgeons for standby. And usually the AR patient, we should be careful, and not like the aortic stenosis. If the patient, the AR patient, has a heart failure, it usually takes longer time to recover. Okay, that's all. Thank you.
Thank you, Professor Tang, for your. We really appreciate your expertise in this field, for sharing the nice cases. We learned a lot. So, any comments from the panels? So, I think you have experienced a lot of devices for AR, and each device has, I believe they have recommended oversizing. And so far, how is your experience with the post-procedural AV block and potential need for a pacemaker?
Yes, you're right. If you use the first generation of the transcatheter valve device, you really have to make a bigger oversize. Sometimes the 15% oversize or 20%. So if the depth into the annulus is okay, because it's 0, 2, or less than 4 millimeters, usually the AV block is okay. But if you a little bit deeper into the left ventricle, the AV block should be careful. In my opinion, maybe 15% or even 20%. So if you use the second generation, for example, the Jie valve for the pure AR, actually it's less than 5%. It's better for the AV block. Yeah.
Thank you.
Professor Zhang and Dr. Tien-Ping from Chun-Ting General Hospital, congratulations. And I just follow the question: have you ever encountered valve migration after the implantation?
Yes, actually, if you do with the first generation of the valve devices, the migration actually is not uncommon. If in the OR you do the pure AR for the first generation devices, it's easily to travel deep into the left ventricle, and sometimes you have to put the second valve. And also, there's some few cases report actually after even 1 or even 3 days later in the ICU and in other places, they still has some chances to migration. So in my opinion, just I mentioned that if you have the choice of the second generation, for example, the Jie valve, it's the first choice. If you do not have the second generation of the valve, you have to use the first generation. You should be careful. Should still has some risk of the late migration after you implant the devices. Thank you.
Professor Zhang, this is Ken from Hong Kong. Thank you for the very nice and also educational cases. I also like the Jie valve a lot, but I have some question on this platform. In your experience, does it work well in very horizontal aorta, because it's actually quite common in the AR patients, like would angle more than 70 degrees? And that's the first question. The second question is, it works very well for tri-leaflet AR. What about in bicuspid ARs? Does it work well or no? Thank you very much.
Yeah, we all know the Jie valve has 3 graspers. If you have the case of the bicuspid, we only need 2 graspers into the sinuses. The third grasper, either 2 graspers into 1 sinus, or the third grasper just between the sinuses. Both is okay, is acceptable. So all we have to do is just make sure 2 graspers into the 2 sinuses. That can make you implant the valve safely. First, the question about the degree, right? The 70 degree or even maybe about that. The Jie valve, the first generation is a transapical one. So the 60 or 70 actually is not hard for the transapical one. So it's better than the transfemoral one. Yeah, thank you.
Thank you, thank you.
Right.
Okay, so Professor Pang, thank you so much for sharing your experience for PUR-AR, and I guess it's time for closing this session. I think we dealt with a lot of important topics, followed by mitral valve and valve case from the our host hospital, then followed by the PUR-AR. So thank you so much for joining, and looking forward to the next session.
It's time to start this session. We are waiting for Dr. Yin, and I'm home from South Korea. We have the panelist, Dr. Wei-Hsian from Thailand, and Dr. Chen, and Dr. Han, Dr. Lee, and Dr. Liu, and Dr. Un. Okay. First, the speaker is Dr. Yin, but he's not available. We have to be, is there Dr. Liu? Dr. Liu? Ah, okay, now. You have to be here. You are first presenter. Okay. The title of Dr. Yin's presentation is Coronary-First Approach for TAVR and TAVR. Okay, Dr. Yin, please.
Okay, dear colleagues, it is my great pleasure to share with you some of the idea regarding doing TAVR-in-THV. As we know, a self-expanding valve at 10 years will have a failure rate of 10.8. And for balloon expandable valve, better data showed at 5 years it was 3.3. So over time, sooner or later, the bioprosthesis will fail. How to deal with bioprosthetic failure? We can do TAVR explantation, or we can do redo TAVR. However, the surgical mortality was really high in TAVR explantation, may up to 10%, and the 1-year mortality of around 25%. If the valve is a supra-annular valve, it is associated with more extensive aortic wall and atherectomy, and you may need to repair the ascending aorta. So in this regard, repeat TAVR or redo TAVR will have a lower 30-day mortality of 6.2, and the total MACE rate reduction will be 2.9. So I think the surgical risks associated with TAVR explant are not negligible. So no matter the physician or the patient, I think in the upcoming 10 years, they will find to seek TAVR-in-TAVR or transcatheter approach to fix the bioprosthetic failure. Considerations in redo TAVR. I think we should consider coronary risk and the hemodynamics first. We all know that risk plan after implantation of a transcatheter valve. In first TAVR, the ceiling skirt height and the leaflet length determine the risk plan. However, in redo TAVR, as you can see, when the second valve push the first valves, the leaflet attached on the frame, it will create a new or near skirt. That means the near skirt height, the risk plan is even higher, almost always higher than during the first TAVR. Another thing is that in doing redo TAVR, usually the second valve will expand the first valve further. That means valve expansion in redo TAVR reduce valve to STJ and the valve to aortic or valve to coronary distance, and this may significantly increase coronary risk, especially in small anatomies. Furthermore, the implantation position matters. If the second valve was implanted higher, you will form a higher or a neo skirt. That means the coronary risk will be higher in that scenario. This is especially true in self-expanding combination. The reaxis, the possibility of reaxis coronary will be lower than 30%. So that's published data. After first TAVR, without coronary alignment, up to 46% of patients will encounter difficulty in coronary reaxis. And during second TAVR, 23% will encounter the problem of sinus sequestration, and after second TAVR, up to 78% of patients cannot have successful coronary reaxis. On the contrary, short valve with risk plan subcoronary allows for future coronary access. That means if you choose a short frame balloon expandable valve, the coronary reaccess rate can be as high as 78 or 79%. Lastly, put them all together, we should consider aortic root anatomy and the interaction between the valve you choose and the valve combination you use. If the aortic root anatomy is big, the coronary height is above the neo skirt, and the root is big, and the STJ is wide and the VTC is large, then no matter which approach you do, there will be no coronary issue. However, if the coronary ostia is below the neo skirt, there will be some risk regarding coronary access. And in this scenario, the outcome depends on the aortic root anatomy. If the anatomy is big, even in BEV in BEV or SCV in BEV or BEV in SCV, the TAVR-in-THV can still be done successfully, but self-expanding will still carry a high risk, as I mentioned before. However, if the anatomy is small, like we discussed this morning, and then no matter which combination you use, it carries a really high risk of coronary access. So in this high-risk patient, two options. You can do leaflet modification with basilica or shortcut, or you can excise the leaflet of the first valve and put the second valve in. That means the surgical resection of the prosthetic valve leaflet under the revision for reduced TAVR. That's the so-called surplus approach. Regarding hemodynamics, from the Transit PPM international project, severe and moderate PPM was, after reduced TAVR was 6.5% and 14%. The incidence of severe PPM was notably higher among patients who received a supraannular SCV in BEV. It is reasonable because if the first valve was small and you put the second valve SCV deeper, you will get a higher gradient, like this. So when the THV was implanted deeper in a small surgical bioprosthesis or a transcatheter bioprosthesis, then the hemodynamic will be worse. Although BEV in BEV is good to the coronary, but hemodynamic still an issue, especially small valve in small valve. In the Japanese data, some of the patients have a really high gradient after reduced TAVR, needing explantation of the valve. There is another new issue regarding leaflet overhang. This happened when you deployed a short frame THV in a tall frame THV. The valve, the leaflet of the first valve will be pushed outward, but you will overhang over the second valve. Whether this will cause any hemodynamic issue, up to now, no long-term data. So the data showing that hemodynamic function is still acceptable. So in summary, in our center, we consider Coronary-First, then PPM, I mean the hemodynamics, and then conduction disturbance and the PVL, because conduction disturbance and the PVL can be fixed easily. For patient using BEV in SCV combination, in small valve, you may have a hemodynamic problem issue, but the coronary risk was okay. For patient with SCV in BEV, although in small anatomy or the small first THV, you put the second valve, will have a higher PPM, but the coronary risk was still low. BEV in BEV had the lowest coronary risk, but in small anatomy, PPM is still an issue. The most unlikely to or unacceptable combination is to use SCV in SCV, because although the hemodynamic is of no issue, but it will carry a highest coronary risk. So in our center, we avoid as possible as we can to avoid this combination. In our center, when doing reduced TAVR, we use a Coronary-First approach. That means we consider the anatomy of the aortic root.
we classify them into three configuration. The first one is the barrel shape, which is big anatomy. The second one is hourglass. He were narrow waist but big SOV. The third type is the tube type. It's narrow and no waist. For the patient with a high coronary access, implant the valve with the wrist plane below the coronary ostia and keep the commissure alignment is the way to go. However, for those patients with type 2, that means if the coronary height is lower than the wrist plane, you should be very careful. The second valve should be placed below the lower margin of the coronary arteries. In those patients with narrow STJ and VTC, you may need to do leaflet modification plus snorkel stenting. However, in those patients cannot be successfully done, or if the coronary alignment is not good, leaflet modification cannot work, then you have to consider transcatheter Harvard explantation as the last resort. If we use SEV in BEV, as I mentioned, the key point is to put the valve, the second valve, below the coronary height. Although in this approach, you can still have the coronary reaccess possibility. However, if the coronary misaligned in the first valve and the leaflet modification and the snorkel stenting is unsuccessful, you have to send the patient for surgery. In SEV, in BEV, still, you should keep the inner skirt or the leaflet height below the coronary lower margin. In this way, you can still have coronary reaccess possibility. In type 2B and 2C, if the coronary misaligned and the leaflet modification cannot work, the patient have to consider surgical explantation. So we have done more than 30 cases with repeat TAVR or redo TAVR. As I mentioned, if we keep this approach, it is safe for coronary. Although hemodynamically, in some cases with small anatomy, we have to compromise. Thank you for your attention.
Okay, excellent summary. And after the three presentation, we will have time for the discussion. And the next presentation is case 1 presentation. Dr. Lee, Yung-Tsai Lee, he will present case 1 presentation.
Good afternoon, esteemed moderator and panelists. I'm Chun-Ting Liu from Zhengxin General Hospital, and I'm here to present a case involving a failed evolute valve. This is a 84-year-old female who had experienced dyspnea on exertion for several months. She has a history of aortic stenosis, underwent a TAVR procedure with 23mm evolute aortic valve in 2017. And progressively, the prosthesis valve is stenotic and results in the congested heart failure symptoms. She also had a comorbidity of atrial fibrillation, underwent the pacemaker implantation in 2017, chronic renal failure, hypertension, old stroke, insignificant CAD, And she also had a pneumonia with respiratory failure, who just discharged from another hospital 1 month before the procedure. Her STS score is 8.9% and case frailty score is 0 out of 6. The lab data showed a hematocrit of 31.4% and creatinine of 0.98. The echocardiography revealed normal LVEF of 62%, a critical AS of the pressure gradient 40/64 millimeter mercury, and an AVA of 0.6. Severe MRTR, moderate AR also noted. The pre-procedure CT showed quite enough VTC of both coronary artery over 3 to 4 millimeter. However, a small VT-STJ of the RCA was noticed is approximately 0.5 millimeter, which might cause a problem during the procedure. We utilized the app to aid in the pre-procedure planning of how we might gonna put the SAPIEN 3 valve into Evolut R. So here are the information of our case, and we're looking for the expert's opinion of how do we proceed the management of this case.
So good afternoon, Chairman and audience. So this is Timothy from Hong Kong. So I think all of you would agree that this is a very, very challenging case. So I would not say myself as an expert. I would also like to see all the opinion from all the experts sitting here. So let me get to the PowerPoint. Okay. Can I just play it? Can we show the PowerPoint here? Oh, yes. So, all right. So, this is a challenging case. So, this is an 84-year-old lady with prosthetic aortic stenosis related to Evolut number 23. So, she also has multiple comorbidities. So, you would agree that she would be a high surgical risk candidate. So, an old, frail lady with a lot of like AF, renal failure, pneumonia, stroke, hypertension, etc. So the next approach for a failed prosthetic valve, so we can consider TAVR-in-THV, implanting another valve inside the TAVI, or we may consider explantation of the TAVI. So basically, when we were thinking what approach we would use, we will have a lot of consideration. So for this patient, probably age, comorbidity, and surgical risk would favor TAVR-in-THV. And also, like she doesn't have any, as you can see from the echo, she purely has the like a prosthetic aortic stenosis and also some regurgitation. There is no paravalvular leak, probably no patient-prosthesis mismatch. I suppose she is a small lady, and that's the reason for her to have a 23 at the beginning. And endocarditis or thrombosis, these are the favorable factors that we may consider explantation. So otherwise, we perhaps consider TAVR-in-THV first. So however, when we analyze the CT, it seems to us that this is an hourglass shaped aorta. When we look at the inflow is around 335. And when we look at the coronary plane, although the VTC we will say is still okay, 3 mm and 5 mm. However, there is a narrowing above the coronary plane, which is somewhere here near the STJ area. So the nearest area is 267, so it's rather small, and the diameter is only 18 mm. So probably we cannot put in a big valve in this patient. So when we also look at the VT to the STJ air, the distance is only 0.6 mm for the right coronary artery. So would be very difficult in case we have any kind of leaflet obstruction here, and then we try to access the coronary from above. And from here, for the left side is around 3 mm. It's still difficult for us to put in a guiding or difficult for us to put in a diagnostic catheter. So when we look at this kind of coronary problem, so we can, as Dr. Yin has mentioned, we would classify it according to the like the distance, the type. So this is probably a mixture of type 2A and 2B. So the distance of the wrist pain is, one of them is even less than 2 mm. So it will be quite a high risk for coronary access issue if we put in another transcatheter heart valve and then we try to access the coronary from above. So we also utilize the app. So when we look at the Evolute R23, we may consider self-expandable valve in self-expandable valve, balloon expandable valve in this self-expandable valve like this. We may consider another like Sapien or MyValve, whatever, into the TAVI, or we put in another self-expandable valve like Evolute FX into the old valve. And also we may need to consider the note position when we try to put in the new valve. As in the CT, the patient for the original valve, there is quite a moderate misalignment of the coronary, so it's around 42 degrees. Basically, if we put in another self-expandable valve in this Evolute, the double-layered metal frame would probably make the coronary access impossible. So probably this would not be a good choice. So along this pathway, probably we may need to think along the way of the balloon expandable valve. For the position of the balloon, of the valve, we would probably recommend perhaps like note number 4, or not higher, because as we said, it is a rather narrow STJ and also narrow VTC. So the risk of coronary obstruction will be quite high. So we would allow the presence of a leaflet overhang, as Dr. Yin has mentioned. Usually the hemodynamics is still acceptable. So in the next step, we will probably consider a Sapien 20 in view of the smallest endless dimension. It's around like 260 something is only around here. And probably a Sapien 20 and then put in at a note 4, for also putting in mind that there will be high risk of coronary issue. So we may need to consider coronary protection by like putting in a guiding catheter preemptively, plus or minus knuckling or chimney stenting. So would a leaflet modification be helpful in this situation? I think probably not, because of the misalignment of the coronary, misalignment for the first valve. Leaflet modification, be it like using Basilica or the other unicorn technique that was developed in Hong Kong, probably may not help too much given the like misaligned post. So in summary, probably in this situation, when we use consider TAV-in-THV in this situation, we probably use an S3, the number 20, put it at a rather lower position at note 4, putting in mind that there will be leaflet overhang. However, the new valve we are going to put in will be a small valve. There will be risk of underexpansion because we probably won't be very aggressive to overdilate it. And there is also possible residual gradient. And also the coronary obstruction risk is not negligible. And also, given the small valve, we are not sure about the long-term durability. Another possibility would be surgical explantation and redo TAVR. So also, as Dr. Yin has set up the stage for us, although this patient is old and also frail, has some comorbidity, we need to think carefully and also think more proactively whether surgical would be a better option for this patient, because we may consider some hybrid approach as the surplus approach, for example, transaortic approach, and then the surgical team may also just resect the leaflet and then we do the TAVI afterwards. So for this patient, probably my opinion would be we would think very, very seriously about Sapien 20, S320. However, given the coronary risk and obstruction, we would discuss in the heart team, and probably I think a surgical option would be a better option for her. So we would like to see the other opinion from the experts. Thank you.
So I think that everyone is a beginner in this field because we just only have some few cases, and everyone push the limit to the TAVR-in-THV. I know that redo surgery is a very attractive option for implant and the surgery. However, patients do not like the surgery again, especially when they are aged around 80 or even 90. So that's we must try to do our best for the TAVR-in-THV. So that we do more multi-slide CT analysis. Is the implant. Fortunately, the only one fortunate, the lucky thing is the implantation depth is 6 millimeter. So that the neo scale is relatively low in this case, and the overall height of even the misalignment for this case, and only that's around maybe 8 or 9 millimeter above the risk plane. So this is a more important figure. Is all of the BTC is 3.5, and there's BTSTJ is very low. So that we do the basilica first. Okay. 没有跳。我已经下一页了，他没有跳。我已经下一页了，他没有转出来。So in this case, we try to do the basilica because even as a misalignment, however, we make a slit over the RCC is still have some coronary flow into the sinus basaba, so it's okay for this case. Okay, so that's it got very difficult to do the basilica because the co-valve limited the case. We change to the JR, and even as every kind you can think in the case lab. So it's very difficult. So that we just self-modify the pigtail, just cut 2/3 of the pigtail, so it's make a good curve for that, so that it can puncture to the liberated tissue into the LV and the graft to the basilica. And you can see the echocardiography, and we make a slit over the RCC, so that it's okay for this case. And then we implant the SAPIEN valve. So ideally, we hope to do a node 4 or to node 5, and finally, it's because it's quite slippery. So that when we do the valve deployment, it's move up a little bit. However, the lower skirt is still at the annular site, so that it's safe. And the other thing you can see, everything was pushed outward is because SAPIEN is quite strong. So if you implant too much, everything is pushed away. So and finally we use this 20 SAPIEN 3 valve at the node 6 and the 20 cc more than 1. Finally, it's around 21 millimeter. Sorry. So the VTC is around 4 millimeter for the left, and the right is around 2. And the post-pressure gradient is mean pressure gradient is 5. And everyone knows that it's quite difficult to engage the RCA. However, we try our best, and we can engage the RCA with very strange angulation, and that can do the RCA coronary angiography. So that's I think that we must have original CT and the data, and you must take care of BTC and the BTSD. And the idea is just use another valve is better for one, and we just measure the inflow, waste, and the outflow. And I think the waste is more important one when you implant the SAPIEN valve, and that's always take care about the original annulus, but not too high to overstretch the core valve and make the coronary become very risky for this case.
Very excellent cases. This is a really difficult cases in the real practice. Any comment and question about these cases?
So is the SCJ and the VTC get narrower after you implant the valve? It did.
Yes, originally the VTC for RCA is around 4, and after procedure, because we add 1 cc more into 20 valve, so that the VTC become around, by echocardiography check is around 2. So there's maybe we do not have a third time procedure for that.
For BEV in SEV, valve expansion is really an issue. It will just reduce the VTC and the VTSDJ.
It's why the paper did not say that we should take care about the valve further expansion. However, we have several times the VTC become less and less if we overstretch the valve.
I think this is the initial valve was deployed 2017, and this year 2024. So 7 years later, the valve degeneration is occurred. So therefore, it means that the TAVR procedure itself is not totally curative procedure. Valve degeneration occurs in some patient. And second one is, I'd like to ask that it is a very, very wonderful. Is the maintaining the 7 years patient healthy, even though it's such a lot of the comorbidity. And okay, this is a second TAVR and TAVR. What is your expectation for the longevity? How long do we maintain this patient? You know, what I mean is that, okay, theoretically, it's a highly top level, extremely top level of the technology. I agree, totally agree. And then that is what should we do? And so I'd like to ask what is the next step for this patient?
I think it's quite difficult because when she was 78, he said that I only have 5 years to live, because the average survival in Taiwan is around 82 at a later moment. So that's she said that's enough. And after procedure, he said that I hope I can live longer. And until this year, he got the pneumonia, and then the symptom progressive, and he got very severe symptom of aortic stenosis and needed to do another procedure. And another thing is after procedure, she became active, and just when she was at 78, she said that now I hope that I can live for 90 or even 95. So that's he tried to do a very active life.
Okay, any comment? Okay, excellent. And we will move to the next topic. next topic is CT procedural planning and how did we do? And the presenter is Dr. Liu.
Okay, I learned a lot from the case number 1, and so we're have more to come. So I am here to present a case number 2 involving a degenerated prosthesis valve after aortic valve-in-valve procedure. So would you please open the case number 2 PowerPoint? Okay, this is a case involving a 72-year-old male who has experienced a dyspnea on exertion for several months, and he has a long history. He has a history of bicuspid aortic valve and underwent the surgical aortic valve replacement with a 23mm Edward Magna valve in 2010. At that time, a dilated aortic root of 4.5 centimeter was also noted. However, the surgical prosthesis valve became stenotic, and he subsequently received TAVR in SAVR procedure with a 23mm Sapien XT valve in January 2017. Soon after the TAVR in SAVR procedure, stenosis of the prosthesis valve was observed with a high transvalvular pressure gradient of 40 out of 60 mm mercury. And after post-balloon dilatation with a 22 mm nucleus balloon, the procedure gradient decreased to 25 over 42 mm mercury. But the PPM remained an issue. Additionally, the patient had a history of atrial fibrillation leading to recurrent congested heart failure. His medical regimen originally consisting of a cortisone and a beta blocker was changed to Rimonon and the CCB. So he eventually required a pacemaker following a near syncope episode in 2019. So the current medical issue is that the Sapien XT valve is progressively failing with a high pressure gradient of 42 out of 75 mm mercury. And also the aortic was at this time was 6.5 centimeter when we do the CT pre-procedure planning. The patients also had a medical history, including the acute stroke resulting in limited limb activity, leading to a fail and a lumbar spine compression fracture, rendering him partial dependent. So his case fragility score is about 4 out of 6. And his STS score is 4.3%. The lab data shows a low hemocrit about 29.3% and a creatinine of 0.8. He also had a comorbidity of COPD, autoimmune thyroiditis, and hyperthyroidism. Okay, that's the history finished. The echography shows the LVEF is about 40%, a mild AR, severe AS of pressure gradient about 41 over 66 mm mercury, AVA 0.6, the index AVA 0.36, mild MR, moderate TR is also noted. The pre-procedure CT shows the inflow plans of area about 186 millimeter square and diameter of 15.4 millimeter. The narrowest part is about 4 millimeter above the inflow plans with the area of 180, diameter of 15.4 millimeter. The outflow is a little bit flare. So this patient also had a dilated aortic and ascending aorta 6.4. As we mentioned, when we simulate the evolute 23 millimeter valve into the surgical valve, we can see that the stem frame is far from the aortic wall, so a a quite large VTC is noted on the CT planning, so indicated that the coronary issue might not so important in this case. So we utilize the app as well to aid on the pre-procedure planning, and the results show us it might be a possibility of the PPN because of the index EOA on the app show us a 0.82 centimeter. That might take into consideration when we do the procedure planning. So that's all about the patient's current information, and we're looking for the next experts to give us some management planning. Thank you.
Dr. Budwari.
Okay, thank you, Dr. Lee, for bear with me a little bit because this is not TAVR-in-TAVR, this is TAVR-in-TAVR. And this is my first case. Dr. Lee did update her slides a little bit, so some of my slides might be a duplicate of hers. So this is a summary of the case. He is currently 72 with these comorbidities. And also, I was told her the root, the last measurement was 6.5 centimeter in diameter. So when she had a Magna put in, he was 58, right? The Magna True ID was 21. And then 7 years later, the Magna failed. And he had an XT number 23 put in with the PPM, severe PPM requiring balloon valvuloplasty. It did work very much, but it lived for another 7 years, and then the XT failed. Now with severe AS, slightly decreased LV function, aortic root, according to the one sent to me, was 4.6, but I guess it was 6 at some point. So what we don't know and don't have, and what we should know, is that the original valve pathology, I didn't know it was bicuspid, but I suspect that it was bicuspid because the root was enlarged, markedly enlarged. And then we didn't have the measurement, the other measurement of the original pathology, and also coronary orientation, especially if it was bicuspid. Then with the original TAVR procedure, we didn't know it was a Magna failing, which pathology was it, stenotic or Regur, but now we know it's stenotic. It's just the position of the XT inside the Magna, especially the angiogram, whether it's low, high, and then was the fracture performed. I suspect it was not because of the measurement currently show that the border of the valve was not very well expanded. Now we know the degree of PPM from her slide and the result of the BAV, in which I didn't know when I was getting the slide. Anyway, the current measurement, we didn't know the exact number of the SOE width, the STJ height and width, the coronary height, root dimension, in relationship to the two valve with the slides I'm getting, but now we know, and I'll go over that in a little bit. To me, there are two choices. Choice number one, he's 72 with the STS score of 4. With all these comorbidities, I think redo surgery still be an option. You put in a new generation prosthetic valve that would allow future valve-in-valve, perhaps with aortic root replacement as well, because it's 6-something now. And these are the reasons to support this choice. And then the other reason might be if you explant these two valves now, comparing explanting when you have a tall evolute in as a third valve, the mortality might be better now than 7 years from now. Well, the second choice obviously is the redo TAVI. It's a TAVI-in-THV in TAVR. The risk is probably lower than a redo or explant the valves. It's feasible for sure. And we use the transcatheter valve and the strategy that would provide least mismatch, best hemodynamic, and probably best clinical outcome that we have the data up to date. But we also need to explain the patient the unknown of the durability of this third valve, and also the unknown of what the next procedure, perhaps 7 years from now, when he is 79. What would it be? How could it be done? And what the risks and what the outcome? But anyway, we're going to go with the second choice, I guess. So before that, we need the old records in terms of the valve pathology. Now we know it's bicuspid, position of the XT inside the magna, especially from the angiogram, and then whether the valve fracture was performed, and probably not. Then more CT information in terms of the current situation, the SOE width, the STJ diameter, and also the STJ height, the root diameter, and also the coronary height. But I guess if you could read all these small number, the SOE diameter is huge. The STJ diameter and also height is above the neo-skirt plane. The root is huge, and the coronary wrist plane is also above the neo-skirt plane. So we probably could safely put a self-expandable supraannular valve in, for example, the Evolute platform, either the R, the Pro Plus, or the FX, whichever you have. The newest generation is probably can orientate the commissural alignment better than the older version, but keep in mind this is a very small diameter. The R might have the advantage of not having infolding. Okay, less chance of infolding in a small, crowded anatomy. But anyway, and you position it at node 3 where the level, the neo-skirt level right at the XT outflow, which is going to be below the coronary wrist plane anyway. The average of the diameter, if you average them out, the 3 measurements that Dr. Lee present, you will get the area of 232, and the perimeter, diameter derived from that would be around 17.2, which is actually lower than you would like to have for a Evolute 23, but it probably can be done, doable. You don't need to worry about the coronary obstruction, so nothing needs to be done in terms of coronary protection. Now, if you worry about the hemodynamic, then valve fracture, I'm not sure it would work or not, because you have 2 valves in there already, which expand only into 16 or so in terms of diameter. You could potentially make it bigger if you could fracture the original magna and expand the XT a little bit further, and still without having to worry about the coronary. The only thing I would worry about would be his LVOT is probably small, and you might have a slight increased risk of annular rupture. And then of course, cerebral protection is probably recommended in this case. And this is what the app that he just mentioned recommend. Thank you very much.
Dr. Lee, Yung-Tsai.
For this case, at the best, I hope he received the surgery, even at the first aortic valve involved, because I talked to the patient a lot, and I say that aorta is 5, and then you need a corrective surgery for your aorta and your failed prosthesis. However, he insists that I just do a minimal invasive one. So after another 7 years, everything is failed. And I think that the lifetime strategy for this case is not enough, because maybe in the 6 year or 7 year, another procedure will come in, even the aorta or any other things. So it got very difficult to cross this the Aortic valve. So we try for minutes. So that's a live demonstration to China, and we just I say that's okay. We just go transcatheter 1, and in minutes you just cross the Aortic valve, and then we do the BBF with 22 balloon. I think that no one do that in XT in Magna after 7 years. So that's we do a break. So it is break. So could you see that? It's a break. It's just open in the outside. And then it's become severe aortic regurgitation, so we must implant the core valve rapidly, and we use the inflow to inflow, and there's the pressure gradient after 2 times of release, and we release the valve. So it's around the inflow to inflow, and then the pressure gradient is still 20. So we do another post dilation for this case with 22 balloon. So I hope that we can have enough strength to push outward of the valve. So it's a full dilate of the previous SAPIEN valve, and the Magna is, and the post-procedural pressure gradient is 14. I think we do our best for this case. I hope that I cannot see him again. However, that in the future it must an issue for this case, because the lifetime management for him is not good enough, because the first time is coming.
This is the Evolute 23. Yeah, okay, and which Evolute? Is it the FX? So I think that the redo tab is saver is feasible because I think the most attractive for the patient, and we must individualize case by case. And consideration for saver is much difficult in this case, because the patient, much of comorbidity, and now after procedure he can work a little bit and try rehab a lot. And now he was prepared to have another surgery for spine. I told him again that in the future, if you have some problem, you need a second operation for your aorta and your valve, and take everything out. Another question I have is that the valve fracture, doing it before or after the core valve, what do you think about that? Why do you do it before instead of after?
In our preference, we always break the valve before, because in the borderline case, we can use a 26 core valve. And for this case, we just have only one chance. I don't hope that we break the core valve inside the core valve, and the core valve has some problem. Now we have the THV, 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 and SAV. It's too difficult to do any other things. So that we break the valve again. However, after break, the blood pressure cannot go up. It goes around 30, so that everything need to prepare very rapidly. And fortunately, the core valve system have a retrievable, so we just put in and let the hemodynamics stable, and then we do a partial release to the correct position, and the valve is function well.
Patient age is 72, so the patient should survive up to 90. So the 18 years should be survive under your best treatment. And what I mean is, second one is 2010 surgical valve and the 7 years interval, and the Sapien, and now is the Evolut, and the patient is maybe 7 years later. The patient age is 79. At the time, he should be take surgery.
I think that the aorta is a big problem. Because in the beginning, the aorta is 4.5 bicatheter valve, and a lot of surgeons left the aorta do not touch it and replace the problem. However, a lot of aorta is not a benign disease, so that's we should focus on the aorta with bicatheter valve. In some situation, you need to replace part of aorta, such as in this case. So when we do the aortic valve in valve, the aorta is 5. Now the aorta is 6.5. It's quite huge. However, at this moment, he do corrective surgery. I think he cannot survive. Even the procedure is successful. However, you cannot recover well about pulmonary function or any other things. So it got very difficult in this situation. And finally, the patient asked for a convenient one. It's a transcatheter one.
The case from your hospital is always exciting. Really, is that's true. And the last topic is redo valve surgery or TAVR and TAVR when the transcatheter heart valve fails. Actually, this case will be present Dr. Chan.
Thank you for the kind introduction. So I think some of the content has been covered by Dr. Lee and Dr. Yin already. So I would just like to give a brief overview when the transcatheter heart valve fails. What are the treatment options, like an overview, and also a lot of the details will be covered by a lot of experts during this meeting as well. So nowadays, the TAVI, as we know, is covering all kind of a risk profile, just like surgical AVR. So we are moving towards those younger patients and also lower risk patients. And then we have to think about the long-term sequelae after we put in this TAVI valve. Now, although there are studies, some registry reporting up to 10 years of the TAVI results, the structural valve deterioration is about 10% at 10 years, which as a surgeon, I think is an excellent result. However, when considering the amount of the data, it's still quite inadequate compared to surgical valve. So I don't like to make that conclusion that early. But one thing to be sure is that, like Dr. Yin mentioned, in the coming 5 to 10 years, we have to do a lot of these patients with a transcatheter heart valve failure. So valve 3 classification have a very detailed description for the definition of the failure, how do we find out, how do we diagnose them, what are the diagnoses. But in this scenario, I think the most important thing is to decide what kind of structural valve deterioration is our patients having, whether they are only mainly at the leaflet level or those non-structural valve deterioration, which include those outside the leaflet, like the peripheral leak, the patient-prosthesis mismatch. Of course, you have to think about the thrombosis and also the endocarditis as well, because this is very important to help us to decide what kind of treatment we can offer to the patients. So talking about treatment, options are limited, whether we don't do anything or we do the TAVI explant or redo TAVI. Unfortunately, both the TAVI explant and redo TAVI are challenging and high risk. Even more high risk when we compare to the redo surgical AVR or the TAVI in surgical AVR, just because we have different types of design and the shape of the TAVI valve we have. Now let's look a little bit more details on the treatment options. So first, TAVI explant. Now, we have this couple of recent registry, and also the explant TAVR registry can give us some idea what's the situation right now. So the rate is not that high, 0.2% of all TAVI, but as I mentioned before, expected to going up in the future. And most of the time when we do the TAVI explant, usually those patients are quite recent from the TAVI. So most of them are within 1 year. And of course, most of the patients are younger and have a lower risk. And the indication, so you can see that most of the patients receiving TAVI explant because of endocarditis, and then followed by those non-structural valve deterioration. So the mean STS score expected is 5.6%, but there are a lot of reports showing that the actual mortality is 2.5 times higher than what we expected for those patients. This is because, number one, a lot of them receive a concomitant surgery, like up to 14–15% require the root replacement, and more than 50% of them require the concomitant procedures. Of course, some of these concomitant procedures, because the patient needed that, they have a significant coronary disease, mitral valve disease, etc. And second reason is that the stent of the transcatheter heart valve may have interference with the aorta, the aortic root, or even lower down to the mitral valve as well. So for TAVI explant, for the surgical technique, I think this is something new for surgeon. There are different techniques for the balloon expandable valve or the self-expanding valve. But I think for our own experience is that there are a couple of key points. First is to carefully dissect out the stent at the ST junction using both sharp and blunt dissection. And once we get to the annulus level, we can twist it, press the stent so that to deform the TAVI valve and take it out. And then we examine what the damage we have made and decide whether we need a concomitant surgery. So there are a couple of techniques available talking about how to aid the procedures, like cutting the frame, the tourniquet technique, or mention about the hybrid technique using the surplus or even the open valve-in-valve technique. So the redo TAVI, again, the rate is not that high, 0.46% of all TAVI. Time to redo, it tends to be longer. And also the patient's age is older, higher risk, because we can see that the indication most likely is dealing with the structural valve deterioration rather than those non-structural valve deterioration. Now, the numbers are better. Here you see the mortality 3 to 6%, complication rate up to 12%, device success rate 85%. But definitely, these numbers are much higher than routine TAVI or even higher than those TAVI in surgical AVR. But no need to mention that about 1/4 of the patients, they turn down for the redo TAVR because of the anatomy concerns. Now, and also for the preoperative planning, is very challenging as well. Now, the reason is that we have so many types and design of the TAVI valve as the index TAVI, and also there could be possible of a combination in the second valve choice. I think the most important issue to decide whether we can proceed or what time to choose, what kind of valve to choose is a coronary obstruction. Now, we've mentioned about the new skirt, wrist plane, the frame to aorta, the distance, and stuff like that. So when we're facing the patients with such a large root, it's easy. Whatever we can do, we can put in the valve, we can break the stent, we can do a balloon. However, if we're facing some patients like this, the stent is basically touching the coronary ostia. Then the next step is to see whether we have the commercial alignment. You see that we do some leaflet manipulation, and then we do the TAVI in a special situation like the basilica, or in this here, we do the unicorn procedure in our center. Now, when we compare two treatment mortality, the TAVI explant versus redo TAVI. So this is the explant or redo TAVI international registry, gives us a lot of details. So we compared 200 patients to about 180 patients. But you have to be careful is that in this study, they excluded the 150 patients because of the SBE. So this group of patients, they have to go for the TAVI explant. So as mentioned, the indications are different. mostly for redo TAVI, we're treating those structural valve deterioration. For those TAVI explant, we're treating those non-structural valve deterioration. Now, this is the landmark analysis, which is we always talk about. Definitely, in the first 30 days mortality, TAVI explant could have a significantly higher risk, higher mortality. The complication rate are similar, and you can see that the mean gradient as the second valve is similar as well. However, you can see the baseline, the mean is about 12. It's higher than what we do in the first TAVR. But after the 30 days, the mortality will be quite similar. So after all these difficulties, when we're having a patient having a THV fails, so I think importantly, we have the patient profiles, and also we have the CT imaging, everything best to have those old ones before the first index TAVI. And then, of course, we need a team assessment. First, we see what is the age and risk of the patient, and also any significant concomitant procedure we need to deal with. If yes, or they're young, then I think TAVI explant is a good option, first of all. Secondly, SBE, definitely, we go for TAVI explant. Those non-structural valve deterioration, we consider TAVI explant as well. But majority of the patients, if they are suffering from structural valve deterioration, I think redo TAVI is the first option. Unless the anatomy is not favorable, then we think about the TAVI explant. So I think nowadays we have more younger and low-risk patients undergone TAVI. So this long-term treatment, nowadays we have to be prepared. Both TAVI explant and redo TAVI are high risk and complicated. Both of them has a new set of the skills, including the pre-operative assessment, intraoperative kind of techniques that we have to learn about. And for now, we still have the data knowing that TAVI explant had a higher risk than the redo TAVI. But most importantly, all this information can help us to do our first TAVI better and to select a better patients. Thank you very much.
Excellent presentation. Any comment?
Yeah, as Daniel said, what we learned from these TAVR-in-TAVR cases is that we should make the first TAVR plan very good. Because as the second case, at that time in 2017, we don't have the idea of a break. And we dare not to do that at that time. So if the first surgical valve, we break that, we might put the larger valve in, and that will make things easier for the third procedure.
And the first case, if you go back and think about, you may have to put the second valve in, but still use the self-expanding. Would you put it lower? Position it lower, so that the STJ and the valve would be, and the VTC would not be such a problem.
You mean as I put self-expanding in self-expanding?
You put the evolute in the lower position.
Yeah. So as a for the first valve.
For the first valve,
yeah.
Right?
Yeah. So we hope that it's at a lot of time we still not know that's as high as possible. Now everyone say as high as possible, and now we know that's as high as possible have a risk of the coronary and the STJ, and then now we just acceptable about around 3 to 5. I think it's okay. However, you must take care about the conduction system. So we always check the membrane septum, and if the patient can tolerate a little bit, we just keep maybe 5. And 5 for the newer generation system is quite easy and comfortable, and you can save your time and do easier.
Thank you for your presentation. Actually, for the first case, I think it is a very excellent job for you guys to have implanted a SAPIEN valve at the end. So actually, thinking back, knowing that there is a lot of possibility of TAVI-in future. So in retrospect, would you think putting in a balloon expandable valve for the first patient, the small lady, is an advisable choice at the beginning, thinking that we may need coronary access in the future?
I think it's step times, and when you do the second times. However, in the morning, we talk about the patient-prosthesis mismatch and the device durability. Till now, we still not know that the SAV or be better. And for the first time valve, it should be the short stem valve. However, it's in the XT, especially XT, a lot of valve failed at the 5-year or 6-year. However, in our experience, the first generation core valve without any the treatment, and there's not retrievable. Some patients still alive, and the device quite well. And at this opinion, I think it still have a question, because we did not have a longer observation to the S3. And if the S3 lasting for 10 years, I think that S3 is a good valve for the first time procedure. However, for 5-year or 6-year, and you implant another valve, and you know that the Shih-Hsien material that we see the stroke, we are limited another valve. So that's when we do the SAPIEN, the residual pressure gradient usually around 20. So it's not good enough for the valve. So that's we must think about when we do the patient, such as the second case is 60 or there's maybe the 65. Maybe you have a third time surgery for that case.
Okay, I'd like to close this session. Thank you. Thank you.
Together with me is Dr. Yohei Ono, who is the course director of the Tokyo Valve. And we will also have Roman Pfister and Dr. Song Shih-Hsien, Dr. Yang Jian online, and Dr. Kenso online. This session we will have 6 topics to 6 talks to deliver. And we may have some brief discussion if the time allowed. The first talk will be given by Dr. Yohei Ono. The title of the talk is A Minute of Mitral Tear. Please.
Professor Veen, ladies and gentlemen, thank you for your kind introduction. So it's really my great pleasure and honor to be here again. My topics today is to deal with the unmet needs of mitral tear. So we now in Japan we have two devices available for mitral tear, which is MitraClip 4th generation and Pascal precision device. So as you know, you're all aware of MitraClip is the first device in this field for mitral tear. As for the 4th generation, we have 4 clip size available: NT, NTW, XT, and XTW, combination with arm length and the width of the device. It has enables independent grasping, just like Pascal. So Pascal, in Japan, we only are able to use it for primary MR, starting from last December. And P10 and the Pascal Ace 2 size lineup is available. So actually, what have we learned from our experience in Japan? Just like Ocean TAVI Registry, we have Ocean Mitral Registry, have participating 22 high-volume centers throughout Japan. And as you may know, thanks to our reimbursement system, the number of cases, including TAVI and MitraClip, are growing. So far, we have registered around 4,400 cases for MitraClip. So this is the initial data set dealing with 2,150 patients. Mean age is 80 years old, has a lot of comorbidities, including AFib, hemodialysis in some patients, diabetes. So a lot of patients were hospitalized within 1 year, and they majority of the cases were presented with NYHS 3 and 4. So after the TEER procedure with the MitraClip, what has changed? The MR change over time. So actually, with the device, I would say a little bit less than 80% of patients had finished with residual mitral MR 1+. Around 20% still had 2+ MR, and some of them had significant MR left. It was maintained up to 1 year. Likewise, as for the clinical symptoms, NHA scale substantially improved, and it was maintained throughout 1 year as well. So as for the 1 year outcomes, the event rate regarding death was 12.3%. Death plus heart failure hospitalization was around 23%. Compared to the Western registry so far, like TRAMI registry from the Germany, TVT registry from the United States, of course, we're dealing with a different risk profile patients, so it's not easy to compare. But at least I think the outcome for our 1 year result is acceptable. But still, I think there's room for improvement. Obviously, single leaflet device attachment, SLDA, has the incidence of 1.7%. Leaflet tear had 1.2%, and mitral valve re-intervention, whether intervention with the MitraClip or surgical intervention, was 2.4%. How was the impact of residual MR for clinical outcome? I think this result is in line with the previous result. Obviously, it's better not to leave mitral regurgitation more than 2+. So this impact actually was quite different from the etiology of the MR. So if the patient had primary MR as etiology, the impact of residual MR was more significant compared to the secondary MR. So the current generation, 4th generation MitraClip provides good result. Let's say this patient had a combination of degenerative as well as a functional, atrial functional aspect. Using 2 clips, we were able to control the CMR less than mild. Mean pressure gradient was slightly elevated, but the patient was high age with limited functional capacity, so we thought it was better to control the residual MR. And we sometimes have to face with these very large, frail primary MR. The patient had to undergo lung cancer operation, so open heart operation was not a choice. In the previous generation of mitral clip, maybe this was quite difficult to control. But using the wider and longer clip, XTW, we were able to control this severe torrential MR, I would say, with trivial residual MR. But still, some pathology could not be treated or carries risk with the current TEER device. Multiple scallop prolapse could be difficult. Well, you can place 2 clips in the A2P2 area as well as the AC, maybe having A1P2 leaflet to control, but it still could be quite difficult to achieve optimal result. And obviously, the outcome of mitral TEER rely on the patient's anatomy. So let's say like this patient has a very enlarged, extremely enlarged giant left atrium, long-standing history of AFib. So the valve is quite flat, and there's a loss of coaptation. And top of that, the quality of the leaflet is not good. It was kind of degenerated, shortened, and fragile. So in this kind of case, if you try to do mitral clip or Pascal, you need to be very careful. Otherwise, there's a risk of SLDA or the leaflet injury. So still, I think the incidence is quite low with 1.2%, 1.5% range, but we sometimes experience the leaflet device attachment. The movie is not working. So, when we consider this treatment, whether to go advance with the TEER approach or the potential other therapeutic options, multiple things need to be considered. The number of lesion, number of the significance of the lesion, what is the mitral valve area that could potentially lead to mitral stenosis. How about the calcification of the leaflet or the annular calcification, so on. So we need a careful patient selection. Obviously, the anatomical selection is very important. So we are still trying to understand which pathology, which anatomy is suitable for this mitral TEER approach. We know that A2P2 lesion with substantial length of the posterior leaflet is a very good candidate for this device. Using the current generation MitraClip G4 or Pascal ACE, Pascal Precision, could lead to almost surgical-like result. However, if we go on to this yellow zone, it could be very challenging because of the limited mitral valve area. The length of the posterior leaflet matters a lot. So if it's quite short, it could be very challenging. As for the red zone, as you can see in the most right-hand side, with limited mitral valve area, whether patient has a MAC, mitral annular calcification, calcification in the leaflet and especially in the grasping zone should be avoided because of the adverse event. So to conclude my talk, outcome of the mitral TEER heavily rely on anatomy, as we know, and careful patient selection still needs to be considered. Device alliteration has contributed substantially to perform mitral TEER safely to a wide variety of anatomy. Thank you very much for your attention.
Thank you. We will move to next talk, and maybe we discuss at the end of the session. And the next talk will be delivered by Dr. Roman Pfister. And Dr. Roman Pfister is from Germany. Am I right? Hi, good to see you. His topic today entitled Best Practice of a Pascal System.
Yeah, thank you very much for the kind invitation. It's a privilege to participate in your great congress. Hopefully you can see my slides already.
Yes, please.
Okay, so my talk is about best practice application of the new Pascal system, and the previous presenter already set the stage introducing the two established systems for TEER, which we have available so far. Now, all of you know that pathology of mitral regurgitation is quite heterogeneous. There's a large variety of individual pathologies, not only the distinction between primary and secondary MR. As you can see, there are a lot of individual subtypes, and it is quite clear that more device techniques and designs we have available, the better will be our results. And I'm not sure whether we're already at the stage of individualized therapy, but we are on the way to that. So when we look at the guideline recommendations, both for primary and secondary MR, then with respect to catheter-based therapy, leaflet-based therapy with the TEER system is definitely the first choice. And we have two advanced techniques available so far: the historical MitraClip for more than 15 years, and during the last years, the new Pascal system was introduced. And of course, we want to know how good is the new player in the game, the Pascal system. Of course, it has to compete with the historical standard, the MitraClip system. And we have one randomized control trial so far, the CLASP 2D, which randomized both techniques in a 2-to-1 scenario. And here you can see the efficacy endpoints for the first year post-procedurally, showing clearly that efficacy with reduction of MR to 2 or less and 1 or less is definitely non-inferior. And the same was true for the safety endpoints, which luckily are very rare, about 1% of severe clinical events. So very promising so far. And there was also accompanied a registry for patients with complex MR anatomies. We are just talking about primary MR so far. And these patients were not introduced in the randomized control trials, but were observed in a accompanied registry, as I said. And on the left side, you can see which kind of complexity criteria were present in the patients. The vast majority had 2 independent chats. There were patients with a B-leaflet or multiscallop prolapse involvement. Of course, patients with a small opening area. These are traditionally referred as the Everest criteria. So these were patients which were excluded from the pivotal Everest 1 and 2 trials with the MitraClip, generally regarded as the yellow category in the complexity. And the results for these patients, and this is just a Pascal group here, was also quite promising, because you could see that the percentage of excellent or acceptable results were similar as in the randomized cohort. So even there was a highly complex anatomy, the results that could be achieved were very, very good. So these are the hard evidence data. And when we now go one step back and think what is our treatment aim with these devices, then according to the Mitral Valve Academic Research Consortium, the device success is determined by the lack of complications, usually structural complications of the leaflets or the subvalvular apparatus. As we have heard, this is very rare, about 1%, 1.2%. So from my perspective, it will be really difficult to demonstrate superiority between devices in such a rare complication. So with respect to safety, I think it is very difficult to do this evidence-based. So there is some kind of gut feeling when we look at the design of the devices. Of course, what is the main aim is to reduce the mitral regurgitation rate as far as possible. Optimal would be actually trace or even absent, and acceptable reduction would be grade 1 or 2. Now, we have already seen the design of the new Pascal precision systems. We do have 2 devices, 2 device sizes available, the ACE device and the P10 device. And you see the main differences are the size of the devices, the width of the pedals here, and also this spacer which is between the gripping arms. And this is unique, particularly with respect to the mitral clip system. And what is also different is the total construction made of 19-node, which means that particularly the closing is somehow passive based on the memory function of the 19-node. And the third important design point is that we not only can invert the device if we want to reposition it, we can actually completely elongate the device, leaving no free edges which could be entangled within the leaflet. So, to my opinion, there are 5 very important unique design issues which all have or might have impact on efficacy and safety. The first one is the spacer, which is particularly true for the P10 device. And it is quite obvious that this decreases the leaflet tension because you do not need to adapt leaflet to leaflet. You can adapt leaflet to spacer, and this leaves 5 millimeters of tension. The second important one is the 19-node design. As I already said, the closure mechanism is somehow passive based on the 19-node memory function, and such there is less force on the leaflet, and sometimes the Pascal device doesn't completely close to the spacer, which might be thrilling if you see it in the first place, but actually the device is nevertheless quite stable and the leaflets are captured very, very well, but it is a quite dynamic structure. The third very important point is the capture of the leaflet between here, the clasp and the pedal. And this capturing mechanism is also 19-node based. And this is in opposite to the overall closing mechanism. This is quite stronger than we know from the mitral clip system, where these grippers come down just because of the pressure of the lock line. So here is more force, and this would expect to capture the leaflet more stable. The fourth is the elongation. As I already mentioned, this might increase safety because you have a less risk of entangling within the valve, and you can do more repositioning, more recapturing. And the last point is with respect to the retention element. This is these small needles which are responsible for really firmly capturing the leaflet structure. These are designed at the end, as you see here at the end of the clasp, and now these needles go within parts of the leaflets which are quite stable. And if you have a retention element maybe more at the base, this would be the edge of the leaflet, and this is not that stable. So that could be also a design aspect, increasing safety if you have to recapture the patient. Now, of course, randomized controlled trials are very important for an overall impression, but if you want to go into maybe some kind of individualized therapies, real-world data may be also important to consider. And we, together with 9 other large centers in Germany, collected our first cases after the commercial rollout of the Pascal P10 system and compared these results with a large mitral clip registry we have here in the western part of Germany with more than 1,000 patients, and did a one-to-one propensity score matching for the important covariates and compared efficacy and safety, as you can see here, similar as in the Class D randomized controlled trials. We observed a high rate of efficacy, and this was similar in the Pascal and the MitraClip system. And if we look at the optimal reduction of MR1 or less, then there was quite a surprising trend towards increased efficacy of the Pascal system. And this has to be confirmed in other real-world data. And this is one important point. The second important point, and this is, I think, nicely supported by the design I just showed you, was the remaining opening area and the remaining post-procedural transmitral gradient, which was significantly higher in the MitraClip group, and also the rate of patients with a gradient of 5 millimeter H mercury or higher was also significantly lower in the Pascal group. And I think this is nicely explained by this spacer design. And this was an early experience where only P10 devices were used compared to first and second generation of MitraClip. So I want to show you two nice examples where I think it is quite comprehensible what I mean with the spacer design. So this was one patient which was referred to our hospital. He underwent MitraClip procedure, and this was aborted in another hospital due to increased gradient after the procedure. Gradient was 6 to 7, and they removed the MitraClip and well, yeah, aborted the procedure. It was a secondary mitral regurgitation, atrial pathology with a small valve. It was a small, tiny person. And this is the echo showing also degenerative changes of the leaflet, but the main pathology was atrial dilatation. And we decided to use a P10 device, which might be not intuitive because the P10 device is a really large and massive device, as you can see here in this tiny valve. But in the end, the result with respect to regurgitation was quite good. And we had, I think, a good residual opening area, and the gradient was absolutely acceptable. So counterintuitive, a large device, but based on the spacer design and the lower tension on the leaflet, this was possible also for this intermediate opening area. And the second case was ventricular mitral regurgitation, massively advanced stage. So no co-op criteria, but rather Mitra FR patient maybe, but we had the intention to improve symptoms. And also a small baseline opening area of 3.9 square centimeters. You can see here a massive dilation, a massive tethering of both leaflets, and there was a huge coaptation defect in the center of the valve, resulting in massive mitral regurgitation. And for several reasons, we first tried to use the small Pascal device, an ACE device, which already, I think, clearly improved the mitral regurgitation. The remaining opening area and the gradient were acceptable, but clearly it was not possible to insert a second device. So we could have left this. I think it is quite a good improvement, maybe residual grade 2, but we thought maybe we can go better, and we removed the ACE device and then inserted a P10 device. And I want to show you the results here. You see that efficacy, it was even better, the residual mitral regurgitation even better, maybe grade 1 in the overall quantification, and remaining opening area and gradient were even better than with the ACE system. And there is a substantial amount of observational evidence supporting our observations, indicating that the Pascal system overall, but particularly the P10 system, is very good for functional mitral regurgitation with a lot of tension on the leaflets with respect to post-procedural gradient. A very important point, which all of you know who do a lot of MitraClip procedures, was some kind of disappointment after release of the device, because in several cases you saw a deterioration of mitral regurgitation after release of the MitraClip. And the question was, is this also true for the Pascal system? And Peter Lüdecke from Essen here in Germany analyzed this in his center, comparing the first 100 MitraClips and Pascal system. And he observed how strong the mitral regurgitation deteriorated after release of the device. And you can see here in MitraClip, there were about 1/3 of the patients showing a deterioration. In the Pascal system, about 5%. And this is, I think, highly consistent with our personal experience. About 1 of 3 patients gets worse, not completely severely worsening, but sometimes a worsening of grade 1, and this is really, really annoying in the end. Actually, we cannot really explain why this is. I don't know what kind of design feature is responsible for this, but the observations across centers are highly consistent on this. And I think, and again, an important point to consider when you choose your devices. And I want to come to the conclusion. I think the Pascal precision system provides several important features in enabling individualized, safe, and effective transcatheter treatment of MR. We will not be possible to prove all the individual features with respect to evidence-based criteria on efficacy and safety, but I think some of them are really supported by observational evidence and some are supported just by rational thinking. Thank you very much.
Thank you very much. Excellent talk, Dr. Pfister. And we will continue to the next talk, which will be delivered by Dr. Yang Jian from Xi'an, mainland China. The topic he want to talk about is 3D simulation for mitral tear, which which can facilitate or improve the outcome of the procedure. Dr. Yang, please.
Yeah, thank you, Dr. Yin. And I'd like to express my gratitude for inviting me to attend this Taipei Valve Summit. Today, I'd like to give you some experience from our center about the 3D simulation for the mitral tear. I already read from this morning about TAVR session and the two speakers about the tear session and learn a lot. As we all know, the tear technique developed over 20 years, but it will also have a very, very huge market potential. More and more people will be benefit from the tear. It's definitely inevitable. So we should learn how to grasp the tear technique. In mainland China, the situation is different from Japan and from Germany and also from Taiwan. Here, we only have the mitral clip. About 2 years ago, the mitral clip generation 3, G3. And after that, last year, we have domestic 2 types of tear device. One is transapical and another is transfemoral. The transfemoral is Dragonfly, and this one is transapical one is valve clamp. So now we have only 3 commercially available devices. Yeah, this is our current situation in mainland China. But we also have some clinical trial devices which combined the design from the mitral clip and also from the Pascal. For example, like the Gemini 1 device from the Peijia Medical, they have a special design, and also the Dragonfly device. Probably they combined the design advantage from the current available devices, and they have come into clinical trial in a lot of centers, because here all around China is just around the thousands. It's relatively little experience compared with Europe and also from Taipei. We know that the echo evaluation is very crucial for tear. And as the speakers mentioned, each patient have different anatomy. For example, different area or different zone prolapse. And we have the echo, we need the very, very clear echo. We have the 3D echo to show, we have also the color to identify the position and the area, and also how maybe the etiology, a lot of considerations. So that means we need highly rely on the TEE evaluation for a very successful tear procedure. But as we all know, the TEE, we need a very good echocardiologist, and also the patient varies from patient to patient. We should have very clear image. The operator should very, very well know the echo image. So that can, for example, some operators are cardiologists, others are surgeons. So they have to study a lot from the echocardiologist. And now, you know, in mainland China, we just studied it here compared with the TAVR procedure. For example, in our center, we performed over thousands of TAVR, but we only limited less than 30 cases of TEER. So we need a lot of promotion of TEER, but we know there are some obstacles in TEER promotion in most centers in China, because for operators, we have inadequate knowledge of the mitral valve apparatus. The lesion is very complex, is from person to person, and we have transseptal puncture. If a good transpuncture site makes it easier, but if not a good puncture site, it may be extremely difficult. And also, this TEER procedure is extremely rely on the ultrasound technique. So, I just, in my opinion, I just think of a method to help to promote this TEER procedure to be spread, to help more operators to grasp this technique to benefit more patients. So I just think about the 3D printing technology or the 3D imaging technology. It also can be used in medical area, in education, and also in research. It helps to make a individualized, precise, and also some automatic plan for each patient. I think it has this kind of benefit. I'd like to give you a brief introduction of the 3D printing technology. It's just developed recently, and it's from the CT, echo, MRI, the data, and analyzed. Now we have also AI or deep learning technique, which helps to make more accurate analysis. And then we use the digital printer, the 3D printer, and we do some post-processing technique to make the patient-specific model for each patient. And now there's a great advances in cardiovascular 3D printing material, from the mono color to multi-color, and from the hard tissue material to soft material. Now we can make from the anatomic model to the functional model. Now we can see we have this kind of model from multi-color and a multi-material combination. So it helps to understand the anatomy, to practice a lot, and to help us to, especially useful for the structural heart disease intervention. Among the literature, we see it started to use the 3D printing technique used in structural heart disease, especially in TAVR procedure. It can simulate the gradient of the aortic valve, and it simulates the TAVR procedure. And also we just make forward from the aortic valve modeling to the mitral valve modeling and print it out to make a simulator. We developed a simulator with Marker Medical. We developed a TEER simulator to just help the operators and help the company to spread this technique. You see, this is a circuit of the technique, the simulator. We can change this part. We just make the leaflet. We can see the leaflet can be open and closed. And also it can be this echo. Oh, sorry, there's a sound. Yeah, so we can see that this can be seen also in the echo, and this is an upgrade simulator. We use this simulator. You can see we use a device just in vitro to help the operator to know how to use this kind of specific device. We have maybe around 5 to 10 different types of TEER devices, most of them in clinical trial, or some more early in animal study period in China. But here, and also we have very, very few cases in most centers. Only less than 5 centers in China have done more than 100 cases of TEER. And most centers do not have very experienced a lot of experience. So we need to spread this technique. And also for me, for my team, I think that we have a lot to learn from different company, from different anatomy. So that's why it's very important for the simulation of the TEER procedure. It helps the students, for the colleagues to manage, and also from echo, from also whole the team to grasp this technique to know very specific, especially the transeptal puncture and also the delivery system, everything about the TEER procedure. It helps to conquer the learning curve of the procedure. Another thing is very important. Another aspect is about the personalized strategy making for the TEER, because each patient is different. Here because every patient, we do not so much patient. We do every patient very, very carefully. Not only we do the echo, we also do the CT scan for each patient. So we can now have the 3D modeling from the CT scan, but then we can use combination with the echo image to comprehensively anatomy knowledge to get the detailed information for each patient. For example, this is the P1, P2 prolapse. So we know the area, the length, and everything about the patient, and we can make a very precise TEER strategy for the patient. And also now here, with the help of the Wei team, led by the Dr. Patient-Jie, they have done a zero fluoro TEER. We just invited him and his team to help us to perform this without the fluoroscopy. We only do echo guided. This is more difficult, especially for the complex in the yellow zone area. The patient, we can also do this, but we need much more skill. So how to do that? We should know everything. For example, especially it is only guided by the echo. So we should know the transeptal puncture site, or we pick a very, very good site, and we know the adjustment in the atrial about the device and the orientation adjustment, and the leaflet grasping. Close the leaflet. Each step is just similar to match clip and the Pascal. I just show you very briefly. And also, we can see the color, the regurgitation jet, it's disappear. Or there's a radio jet. We do to show if we need another clip. So we see the tissue bridge, whether it's in the spatial is stabilized, and also the mitral valve pressure, the average. And also we use the 3D modeling, digital 3D modeling, to see this is another patient. Use the 2 clips. We see how stable, and to examine how successfully we have performed this procedure. So I think that, in my opinion, the 3D printing technology can help us to make a safe, precise, and efficiency TEER procedure, and helps us to grasp this technique to use very latest devices. We have make a very precise clip strategy for each individualized patient. We started only 2 years ago in 2022, but now this is the first 10 cases. Now we performed less than 30 cases. We use different type of device. All of these devices in clinical trial, because although there's currently available device in China, but they are not allowed into enter our hospital. Hopefully, we will use these three kind of devices in the latter part of this year in our center, and we will have more experience. Last, I'd like to give you a brief summary. I think the TEER technology, TEER procedure should be grasped by more and more doctors, especially the cardiologists and also surgeons. We have a huge care from this high-risk MR patient, and also for TEER, how to make a successful and efficient and safety TEER is very important. We have the 3D printed 3D modeling technique, which helps us to understand the procedure, to simulate the procedure, and to make a personalized strategy making. And also we need a long-term, large sample, multi-center randomized trial to help to assess the benefit of this technique. This is a part of some our publications from 3D printing technology, and especially the middle book is co-edited by me and Tien-Ping, especially for the TEER procedure, the transcatheter mitral valve intervention combined with the 3D printing. Yes, this is just published last year. And we also have a forum in this October. I'd like to invite the experts to attend this online or just inside. Hopefully to see you soon. And last, I'd like to thank you very much for having the opportunity to share our experience. Thank you.
Thank you very much. I think this is a very efficient way to overcome the learning curve. Next talk will be delivered by Dr. Ken Tsao from Hong Kong. The talk is entitled TEER for Concomitant Tricuspid and Mitral Regurgitation. Dr. Ken Tsao, please.
So thank you, Professor Yin and the organizer for your kind invitation. This is Ken from Hong Kong. Sorry for not able to join physically this year because of ongoing commitment in New York Valve. So today I'm going to share with you TEER for concomitant tricuspid and mitral regurgitation. So here's my disclosure. So when we discuss about a concomitant mitral and tricuspid TEER procedure, there are a few questions that we need to address. So the first question is when to do a combined procedure. The second question is which patient to do combined, which do not need a combined procedure. And the last is the easiest question is how to do the combined procedure. So when to do a combined mitral TEER and tricuspid TEER procedure. So we know that TR carries poor prognosis, and very often mitral and tricuspid regurgitation, they coexist. So in degenerative mitral regurgitation, around 15% of the cases has concomitant moderate to severe tricuspid regurgitation. And in functional mitral regurgitation, around 14% of the cases actually also has moderate to severe tricuspid regurgitation. When we refer the patient for open heart surgery, concomitant treatment of both the mitral and tricuspid regurgitation is actually recommended by the current guideline. But it's actually very unclear whether treating both valves should be performed simultaneously using a transcatheter approach. So, but we know that in patients that receive a mitral TEER procedure, if they have a residual severe tricuspid regurgitation, it is actually associated with very bad prognosis in terms of cardiovascular and also all-cause mortality. So leaving alone a severe tricuspid regurgitation is not something good. So is there any evidence recommending to performing a combined procedure? So there is a registry-based analysis performed by European centers. They actually pull up the TRAMI and also TriValve registry. The cohort of patients they actually gather are those that has severe mitral and tricuspid regurgitation in both of the registry. In the TRAMI registry, in this cohort of patient, they only perform an isolated mitral clip procedure, whereas in TRI-valve, in this cohort of patient, they actually perform a concomitant mitral and tricuspid valve edge-to-edge repair. And after a matching analysis, it is actually found that in patient that has a moderate to severe, in patient that has a severe mitral and tricuspid regurgitation treated with a combined procedure is associated with more favorable mortality over around 5 years of follow-up period of time. So having said that, what are actually the pros and cons of performing a combined versus a staged mitral and tricuspid TEER procedure? So when we want to answer this question, we need to understand, very importantly, a percutaneous intervention is actually very different from an open heart surgery. In open heart surgery, once it goes in, you don't want to leave a residual pathology behind, because a repeating open heart surgery is associated with technical difficulty and also an operative mortality. And having this in mind, the percutaneous approach, repeating it is actually not that severe in terms of patient's risk profile. So, and then we need to consider whether the TR require treatment or not, because 1/3 of TR actually regress after a successful mitral TEER procedure. So if you do upfront concomitant procedure in unnecessary patient, that will be associated with unnecessary risk because of the longer procedure time and the associated transesophageal echo related complication. And the operator might be fatigued after a prolonged procedure that might be associated with a suboptimal outcome with the subsequent TEER procedure. Having said that, if you are able to do a combined procedure, then you might be able to reduce the need of a repeated general anesthesia, repeated intubation, repeated vascular access that is associated with more complication. And more importantly, these cohort of patients are usually older and frail, and do a combined procedure could avoid another hospitalization. Some of the administrative consideration in different locality of the world, it will be the reimbursement issue, because in some country, a combined procedure is not reimbursed equally. So that's also important. So what about doing a combined procedure? How is the procedure outcome? So from the biggest European registry, we can see that a combined versus an isolated procedure is actually having a similar procedure outcome, but then a combined procedure in experienced hand has around 50 minutes of additional procedure time. Very interestingly, in their analysis, is actually find out that the combined procedure is actually associated with a trend towards shorter procedure length of stay. I suspect it's because after you treat the TR, you need to, you don't have to keep the patient that long for a medical optimization. But in these analyses, there are some limitation, including the operator's experience and also the anatomy of the MR and TR actually are not taken into consideration when they make the decision. So which patient we should actually consider to do a mitral and TEER? So as I mentioned, it's very important to avoid unnecessary procedure at the very beginning. So if we anticipate a patient has a chance of improvement after a successful mitral TEER procedure, then we can actually avoid doing a concomitant procedure. But if we anticipate a patient will have severe residual TR, then a combined procedure is reasonable. So in your intervention 3 years ago, there's a European analysis find out that in patient that has atrial fibrillation, tricuspid annulus more than 34 millimeter, or a more than moderate residual mitral regurgitation after the mitral TEER procedure, these 3 factors actually associated with a severe tricuspid regurgitation during a follow-up period of time. So it's reasonable to pick up these cohort of patients for considering a combined mitral and tricuspid TEER procedure. Apart from patient factor, it's also very important to take the operator's expertise into consideration, because it is actually very easy to understand there's a learning curve in doing a combined procedure. It is shown that in early period of experience, the procedure time is actually significantly longer compared to a subsequent period of operator's expertise, and it's also associated with a better residual TR in later experience. So the team's experience, including the operator and also the echocardiographer, is very important when we consider whether to perform a combined procedure, one team has to be competent in performing mitral and TEER as a standalone procedure before they perform a combined procedure. So last bit, the simplest portion is how to do a combined procedure. So conventionally, we perform the mitral TEER using the mitral clip steerable guide and then pull back the mitral clip steerable guide to finish the tricuspid TEER using the mitral clip steerable guide catheter. The limitation with this approach is the mitral clip system does not have an SL knot, and the guide curve is actually having longer tip. So that would actually compromise the result of, and technically will be more difficult to finish a TEER procedure. The second, more conventional and most adopted approach will be to use the dedicated system for using a mitral clip system for the M-TEER, use the tri-clip system for the T-TEER procedure. Then that ideally is the best, but then you need to exchange out the steerable guide catheter that would be associated with a longer procedure and also would potentially increase the risk of blood loss during the catheter exchange. A more novel, recently more adopted in different centers approach will be to use off-label tri-clip steerable guide system to complete the mitral TEER and also to finish the tricuspid TEER procedure. Then you would avoid the need to have a catheter exchange because it's the same guide just pull back from LA to RA. And the additional benefit that we see is the SL knot of the tri-clip system might potentially allow you to gain or shed height if the transeptal height is suboptimal when you're doing the M-TEER procedure. So this is a video showing how we actually perform a combined procedure. In this case, we also combined a left atrial appendage procedure. So after a successful transeptal puncture, we actually put in a 4 French MPA guide catheter to keep the left atrial axis for subsequent appendage closure. So we finished the mitral clip system using the tri-clip steerable guide in the left atrium. So after an optimal result is obtained, we then pull back the tri-clip steerable guide from LA to RA and then complete the tricuspid procedure. And then using the MPA guide catheter that's remained in the LA, we exchange to a stiff wire and then back to a appendage delivery system and to finish the appendage closure. This is how we finish this 3 procedure combined together. So we actually have pulled up our experience around 8 cases in the early days, which is published in Jet Intervention a few months ago. And so when we look into, although now we have more experience, but when we look into the first 8 cases, so you can see that most of the cases are atrial functional mitral and tricuspid regurgitation because of the reason I just mentioned. So technically, we actually use a more posterior transeptal access point, mainly because of the shorter steerable guide curve for the tricuspid system. There's a limitation with our experience because majority of the mitral clip we implant are at A2P2. So whether this technique is actually applicable for a more extreme anatomy like commercial A1, P1, P3, A3 depends on the subsequent experience that we have. So we also have document the procedure time. There's an additional 45 minutes time for a completion of a TEER procedure, which is actually reasonable because you can see we have implants 1 to 2 clip in majority of the cases only. So to conclude, TR is actually common in patients with severe mitral regurgitation receiving M-TEER procedure. Residual TR carries poor prognosis. So serial monitoring plus or minus stage TTR procedure after an M-TEER procedure versus a combined mitral and tricuspid TEER procedure are both reasonable strategy to tackle these patients. And the optimal approach will depend on the patient's anatomy and also the center's expertise. Finally, using a tri-clip guide for concomitant mitral and tricuspid TEER is actually a feasible and safe approach as demonstrated by our experience. Thank you very much.
Thank you. Welcome. Thank you, Dr. Kenzo, for your excellent talk. And this is a very one-stop shop, really. And the next talk will be delivered by Dr. Shih-Hsien, who is also a master in this field. And he's going to talk about troubleshooting dual TEER procedure.
Thank you for the kind introduction and having me in Taipei Valve Summit and to present the topic, the troubleshooting during TEER procedure. Actually, it's a mitral TEER procedure. This is my disclosure. And this slide has summarized all the potential complication or the trouble we might encounter during the mitral TEER procedure, which could be related to procedure or per se, or related to the devices. Including that, in addition to the transeptal puncture, we use the TEE image guiding, and also by doing the femoral puncture, sometimes we might encounter vascular complication, and the best strategy is to prevent the associated complication, and therefore the sonographic puncture would be highly suggested. And some would be related to the anticoagulation resulting in bleeding or ischemia, embolic event. So therefore, during the procedure, we have to keep a good acceptable ACT. In our institution, we prefer 250 to 3,000, which might be lower comparing to the recommendation from Western. And also the most associated complication we might consider is related to the clip per se, which could be single leaflet detachment or leaflet tear, and which, according to the average 2 trial, the earliest one clinical trial, which there would be 0.5% of chordal rupture, leaflet injury during the procedure. So therefore, let's talk about each potential trouble complications. And actually, when a femoral vein go into the pelvic, there would be some patient would have very acute angle. So when you advance the device, you have to be very cautious. So this is a communication from the publication that the guide kink in the femur coming in the artery and causing the EDA vein rupture, and which can need to be rescued by the surgeon. And sometimes if the injury is not too much, we probably can put on a cover stent. Oh, this is a complication related to transeptal puncture, the case from my friend, Dr. Angelus Chu in Hong Kong. And from the left hand, from the image, you nicely showing that after transeptal puncture, the injection test is showing the bubble appearance in the pulmonary artery. And therefore, we might, therefore we are aware that we might have the complication related to transeptal. So during that position, we applied the VP2 to plug the transeptal path from the pulmonary artery to the right atrium and to redo the transeptal puncture and finish the procedure, given the patient is a very elder lady with high surgical risk. So when we encounter the related transeptal complication, if they just needle cross the septum, you just pull it up, maybe you can stop the seizure without any complication. But if the sheath or dilator already passed the transeptal, the septum, or passed to the other chamber, we probably have to rescue the complication by using plug-in or occluder. And usually for patients with very small atrium, we would go too much posterior. And remember, there would be interatrial groove during the posterior septum, and which has been published that after the procedure, after the finish the mitral TEER procedure, when we restore the steroid guide, and followed by the severe cardiac tamponade. So if we can aware of that, maybe we can plug the defect before we throw the guiding catheter. But of course, to be aware of that, we can prevent would be the best strategy. And regarding a leaflet tear grasping, which there was a very good international registry of the failed mitral clip procedure. Among over 4,000 mitral clip procedure, there will be 3.5% of mitral clip failure due to either single leaflet detachment or leaflet tear, or even clip embolization. Majority of the case will be diagnosed during the hospitalization. So, and 60% of them can be fine on the other day. So in this registry, 1/3 of the patient will receive redo mitral clip procedure, And 50% of them would be put on medical conservative treatment. And only less than 20% of them would receive surgical intervention. And from the Kaplan-Meier survival curve, nicely demonstrate that for patients who receive redo mitral clip procedure, actually have a trend to have better long-term clinical outcome. And among those, mitral clip failure procedure, the redo procedure can achieve about 60% MR reduction less or equal than 2+. So even have a single liver detach or even liver tear, we still can consider the redo mitral clip procedure, especially for patients with high surgical risk. This is our patient, 78 years old lady with has history of acute myocardial infarction. So the patient has severe secondary mitral regurgitation. The HH referral is 31. This is a very severe mitral regurgitation. So during the procedure, it is nicely that we have got a both leaflet. This is early experience using the classical mitral clip devices. So you can see the gripper can only be lower at 30 degrees, 60 degrees. So after grasping, and we thinking that is a very good sign that would have both a leaflet. And also we have very good MR reduction during the procedure. And also the gradient is only 4. So like this, we can achieve a sufficient MR reduction for this patient. However, on other days, even the patient did not complain anything, but the following echo, transthoracic echocardiogram showing that the patient had recurred a severe mitral regurgitation. So by using the TEE image, further demonstrate that would have single liver detachment. After review the case, the past cases, this case, we thinking that probably during the procedure we fold the posterior liver, and therefore we did not really get sufficient posterior liver, which resulted in single liver detachment. So the best strategy for this patient, functional MR, of course, redo mitral clip procedure would be the only result. So this is the remain severe MR, and therefore we'll go for redo procedure, resulting in a mild residual mitral regurgitation. And during the follow-up, patient comparing to the baseline have very poor LV function and also dilated right side chamber. After the procedure, the patient actually got very good reverse remodeling of left ventricular function. So this is very important. During the grasping, if you can see the very good sign for the gripper bouncing, or during the closing, you can see the Sika sign, which indicate that we did have leaflet inside the clip. And the most, sometimes if we encounter leaflet tear, which would be very difficult to be deal with, if you use the short arm, if the tear is caused by the short arm clip, we probably can overcome the situation by a long arm clip, long arm and wide clip. But if not, sometimes in these published cases, which have additional clip beside the tear leaflet, and then put on a vascular plaque and deal with the severe mitral this complication. However, according to the publication, there would be only 50% of success rate in this situation. So sometimes this may not be a good, but could be the last result. And even during after the successful mitral tear procedure, we still might encounter some situation we don't want to have. This is a 87 years old lady, has history of atrial fibrillation. The image nicely showing that the patient has severe mitral regurgitation and also torrential tricuspid regurgitation. The patient has had very low cardiac index, 0.64, and high RA and also wedge pressure. The mean eye pressure 35 compared to wedge pressure 21. So it is quite common that after general anesthesia, the patient with severe MR would have very low blood pressure. So the patient has very significant refractory hypotension after general anesthesia. After very quick put on a clip to deal with the severe MR, we can see the pressure went up. And after we saw the guide, we saw that there is a very significant right to left shunt. And you can see the saturation from 90-something and drop to 80-something. And even we increase the FiO2 to 100%, the patients still have very low saturation. So this could be foreseen before procedure if the patient have high eye pressure or if the patient have very severe tricuspid regurgitation. We probably need to, thinking after we draw the guide, what we can do for the patient. Sometimes we plug the defect, or sometimes for this patient, we can, clip, deal with the tricuspid regurgitation. Just what Ken has said, that we do the concomitant tricuspid tear procedure. So after the only simple anterior septal clipping, we can see the saturation was increased. So every clip, maybe the first clip might increase might decrease the TR by at least 20%. So there are also some device-related issues. This is another patient, 82-year-old gentleman with right heart failure, has P3 commissure flare. So after successful grasping with NTW clip, we see that it seems that the outcome looks perfect. However, after release, deploy the clip, we saw the clip was opened a bit almost in 30 degrees. So therefore, we have very severe residual mitral regurgitation. So how can we rescue this condition? This is our very rare experience of clip dysfunction, and therefore we put on a second clip beside the first clip, try to stabilize the first clip. Sorry. And then after the first clip, we then put on, we measure the residual MR and thinking about we might able to plug the commissure position. Even the width is only 0.6 millimeter, and we can see that if we can plug this commissure, and then we probably can deal with the So therefore, then after the two clip, we see the residual regurgitation arising from the commissure part. So we plug, using a VP2 plug, the commissure defect open. Sorry. So you can see that we have remained a severe mitral regurgitation from the commissure. So how can we rescue this condition? So we put on the second clip beside the first one to stabilize the clip. And then we can see that comparing to the baseline MR, we did reduce the MR severity. However, the patient still have severe MR. So we measure the width of the remaining, that would be 0.4 centimeter. And therefore, we try thinking about maybe we can plug this position. And then we use VP2 to plug the medial commissure. So given that we have two clips on the leaflet, so which is give us sufficient support for the vascular plugging. So after the plugging, we see that we almost can reduce the MR to mild residual MR, and the gradient remain acceptable. So this is another case, 91, torrential MR, bowel appearance, and also P2 flare, very small mitral valve area. And also after clipping, it looks that the procedure looks perfect, and then we can reduce to mild MR. And again, when we deploy the clip open again. So this time we try to also want to try stabilize the clip and to prevent future embolization. So we put on another long XT clip so we can still have a good procedural outcome. So the residual mild MR and also the grading was only 3. This is the 3D picture after the procedure. And the follow-up showing that the patient did not, compared to the baseline, have very good improvement in MR severity. So this is the last case from my friends, Dr. Gu Yonggang from Korea, showing that he treated mitral regurgitation by using 2 clips. But the second clip, the lock line was trapped in the system, so he cannot pull out the lock line system. So therefore, when you forcefully pull out, the clip open in the left atrium. So he nailed it out and then to finish the procedure. So for this particular situation, we need to confirm that there would be any knot on the lock line, and if there is any knot on the lock line, you might result in such complication. And last one would be related to TEER, the TEE per se. When patients have very dilated right atrium, which the esophagus might be pushed toward the descending aorta. This is a piece from Japan showing that when you have very large angle dorsiflexion, which might injure the aorta and causing the aortic dissection. So this is my presentation. Thank you.
Thank you. Dr. Cheche stay in another time zone, so he could not make it. But he have a pre-recorded video. Am I right? Okay, great. Okay. No sound.
One of the questions that we see and we hear again and again during many meetings is trying to anticipate what is going to be the default strategy for transcatheter mitral interventions in the future. And in 5 years, we don't really know if it's going to remain TEER, mitral TEER, H2H therapy, or whether it's going to be transcatheter mitral valve replacement. So this is quite a vivid debate, and I will try to make you understand when we can position transcatheter mitral valve replacement. A very first important message is that we have quite good clinical and anatomical echo results with mitral TEER with the devices that we have so far. And there are plenty of data in the literature to support that. So we can clearly see that mitral TEER achieves good clinical results. And if we take a couple of examples briefly from the EXPAND G4 registry, you can see that in this larger score on echo and clinical outcomes at 30 days with the 4th generation of the mitral clip, significant mitral regurgitation less than grade 1 was achieved in 91% of the patient, a very short device time, and clinical significant improvement in quality of life for the patient. So a broader range of anatomies can be treated safely with this G4 device. For the Pascal, we have had a couple of years ago the CLASP 2D registry that was first presented at TCT, showing that there was equipoise between the mitral clip device and the Pascal device for a degenerated mitral regurgitation with similar clinical outcomes with very few events and extremely good efficiency for mitral regurgitation elimination and very minimal gradient. So we can see that both contemporary devices, the mitral clip and the G4 mitral clip and the Pascal devices achieve very good clinical outcomes. But what we also know is that there are over repair devices that are in the pipeline. And I just wanted to briefly touch upon this device, this over repair device, that is the NeoCore Nexus, a transcatheter mitral valve repair device that is aiming at treating mitral prolapse. And the real target is what we see most often is the P2 prolapse. And it's really a device that targets that type of disease. So it's deployed with several steps. The first one being to get the transeptal access, and for those who are TEER operators or TEER echocardiographers, it's quite similar to what we do with the TEER device. Then the device is designed to capture the leaflets and to deploy as cords, sutures. Then an anchor is deployed in the papillary muscles, and many cords, as many cords as we want, most of the time 2 or 3, can be attached to that anchor and to try to secure the mitral prolapse and to enhance the coaptation of the mitral leaflets. And this is a type of result that can be achieved. 1 anchor, 2 cords for this patient in a really nice final result. But we have to be honest. And another important message is that some mitral anatomies are not suited for a mitral tear, and they are too challenging. We know that mitral regurgitation is a very prevalent disease, but at the same time, it's extremely heterogeneous. We have multiple classification. The one that is broadly utilized is the Carpentier configuration, the Carpentier classification, and you can clearly see that there is no single mitral disease that is like the other ones. Every patient has his anatomy. The mitral annulus has a different diameter, the location of the papillary muscle, so the interaction of the mitral annulus and the subvalvular apparatus is specific to each patient. So we have a very heterogeneous disease. And this has been captured in the heart valve collaboratory document that we're going to see. But what we also know, despite the fact that the current mitral TEER device achieve exceptional clinical and immediate results, what we also know is that if we leave the patient with more than mild mitral regurgitation, this is going to have an impact on the survival, death, and heart failure hospitalization at long-term follow-up, at least at 1 year, and this has been demonstrated even a longer follow-up. So these data come from the Ocean mitral registry, but we've seen the same thing in the COAPT trials as well. So there is consistency. We have to achieve the best result for the patient and make sure that we're not going to leave a more than mild mitral regurgitation, because this is harmful. And even with the experience, and this is a patient of mine, you can see that despite the fact that the patient was treated with 2 Pascal devices or MitraClip devices, there was a moderate residual mitral regurgitation and even a mild gradient for this patient because the anatomy was not favorable. 2 tapered leaflets, a bit of calcium at the aortic, at the mitral annulus, and this is going to impact the final procedural result. And so we know that this has an impact as well for the patient. So, as I said, this has been captured in the heart valve collaboratory document. And if we scroll from left to right, from the green to the orange and the red, the green, yellow, orangish, and red, we can clearly understand that there are on the left side of the slide favorable anatomies like the central coaptation gap, the P2 prolapse, no calcium, very large leaflets, very large left atrium, very large mitral annulus. So the risk of a high residual gradient is not that important. And when we go to the right part of the slide, there are less favorable or even unfavorable anatomies, the ones with MAC, mitral annulus calcifications, TEFR, extremely TEFR, leaflets, non-central jets, commissural disease, rheumatoid disease, multiple jets. So all these configurations can lead to either a more than mild final regurgitation or a high residual gradient, and this is not going to improve the patient. So a key message, TMVR, when to position TMVR, it has to be considered when we have hostile anatomies. And so let's end up this talk with a couple of examples. So this was a patient treated with the Intrepid device, and you can see the type of anatomy that is tackled. This rheumatic disease, you can see that the leaflets are really thick leaflets, and particularly at the tip, multiple jets, a gradient at baseline that was more than 5 millimeters of mercury, a very depressed LVEF, mitral annular calcification, so clearly not a good candidate for TIA. And so this patient was treated with the Intrepid device. So you see the transeptal axis, so it has to be as quite high, around 4 or 4.5, just to make sure that we can navigate appropriately and steer towards the mitral valve. And here you see the deployment of the atrial brim and then the rapid pacing to finally expand the ventricular portion of the device. And this is the type of result that you can obtain with these TMVR devices. No regurgitation, a very minimal gradient, and if the patient has been carefully selected, no LVOT obstruction. Another device that wanted just to present is the High-Life transeptal mitral valve replacement solution. High-Life is a very interesting device that is accumulating more experience with more than 100 procedures worldwide, more than 30 teams that have utilized the device, and it has been lately, based on the clinical results obtained in Europe, lately approved for an IDE trial, a pivotal study in the US. So the device is deployed through via three steps. So the first step is to create a loop just beneath the mitral valve and around the mitral cord there above the papillary muscle. A loop is placed, and through this loop, for the second step, is going to be the conduit, the track, the path for the ring delivery. A ring is going to be deployed and placed just below the mitral annulus. And the third step is the deployment itself of the prosthesis, and then all the wires are removed. And so it's a 3 steps procedure that has a kind of learning curve, but afterwards the results are great. So good clinical outcomes, as I said, very, even in this initial experience, very high and frail and high-risk patients. So the ability to decrease mitral regurgitation was very important. So in summary, and this can be quite simply stated, when to position mitral replacement. The very first thing is when we have an unfavorable mitral anatomy for transcatheter edge to edge, and when we expect either a high residual regurgitation, a great residual regurgitation greater than mild, and or a high gradient, because this is going to be harmful for the patients. There are a couple of limitations to date for the TMVR devices. The first one being the dimensions of the mitral annulus, because we don't have a full range of sizes for every single device. So it has to be suitable and anchor enough, provide enough oversizing to make sure that we anchor and seal the mitral anatomy as appropriately. And the second limitation is the risk of LVOT obstruction. You may discuss that, and this is something that the companies are working on. But clearly, when you have an unfavorable anatomy for TIA, and when you expect high residual gradient or regurgitation, mitral replacement should be considered. So I thank you very much for your attention. I'm really sorry not to be able to attend physically, and I wish you all the best for the rest of the meeting. Bye-bye.
Okay, thank you. Now I ask some brief comments from from the panelists, starting from overseas experts. Dr. Roman Pfister, would you like to say a few words to this session or make some comment?
Maybe I have one question for the first speaker. The unmet needs. What, to your personal experience, is the main cause for rejecting TEER therapy to patients?
Thank you so much. It's a quite relevant and important questions. Actually, my personal experience is quite limited in Japan and some experience in Italy, but we face, since Japanese patients have small anatomy, small body size, so on, so we have quite small left atrium, although the patient has severe mitral regurgitation. So dealing with these small anatomy could be challenging, and also have limited area of mitral valve area. So that's what is always deal with heart team conference, whether we go with the TEER device or could carry a risk of significant mitral stenosis at the end. But as you mentioned in your nice talk, the Pascal device, we are still in the early learning phase, but I would like to ask your experience so far, because this spacer could potentially helps for preventing this potential significant mitral stenosis after the procedure with this 19-0 configuration. So how is your impression, and how do you make a device selection for which device for which anatomy?
Yeah, difficult question. I mean, my personal opinion is also, even maybe people are bigger in Europe, that the initial opening area is the main preclusion for TEER therapy. And we increasingly see atrial functional MRs as an etiology for TEER. And this is the typical elderly women who are usually smaller and might not have a problem with their valve regarding opening area, but might have initially just a small heart and a small opening area. And in some patients, the spacer might be a solution, but if it's in the end just a small heart, I think the spacer will not make the difference. It's just, just not possible for TEER to be successful. And the individualization of device selection, of course, is difficult because it is a lot of gut feeling, as I mentioned in my talks. There are some hints from the design to select one or the other, but it is really difficult to focus on strong evidence from large comparative trials. So, as I mentioned, with respect to the functional MR, with a lot of tethering, with maybe a coaptation defect in the center, which is usually reduced ejection fraction patients, I think there the P10 device with the spacer is very helpful. The atrial situation, atrial MR, you have to look into details. And if you think there is an additional tethering, maybe the spacer might be helpful. But from the thinking of atrial functional MR, you would like to have also a strong annuloplasty effect with the device. And in this situation, the spacer might be counterintuitive. But maybe, large arm, either ACE or MitraClip XT device might get more annuloplasty effect in the end.
Thank you so much.
Thank you. Dr. Kensel, would you like to make some comment?
Thank you, Professor Yin. I do have a question to follow for Professor Woolman. So we have quite limited experience of Pascal in Asia Pacific region. So and overall the TEER volume is actually not that high except in Japan. So I'm actually wondering what is actually the optimal volume for a team to have a second tier device? I know they have pros and cons for each device, but if we don't have sufficient volume, is it good to stay with just one single device, or like what is the optimal number for a team to get at least like 2 devices?
That's a good point. I mean, we did analyze the learning curve after the rollout of Pascal here in Germany. But the precondition was that these were all very experienced centers with MitraClip. So several hundreds of procedures with MitraClip. So it is really not generalizability, these results of the learning curve. I would expect that 50 procedures per operator per year should be minimum for one device, ideally, particularly in the early phase, if you're not experienced with another device either.
Okay, thank you. Professor Yang Jian, any comments or question?
Yeah, thank you. I just learned a lot from every speaker, and I have no extra comment. You know, TIER just started in China and also in our center. We should learn more from the peers, colleagues, and I really cherish this opportunity to be online with everybody, and really learned a lot from you. Thank you very much, Dr. Yi.
Thank you. Thank you. Dr. Song and Dr. Ono, any comments? Or?
And just would like to echo what Didier has said, that given that if we, given that the transcatheter mitral valve replacement devices is now not available in majority of Asia country, just wonder if the device is not available, what kind would you also, go for mitral TIER procedure? Even the reduction, we can only cause some minor reduction in the MR. And according to the previous publication, although we are now pursuing less than 1+ MR, but if we can, using the TIER device to achieve less than 2+ MR, would it be sufficient for patient nowadays in Asia if we don't have them? The anatomy is versatile for TIER, but the replacement device is not available. Just would like to have Professor Fischer, what do you think?
Yeah, difficult to say. I mean, you always want to get at least one or less, and we saw almost in every talk the pictures indicating adverse prognosis if you can't achieve one or less. Of course, in the end, individually, you have to decide what you can get, what you have available, and if you have no chance to send the patient to another center with a more complete armamentarium of devices, then I think you have to think about it. In this context, maybe I would rather be conservative in functional MRs. If you decrease it from 3.5 to 2.5 or something like this, I'm not sure whether the patient will have benefit. In the primary MR population with a good left ventricular function, I think you can have a clinical benefit if you decrease from 4 to 2 maybe. But I mean, this is an individual process and decision making with the patient also. You have to be clear what you can achieve and what this could maybe translate into clinical situation and benefit. But particularly, I think in functional MRs, which are usually not 4 or even worse, but usually are grade 3 or 4, then you have to aim a good result, at least 1 or 1 to 2.
Okay, thank you. Dear Yo-Hei, please.
Final short comment. I think at least for the next several years, maybe up to 5 years, the TIER approach would stay the mainstream because it's extremely safe if we properly select the patients. And as for the TMVR, I was involved in one of the clinical trials, but majority of patients were excluded due to the CT screening because of the annular size as well as the potential LVOT. So I think for the time going, the TIER approach would be the mainstream, but looking forward to the device iteration and the improvement of the TMVR. So would help us a lot for the, not a majority, but small amount of patients that can be not treated with TEERs.
Okay, very good comment. I have to close this session. Thank you for all the speakers and the moderators and the participants who attend this session. Thank you. For patient with low coronary height. First talk should be a pre-recorded one, please.
So thank you for asking me to join you once more for this contribution to the Taipei Valve Summit. My name is Bernard Prendergast, an interventional cardiologist from London, UK. And I'm sorry that I cannot be with you in person on account of the concurrent New York Valves meeting running on the East Coast of America, which makes travel to Taiwan very challenging. I'm very happy to talk with you about our increasing understanding of the challenge of TAV-in-THV procedures, second-time TAVI, and also to bring you up to date with current thinking and recognition of the future challenges that will be associated with this large volume of work. It is an unfortunate truth that failure of biprosthetic valves is inevitable eventually as a result of hemodynamic wear and tear and pathophysiological processes that are still under investigation. Some of these factors relate to the patient themselves. Some of them relate to the biological prosthesis, and some of them are very specific to the technique of TAVI itself. Our success in the realm of TAV-in-SAV, whereby a TAVI is implanted inside a deteriorating bioprosthetic surgical valve, has led to rapid growth of this procedure and its incorporation into mainstream clinical practice in Europe, the US, and many, many parts of Asia. Also illustrated on this slide, however, is the slow emergence of second-time TAVI, TAV-in-THV procedures undertaken for patients who have outlived their TAVI device as a recognition of the fact of the increasing age of the population that we are treating and the increased life expectancy observed by patients even in their 70s and 80s in the Western world and other developed countries around the globe. Enthusiasm for this procedure is growing as a result of the recognition that the alternative of TAVI explant in surgical hands is a technically challenging and risky procedure that has a high mortality even in the most experienced surgical hands. Observational data demonstrated here suggests that repeat TAVI is a better treatment option, and this information has been supported by robust observational data coming from a collaborative group in the USA, demonstrating that a second-time TAVI procedure in carefully selected patients is as safe as the original index TAVI procedure itself, often performed many, many years previously in younger and lower risk patients. Note here primary endpoints at 1 year, demonstrating equivalent outcomes with redo TAVR compared with native TAVR, and further breakdown of this endpoint according to mortality both at 1 year and 3-year follow-up. Therefore providing reassurance that this procedure is feasible, providing that patients are carefully selected and that the procedure is undertaken in skilled hands. These observational data have been accompanied by a plethora of publications from groups, from collaborations, and from registries around the globe, pointing out not only that good results can be obtained, but also that there is much to be learnt in relation to the technical execution of these procedures, which are actually far more anatomically and technically challenging than may first meet the eye. This enthusiasm has also been matched by future market projections, suggesting that over the next 10 to 15 years or so, there will be rapid growth in the redo TAVR sector, and that TAV-in-THV procedures will become commonplace as we rapidly grow the native TAVI market. And this, of course, has commercial implications for industry and our hospitals, as well as volume of delivery challenges for TAVI programs around the world. As we contemplate these procedures, however, there are two major focuses that we need to amalgamate into our current clinical thinking. The first relates to the index TAVI procedure in the modern era, where we need to recognize, in the words of the pop songs, that the first cut is the deepest. In other words, the index TAVI provides the platform for all subsequent procedures. And in the modern era, as we treat younger and younger low-risk patients, we need to make equivalence to surgical aortic valve replacement our goal. It is no longer acceptable to be relieved when the patient relieves the cath lab or returns at 6-month or 1-year follow-up. We now need to consider a long-term investment, TAVI, a long-term investment for the patient, with attention to detail at the time of the index procedure itself. This involves considerations outlined on this slide, and focusing in more detail, we need to ensure that we achieve optimal hemodynamics with minimal or no paravalvular aortic regurgitation and low valve gradients that will reduce the possibility of patient-prosthesis mismatch over time. Secondly, we need to take on board lessons of the last 5 years relating to commissural alignment to ensure that our TAVI devices are implanted in anatomically appropriate locations, thereby ensuring best hemodynamics, but also ensuring optimal and simplified access to the coronary arteries many years later. In this context, we also need to readdress our current algorithms for the implantation depth of coronary devices. Until now, we've been encouraged to implant devices as high as possible to mitigate the risk of peri-procedural pacing requirements. But as we begin to think of the future and the need to engage the coronary ostia in both the elective and emergency setting, we perhaps need to readdress our height algorithms to ensure ease of access to the coronary arteries over future years. Secondly, we need to understand that the second TAV-in-THV procedure is by no means as simple as it looks. And our original concept that repeated stent within stent type procedures are actually not as straightforward as they may seem when the location for our device is in the aortic root. To contemplate the fact that the original TAVI device effectively becomes a tube graft when a second device is implanted inside it. The TAV-in-THV will pin the leaflets of the first transcatheter valve in the open position, in other words, and this has important implications for the second implant procedure. Firstly, the type and size of the second TAVI device will influence the diameter of the tube graft and the associated hemodynamic function. And secondly, the depth of the implant of the second device will increase or decrease the height of the original tube graft. And this is of particular importance, as I have emphasized, in relation to the ease of access to the left main stem as illustrated here, which can be either facilitated or physically obstructed according to the height of the original TAVI implant and its second interaction with the skirt at the time of the second implantation. This leads us to further considerations regarding the accuracy of our procedures and our ability to implant devices at the precise location intended in the heat of battle in the cath lab, with motion of our devices and variability of positioning according to anatomical constraints and movement even under rapid ventricular pacing. It may well be that TAV-in-THV is a particular scenario where more advanced models of simulation are appropriate, as illustrated here with the FEOPS artificial intelligence-driven simulation tool. And this tool and others of similar design may well be of particular utility in this clinical setting. Going forward, we have a lot to learn, and there are ongoing international registries, not only here illustrated in the US, but also here in Europe, where multi-center experience in high volume centers with procedures being undertaken by operators with 10, 15, or even 20 years experience of TAVI will be essential in defining the anatomical restrictions of this procedure and the important implications for widespread clinical practice. At practical level, we also have the availability of the Redo TAVI app, designed by Vinny Bapat and co-workers in Minnesota, USA, and now commercially available on via the App Store and other outlets for use with Android devices. And in much the same way as the Valve-in-Valve app has become part of our daily practice, this will now become the case for the TAV-in-THV app as our exposure to these procedures increases. In summary, therefore, in this short talk, I've illustrated, I believe, that TAV-in-THV procedures are currently rare, but their volume is likely to expand rapidly as we use TAVI in younger and younger patients. In carefully selected patients, the procedure is safe as a native TAVI procedure, but there are important anatomical considerations that we need to incorporate into our planning, particularly with CT and other advanced imaging tools. We need to learn more about optimal hemodynamic performance. We need to ensure maintained coronary access, and only when we have achieved these goals will we obtain satisfactory long-term outcomes for our patients. Careful CT planning is essential, as I have emphasized. Detailed understanding not only of the original valve, but also the way the second valve will behave inside the first one is essential. And our ongoing clinical collaborations across the world will help to advance the field over the coming 10 to 12 years. Thanks very much for listening.
Well, very good talk regarding the TAVR-in-THV. We thank Dr. Bernard Prendergast. And the next talk will be delivered by Dr. Ko Young-gu from Severance Hospital, Korea. Dr. Ko is a very experienced operator of TAVR. He is also, I think, one of the pioneers to use eyes imaging to guide the TAVR procedure. Let's have his great talk, please.
Thank you, Dr. Yin. I'd like to express my gratitude to Dr. Yin and organizing committee for giving me a chance to talk my topic. The two main reasons why we need imaging guidance for TAVR include assessment of procedure result. I think the severity of paravalvular leak is, I think, the most important factor we need to assess. And also the detection of, early detection of complications, especially when the patient experienced hypotension, then we have to look for the potential causes of the hypotension. Recently, I think the MEC anesthesia, I think, is the favored anesthesia method for TAVR as the procedure progress to have a minimal approach. A study published in 2021 showed that the outcomes in terms of all-cause death and the MACE showed no significant difference between general anesthesia and the MEC anesthesia for TAVR approach. However, the ICU stay and hospital stay were much shortened with MEC anesthesia. So this is our experience. So up to until by 2018, so 17, we used only general anesthesia for TAVR procedure. However, after 2018, most of cases, over 95% of our cases are done under MEC anesthesia. And for the general anesthesia, I think the TE was the standard method for the image guidance. However, with MEC approach, currently the TTE is more favored. However, despite the advantage of the TTE, which are the ready availability of the device and low cost, and however, there is a problem such as suboptimal image quality, especially when the patient is in supine position, and also when the patient is obese and also has some COPD problem. So also, if you want to use TTE, then there is interference of fluoroscopy, so it is disturbing when you do TAVR. Also, there is issues like contamination of the operating field. So in that sense, ICE is very attractive method for the imaging guidance because it has very excellent image quality, and also you can perform as an operator ICE concomitantly, so you are independent of imaging specialist. However, on the other hand, it requires high cost, and if you need some learning curve. This is a small randomized trial comparing ICE versus TE for TAVR procedure. Actually, the measurement according to based on ICE work correlates very well with the measurement of the structure by TE, and but the frequency of repositioning of the catheter is much less with the ICE, and for the visualization of the coronary ostia found to be much better with the ICE compared to TE. In Korea, we have two ICE catheter types, so AcuNav 5 and ViewFlex. I think these both the catheters are very good catheters. However, they have some different advantages. ViewFlex is very good. It has very good grayscale imaging quality. However, AcuNav has a better color Doppler imaging. That's why we we favor AcuNav system. These are the basic ICE views for TAVR. So the longitudinal view, we place the ICE catheter in right atrium, and we try to adjust the position of the probe facing the aortic, ascending aorta, and to find the good image of the aortic valve. And for the assessment of paravalvular leak, the short axis view is very helpful. So we try to have 90-degree angulation of the catheter and rotate, and then we can have the short axis image. So I'd like to show some cases. This is a 86-year-old female. In this patient, we implanted Evolut R 29 millimeter, and this was the angiographic finding after the procedure, and you can see some paravalvulic here, so it can be mild or it can be moderate. Sometimes it is difficult to tell. So do we need post-dilation in this case? Here we can do eyes, and in longitudinal view, there is some jet, but I think it was due to the wire, and I think in this view there is no significant amount of paravalvulic. In short axis also there is some spots here and here, some focal paravalvulic, but in my eyes I think the paravalvulic was not that severe, so we complete this procedure without additional post dilation. Another case, 85-year-old male. This patient has increased creatinine level, so 2.5, and so I think, and this patient has very severe calcification of aortic valve. So since this patient has CKD, so we try to minimize the use of the contrast agent. So in this case, I think eyes can be very helpful. So we first did pre-dilation using 20 millimeter balloon, and you can actually continuously monitor how the balloon dilates the aortic valve here. So it can be good, well visualized. And after that, we implanted 29 millimeter Evolut Pro without using additional contrast dye. Just looking at the classification marker, we can successfully implant the aortic valve. And after that, we checked the amount of paravalvulic, and here you can see the jet, and there is, we think, at least moderate amount of the paravalvulic here. And in short axis, you can see the TAVI valve was not symmetrically expanded, fully expanded. It shows D shape. So, and also here, from 12 o'clock to 3 o'clock, you can see the paravalvulic. So in this, after seeing this, we decided to perform additional post-dilation. We can also find similar finding using rotational fluoroscopy, and here we can say the valve was not fully expanded. So we used 23 millimeter balloon for post-dilation, like this, and you can see the valve was further expanded. After that, the paravalvulic here was significantly reduced. And also in longitudinal view, we cannot see the paravalvulic anymore. And this is the TT image in this patient. So this is longitudinal view, and this is short axis view. And it is very difficult to identify the structure. So I think this is a limitation of the TT. And also in the detection of complications, eyes can be very helpful. In this patient, there is some chunk of calcification here, and in this patient we implanted Sapiens 3, and after implantation of Sapiens 3, we found some leakage of here, and the patient showed a drop in blood pressure, and we found on eyes here some flap, dissected intimal flap, and this patient required surgery. So the rupture of the annulus and also the dissection was the problem of the hypotension in this case. And this patient also showed pericardial effusion, and we could perform pericardial synthesis, and the blood pressure was stabilized. We compared the outcomes of eyes versus TE using our center data, And we performed propensity score matching. The age of the patients was about 81 years old. And in this patient, actually, in terms of the composite of all-cause mortality, rehospitalization from cardiovascular cause or stroke, there was no significant difference between eyes and the TE group. And also the hemodynamic parameters such as moderate severe PVR and LVEF, mean systolic gradient and effective orifice area, there was no significant difference between eyes and TE. However, since we use MAC for the eyes procedures and general anesthesia for TE, so there was a significant difference in length of stay in hospital and ICU. This was expected. And interestingly, in TE group, the difference was not significant. However, there were instances of gastrointestinal bleeding in the group of guidance by TE. And according to a paper, the post-procedure ECD showed new injury in 86% of patients who underwent procedures by TE. So I think TE is is not very safe procedure. So these are my take-home messages. ICE provides better image quality than TTE, while it does not require general anesthesia or sedation. ICE provides continuous imaging guidance with excellent image quality for TAVR on the MAC. ICE enables rapid assessment of TAVR research and prompt management of complications. And ICE, I think it is very important too, can be operated autonomously by experienced interventionists. And ICE can be recommended as a guide tool for TAVR, especially in high-risk patients undergoing TAVR on the MAC. However, the cost is a problem. So, and also the ICE, if you want to perform ICE, you need to have a learning curve. I think at least 20 to 50 cases, depending on how you are familiar with echocardiography. And these are the limiting factors for routine use of ICE for TAVR procedure. Thank you for your attention.
Thank you for your informative talk. And the next talk will be delivered by Dr. Hong from Severance Hospital. Dr. Hong is our old friend, and he is leader of the Korean Interventions, I think, Society. So his talk today is clinical outcomes of TAVR for patients with low coronary height. Dr. Hong, please.
Thank you, Dr. In. I'm going to talking about the clinical outcome of TAVR for patients with a low coronary height. My disclosure. In this topic, elderly female patient has the typical feature of the patient with the low coronary height. Elderly female patient in Asia has a triple small feature. First one is a small body size. Small body size means, therefore, they have a small size of the peripheral vessel. Therefore, the higher chance of the endovascular complication like a perforation compared to the big size of the catheter. Second one is the small aortic annulus. Finally, small, tight, and severe aortic valve area is a triple small in this patient. Additionally, low coronary height. When we look at the publication and regarding to the low coronary height, actually the number of publication or data is quite limited. What is the problem with a low coronary height? It is the higher potential candidate of a coronary obstruction after the TAVR. As we know, coronary obstruction was frequently observed in the woman and receive the balloon expandable valve and finally previous surgical bioprosthetic valve. Previous study report that the timing of the coronary obstruction after TAVR was the valve deployment is 70%, and the clinical feature was the shock and the ST elevation and the ventricular fibrillation. The CT finding in those patients with a coronary obstruction after TAVR was the annulus area is less than 400, and the diameter of sinus of Valsalva was less than 30, and the height, left coronary arterial height less than 12. Actually, when the coronary obstruction of the TAVR was occurred, the mortality rate was extremely high, 41%. Once again, coronary obstruction of the TAVR was occurred in the mainly female, and the balloon expandable valve and the valve-in-valve procedure. Therefore, the prevention and the protection is important not to occur coronary occlusion in suspected old patients with a low coronary height. There are 3 ways to prevent coronary obstruction during the TAVI procedure. First one is the coronary protection. Second, chimney stenting and the basilica technique. Regarding to the coronary protection, the upfront coronary protection is more favorable than without the coronary protection, and the stent protection is more favorable than the wire protection. Chimney stent technique and the basilica technique is a little more complicated procedure and the effective way of method for prevent the coronary obstruction. What is the real actual incidence of patient in lab in the low coronary height? This is data from our cath lab. We observed that actually the patient with a low coronary height, which was defined less than 10 millimeters, it was observed in the 11%. All patient, most of the patient, we fix it. The self-expandable valve, only one case is for balloon expandable valve. When you look at the baseline clinical characteristics of this patient, was 83% is all female patient, and the body size index was 23.9. It means the small body size female patient. And in the CT finding, the annulus area is around 400, and the perimeter is 71. And the diameter of sinus valsalva is less than 30, and the height of the left coronary ostium is 9 millimeters. Fortunately, we clinical outcome of this patient in our lab, which was done in the Evolut, was quite favorable. I'd like to comment in this speaking the small annulus TAVR. In this year, the SMART trial was presented and reported in the New England Journal of Medicine. What is the percentage actual incidence of the patient with a small annulus in the real practice? That was observed in the 24%. 1/3 of the TAVR candidate in Asia was the small annulus. Among those patients, the 2/3 of patient was the Evolut, 1/3 of patient was the Shih-Hsien. When we look at the baseline clinical characteristics with a small aortic annulus, female patient with more than 90%, and the height is around 150. Therefore, elderly patient and the height is about 150, small size of it, there is the higher chance of the small annulus. CT finding is similar. Fortunately, in this patient, we did not experience the coronary obstruction, but when we follow the echocardiographic hemodynamic data, we observed that the Evolut group shows the more larger size of the effective orifice area, and that the mean aortic valve gradient was lower. Therefore, hemodynamically, self-expandable valve is more favorable. Let me show 2 cases of it. Actually, this case was performed in the 2020. Is that the patient had a history of the left main stenting. Therefore, in this case, the proximal margin of the stent was protruded in the ascending aorta. Therefore, there is some chance the occlusion crushed the main stenting during a TAVR procedure. We did this procedure was the wire protection. One is the LAD, the other is a circ. And without the predilation, we did the Evolut deployment. In this procedure was under the general anesthesia, and you see there is a DTE guidance, and deploy that, and the evolute valve was successfully deployed. After the successful deployment, we can clearly see that the well-maintained coronary flow, and there is no deformity of the left main stenting. In the aerial view, we can clearly see there is some distance, maintained the distance between a valve and the proximal margin of the stent. This finding was also observed in the TEE guidance. You can see that there is the proximal margin of the stent and the valve. The other one in the short axis and the long axis. Currently, we did the TAVI procedure was the local sedation. In these cases, we fixed it that this case is a Sapien valve. In these cases, we did the guide protection with the ICE guidance. We monitor the whole things in the. This is the predilation. And then deploy the Sapien valve and the monitoring and the guide protection. And successfully the Sapien valve deployed. We can clearly see that the left main was protected under the guide protection. And the whole scenario is well monitored in the ICE finding. Ladies and gentlemen, I'd like to conclude that prevention, rather than the actual treatment of coronary obstruction when after the coronary obstruction is more important. Therefore, coronary protection is highly recommended in cases of all suspected coronary obstruction in patients with a low coronary height. Actually, the incidence of the low coronary height is observed in about 11% in real practice. Finally, use of a self-expandable valve may be recommended to promote the successful TAVI procedure without the occurrence of the acute coronary occlusion in patients with a low coronary height. Thank you for your attention. Thank you.
Thank you, Dr. Hong. Excellent talk. And we may have some short discussion. Dr. Ho Kei-Wen from Singapore is also a very experienced hand in this field. So would you please make some comments or asking questions?
Hi, Dr. Ng. Thanks for the invitation.
Thank you.
Maybe I can direct my first question to Dr. Ko. Thanks for the talk on ICE. Can I just check in your practice the proportion of patients that undergo ICE versus TEE versus TTE, and what makes this decision in your clinical practice which to use?
Currently, we routinely perform ICE guidance for all type of patient, but only patient who require emergent TAVR procedures, they are monitored by TE. However, most of our cases are done on the ICE guidance.
And for Dr. Hong, thanks for the excellent presentation. I noticed that there was a predilection for a self-expanding valve for low coronary heights versus balloon expandable valve. Can you expand on this? Is it just because of fear of coronary occlusion or better hemodynamics? What is driving the thinking behind using a self-expanding valve?
Actually, why I prefer the self-expandable valve in the low coronary height is the first one is the shape of a valve. What I mean is some concave shape in the center of the self-expandable valve. Therefore, there is some space for the prevent the coronary occlusion. And second one is when the coronary artery occlusion is really occur, because actually the balloon expandable valve is already fully attached the vessel wall, so the actual treatment is a more difficulty. And as you comment in our lab is the TAVR procedure in the patient with already hemodynamic shutdown. Is that patient was already intubated. It is therefore is that patient is a TE guidance. The other whole cases is the ICE guidance, and actually Dr. Go has the 700 patient is so is the huge number of experience of the ICE.
Dr. Hong, follow this question. As Dr. Bernard Prendergast mentioned, in TAVR, we will consider leaflet modification. In first TAVR, if the coronary high is really low, would you consider native valve leaflet modification?
That is I think is the more difficult situation than the Western patient because as I said, the percentage of the raw coronary height is quite high compared to the. That is the resulted from the actual size of the vessel size in the femoral artery, and all size is small. Therefore, annulus is small, and the annulus and the coronary height is therefore I think is a raw coronary height to prevent the next scenario, TAVR and TAVR and TAVR. How do we reduce it? First one is a more bigger size. How we obtain the more bigger the aortic annulus, aortic valve area? How do we achieve that? Personally, I prefer the self-expandable because compared to the same one, in the SMART trial, what is the average size of the valve? In the Sapien is 23, but the Evolut is 26. Therefore, the immediate valve area is more larger than in the balloon expandable valve. Is that anyhow, first step is that try to the more and more bigger size of the aortic valve.
I think for elderly patients, I think there is we can do chimney stenting, or also we can do or rescue procedures. However, if you have a younger patient and who has a low coronary ostium height and also small SOV, then I think it is a real problem if the patient requires a second procedure. So for the sense, maybe if the patient is young and if the patient can tolerate the surgery, then maybe surgery is the first choice of procedure for the patient. However, for the elderly patient and with a lot of comorbidities, so we can try to perform TAVR with chimney stenting or the basilica techniques, whatever. So I think the age is a very important issue because the patients live longer, and we have to decide what to do.
Okay, so we've come to the end of the topic. It's been great discussion. We have three important topics: the use of TAV in TAV. This will be increasingly important as we treat younger patients. The lifetime management will be important, how we can safely do this in best of interests of patients. The use of ICE and its advantages in reducing manpower in terms of not needing an echocardiographer, and also not using general anesthesia. And lastly, the important issue of low coronary heights in TAVI patients. I hope that you have gained valuable lessons. I'd like to close the session. Thank you, everyone.
And we have moderators, myself and Dr. Ho K Wong, and yes, and Dr. Professor Zhang Ji, yeah. And also our participating experts, Dr. Myung Ki Hong, and Dr. Wei-Hsian, and Dr. Yung-Tsai Lee, and Dr. Yu-Han. Okay, so I want to invite Professor in to start this program and introduction. Thank you.
Let me just do a brief introduction of the Chun-Ting experience on doing TAVR for pure native aortic regurgitation. As we know, patients with severe aortic regurgitation and the preserved airway function benefit from aortic valve replacement. But if not doing that, 29% high mortality will be within 10 years. Now the guidelines still far behind the clinical needs, because the guidelines still said we should wait for symptoms, wait for LV dysfunction, or wait for severe LV remodeling. And this is a really large treatment gap because this is a really unmet need in this field. However, as we know, catheter-based treatment for pure aortic regurgitation is challenging, because the absence of valve calcification and the hypercontractility of the left ventricle, excessive stroke volume and dynamics, regurgitant jet, and also the dilatation of the annulus or aortic root make the positioning, anchoring, and very difficult. So it is almost always end up with a very large residual aortic regurgitation. So when I present our initial experience of TAVR for pure AR in 2017 TCT meeting, to be honest, I'm reluctant to do that procedure before 2018. As you can see, okay, 你们这个 slide 都不行，都不会动。As I mentioned before, the conventional device for aortic stenosis need radial force and the calcification for anchoring. When use these conventional devices for AR, it is either popping out or deep dive. In this case, we try valve-in-valve with a second self-expanding valve in the first one. The second valve just pull all the things out. So we have to snare the first valve and pull out the second valve and use the second valve to deliver again. Finally, this patient was lucky, and we can have a very satisfactory result. But actually, the whole procedure was very scary. Real time 这样走。Okay. Only after we got the repositionable and the reusable device, then the outcome can be improved with the use of conventional self-expanding and the balloon expandable valve. As shown in this slide, and with the use of evolute system, we can have a better anchoring, and the implantation test was much better. So we published our initial experience with the old generation and the newer generation device. And as you can see, the prosthesis has a predisposition to embolize or malpositioned, and leading to moderate to severe residual power leak
and the high rate of needing a second valve, especially with early generation valve. And with the use of a second generation valve or newer generation valve, despite a better device success rate can be achieved, but the clinical results are less satisfactory comparing to that with TAVR for aortic stenosis. So I think this is the future. We are grateful to have Dr. Jie here to proctor our transfemoral J valve yesterday. The two cases have been finished very successful. As you can see, the locator will self-center and sit in the neither of the coronary cusp. And then when you make sure everything or the position is good, you just deploy the valve. And the two cases we done yesterday both have very successful result. The other system that is also very promising is the so-called Jena valve. This is another version of transfemoral device dedicated for transcatheter aortic valve therapy for aortic regurgitation. As you can see, the system also has 3 locators and a valve in between. So you can achieve also a very successful sealing of the aortic regurgitation. The result has been published in the Lancet, and it meets its primary endpoint. However, we need longer-term follow-up. This is the initial version of transcatheter J valve, which was performed at our center. As you can see, the 3 locators sit in the neither of the coronary cusp, and after confirmation of the position, we just deployed the valve, and the result was really good. And even in larger annulus, you can homemade sealing skirt, outer skirt wrapping on the J valve, and the successful procedure can also be done. So comparing these two devices, we are still in the very early stage. In general, both devices can achieve very good AR sealing, and not AR sealing, I mean the AR healing, and both of them are very promising. Although the Jena valve is a little bit earlier, they have already finished the clinical trial, and the J valve trial is still ongoing. But I think both devices will be very useful in dealing with the patient with pure AR. So in the future, we may need to identify those patients fail to respond to TAVR, and those who are hyper-responder. In this way, the conventional trigger for aortic valve replacement for AR patient will have to be evaluated. And I think this is a very promising field. I think in the near future, we will have both devices, and I think the patient can get benefits from both treatment. I thank you for your attention.
Okay, thank you, Professor Yin, for your very informative talk. Now we will discuss at the end of this section. So the next speaker is Dr. Yung-Tsai Lee. Okay. So his topic is the TAVR for pure negative aortic regurgitation left in a box. Dr. Lee, please.
Thank you. That's here we can share our experience, and we just finished this case yesterday because compassionate use we cannot live for any other reason. So that's I just share the experience from the TFJ valve. This is a 74 female, depending on exertion for a couple months, and he got a severe AI with congestive heart failure. Maybe from 2 years ago, he have a coronary artery disease, then man with PCI repeated and received DES for lemon 1280 and repeated ISR. He got a comorbidity of ESRT and the POD for the right subclavian artery. And we do the stenting years ago, so that the vessel is okay. The STS is 11.4 and the case fatality is 0. And why we do the table for this case is initially evaluated for the conventional surgery for CABG and the aortic valve replacement. However, the aorta is porcelain aorta, and you can see heavy calcified for around the aorta, and even from the echocardiography, and you can see the severe AI without any calcification. And in the beginning, we think that maybe 1 year or 2 years later, maybe she will have a calcium over there, and we can do a conventional TAVI. However, that's after 2 years, he still have the aortic regurgitation without any calcification over liberator, and that means disease progressed. So the annulus is 86.3, and the diameter is 27.4. However, if we choose the CoValve system, you need 34, and it got very difficult to management because we have a previous idea about how to use CoValve in this kind of situation. However, after 85 millimeter, the CoValve become very difficult to manage. So the most successful one is if you use the CoValve 29, it's good for PNAI. However, if you the area parameter over than 85 and the aorta is somehow larger, and it got very difficult to do that. So the ABL here is 27, and the diameter of the sinus masava is 36. And STJ over here, you can see we cannot do the surgery because from STJ to the distal aorta is a calcification. And the lemon high and the right coronary artery is 14, and the VTC is 2.7, and the right side is 5.9. Membrane septum is 1.6. The three cuspid is over 2 over Caudos 19, and you can see here heavy calcification, and no surgeon hope to do that. And if you cut, so the aorta is got very difficult, and unfortunately, the iliofemoral artery is okay for the every device. So the plan is right common femoral artery for the 22 introducing sheaths. I think that is a little bit larger than other device. Unfortunately, most AI patients have the large iliofemoral artery, and just like the others. And we still do protection device in most of our device, and the transfemoral J-valve 29. So it's we do the coronary angiography first and show the ISR in the lemon. So we do sometimes the DEB and the cutting balloon. So there's I think it's I will show this case in here. That's you can see that's a stent boost. Mostly the trim stent or the snorkel stent from the TAVI device. You got very difficult to when the stent outside the aorta, and sometimes you will enter the side wall to the main stent, and it got very difficult to management of the stenting. So that's it's our idea. We do more and more the liberated modification when in TAVR. So I just show the stent booster here, and the final angiography is okay. And then cross the valve got very easy, and just use the PTO, and we can got very easy to cross the valve. And the aorta graft, it's very important and for the J-valve system, because you need to know the 3 locator in the 3 cusp. So always use the 3 cusp, but not use the cusp overlay. and you can see the nice co-planar view. And now that's a very convenient. So I think it's a very great advance of the system, because you can rotate just the SAPIEN. So the beginning you can turn the wheel, so that when you cross the aorta, it's more easier, and when the aorta is horizontal, it's got more easier have a alignment. And then we open the 3 locator. This is the first challenge. I think it got very difficult. You can see the rotator is not quite well, because limited by the calcified aorta. So that's we must retrieve a little bit and push and pull. So that the locator was quite opening, and push the valve into the sinus vasava and the nadir of the cups. So that's a quite terrible. The locator is open, but did not open it well. So the locator is the only thing cannot retrieve. So that's we fortunately we have the Professor Tsao here, so he have a lot of experience of how to manage the problem. And then we use the 3-cast view. However, there's the RQAI in this area. We inject the contrast even 20 or 25. We cannot see the LCC quite clearly. So that's at this moment, we use the cast overlay views to see the LCC isolated and the locator in the LCC quite well. So we just push it and descend the valve into the sinus vasava, and we can use the TE to check the locator is nadir of the sinus vasava. So I cut the valve and just open the valve. At this moment, I think we cannot do anything, because it's just open and anchoring, and it just happened in 1 second. So there's we have no idea about how rapid it is. However, that Professor Tsao said that's okay. So that's we just open that, and the cells expanding work nicely. And you can see here. Oh, sorry. And final angiography only few regurgitation, and the residual pressure gradient is 0, and it's a nice valve. And in the future, if we need to do the coronary intervention, it got easy, because the J valve is short stent, just like a SAPIEN, and we can do the intervention quite easier. And thank you again to let us have the opportunity to share our experience here.
Thank you, Dr. Lee, for a very informative case that illustrates a very useful valve. Hopefully, we'll get this in all our centers shortly. As a change of the next speaker, we will now invite Dr. Michael Lee. This was a pre-recorded lecture on the Align AR trial. So we just get the AV team to play Dr. Lee's recorded session.
Hi, I'm Michael Lee from Hong Kong. Thank you for inviting me to talk to you on this novel therapy for AR, and in particular with reference to the Align trial. These are my disclosures. You know that valvular heart disease increases with age, and in particular, the instance of aortic stenosis we already know is getting higher and higher with aging population. But if you look more closely, actually the instance of aortic regurgitation might be actually more than that of aortic stenosis. This is especially true in China. When you see the China local study, you can see that the instance of aortic regurgitation is actually way more than that of aortic stenosis. So there is a huge population that has been undertreated in all parts of the world. Prognosis of severe aortic regurgitation is very poor once they develop symptoms. Once they are in New York Heart Association class 3 or 4, you can see that their mortality can be as high as 25% per year, and more than 70% mortality at 5 years. Currently, The only recommended intervention is surgical AVR for patients with native severe AR, and for high-risk patients, inoperable patients, there are really few options. We can use off-label use of the current TAVR devices to treat AR, but there are a lot of associated complications. This trilogy system is particularly designed to treat pure aortic regurgitation. You can see there is a 19-node frame, and inside the 19-node frame, there are 3 porcine pericardial leaflets. And what is special about this design is there are 3 locators in which these locators will actually get grabs of the 3 coronary cups so that it will secure the valve before really deploy the valve to get the function. There is also a dedicated delivery system in which you can actually use a 3-step approach to deploy this valve and get very nice location in the coronary, in the aortic annulus. There is also a long sheath all the way put into the ascending aorta and try to avoid any damage to the whole aorta. So the steps are actually not that difficult. The first step is to align the valve with the knot in the locator in the delivery sheath. Once it's aligned, you can actually push forward to allow the 3 locators to be seated inside the 3 coronary cups. But then you have to make sure the 3 locators are really inside the coronary cups by rotating the back of the delivery system. And once you assure that the locators are inside the coronary cups, you can deploy the valve. This is our first case being done outside in Asia in May last year. 78 years old lady, symptomatic severe AR, which is inoperable as assessed by our heart team. And these are the measurements, and in this particular lady, we have used a 23 trilogy system. And these are the other anatomical measurements for this particular patient. And you look at the aortogram, you can see severe aortic regurgitation. And these are the, we try to align the trilogy system with our annulus, and then try to expose locators, try to get the 3 locators into the 3 coronary cups, and we have to do selective angiogram to just make sure that the locators are really inside the coronary cups. Once we are sure they are inside the coronary cups, we can actually deploy the valve, and after deployment, you can see that there is really no residual aortic regurgitation at all as compared to the pre-operative angiogram. We have done 7 cases in our hospital so far, mean age of 78. You can see the usual baseline characteristics, and we have actually very few complications. Basically, we don't see any complications apart from 2 patients have to implant a permanent pacemaker. None of these patients are having any sort of paravalvular leakage at the end of the procedure at all. These are the degree of aortic regurgitation. You can see actually all patients with severe aortic regurgitation can achieve very, very minimal regurgitation at 30 days by echo. And the functional class-wise, they all change from the functional class 3 to functional class 1. So very, very gratifying result. This brings us to the Align AR study, which was just presented last year in TCT. This was a multi-center, non-blind, single-arm evaluation of patients who have symptomatic severe aortic regurgitation and a high risk of surgical AVR. They look at the clinical parameters, look at the echo functional status at 1 month, 6 months, 1 year, and up to 5 years. There are two arms, one arm looking at the primary safety endpoint and one arm looking at the 1-year primary efficacy endpoint. And then they compare with pre-specified endpoints. The primary safety endpoint at 30 days was a composite of all-cause mortality, stroke, vascular complications, any bleeding, pacemaker, renal, kidney injury, valve dysfunction or surgery intervention related to the device. And then the primary efficacy endpoint was all-cause mortality at 1 year. So they actually calculate the performance goal by using the various previous studies, using different valves for patients with high-risk AS, and then they weighted the safety composite endpoint and give a performance goal margin, and then they can come up with a performance goal for 30-day composite safety endpoint of 40%. And then when you look at the primary efficacy endpoint, actually they derive this from the patients at 1 year mortality with conservative management according to the New York Heart Association class, and then they can derive at sort of weighted average, and then they do a literature review for conservative management of severe AR. So they and then they weighted the average reduced by another 5%, so that they come up with a performance goal for 1 year primary efficacy endpoint of 25%. So they screened 379 patients. Out of these, about 200 of these patients are not eligible because probably because of the CT anatomical criteria or some echo criteria which they cannot fulfill. And at the end, they enrolled 180 patients, and one patient have to be converted to surgical VR, and 2 others have been used commercially available TAVR device. And at the end, 177 patients have been implanted with the Trilogy system, and the 1 year evaluation as well as a 30-day safety evaluation was 100%. So if you look at the baseline characteristics, these are the usual patients for TAVR procedure. Mean age was 75, with about equally distributed female and male. STS score was not particularly high, 4.1%, but a lot of these patients are in New York Heart Association class 3 or 4, 2/3 of these patients. And a lot of these patients actually are elderly patients, are very frail patients, or with previous open heart surgery, which cannot be accounted for by the STS score. And if you look at the procedure outcome, basically there are no in-hospital mortality, valve embolization 2.2%, and also there is also a 2.2% of femoral access site intervention. Success rate was very high, 95-96%. And if you look at the primary safety endpoint at 30 days, all-cause mortality 2.2%, and cardiovascular mortality also 2.2%. Stroke rate 2.2%, and the other complication rate, I would say, is not really different from other TAVR currently available TAVR trials. One point to note is pacemaker rate was 24%. This was a bit varying, but I think as time goes on, when we have improved our techniques, I think the pacemaker rate is coming down even in this particular trial. So altogether, the total event rate was 26.7%. So if you look at the analysis, 26.7% with the upper one side confidence interval is still way below the 40% interval. So they have achieved this non-inferiority criteria for the primary safety endpoint. And if you look at the primary efficacy endpoint, which was all-cause mortality at 1 year, which was 7.8%, and or even with the upper one side confidence interval 12.3%, still way less than the 25% pre-specified non-inferiority margin. So again, this non-inferiority criteria was met for the primary efficacy endpoint at 1 year. This was the pacemaker rate that I've mentioned. At the beginning of the trial, pacemaker rate was even higher, 28-30%. But as the operators are more familiar with the system, when they actually implant a little higher than the nadir of the coronary cup, then they can actually bring the pacemaker rate to about 14%. But altogether, 24% pacemaker rate for this particular trial. And paravalvular leak is really very little, and as time goes by, you can see a less and less even mild aortic regurgitation. So at the end of 1 year, more than 92% of these patients are having trace or nil aortic regurgitation. What's more gratifying to see is this LV remodeling as measured by this end systolic dimension and end systolic volume all comes down, as well as the LV mass. This shows a regression of the left ventricular mass as well as dimensions. This is something that we are really happy to see after treatment of these patients with severe aortic regurgitation. Functional class-wise, all patients, almost all patients improve, and at the end of 1 year, you can see that 60% of these patients are in functional class 1, and very few actually are still in class 3, as compared to the pre-treatment functional class. A majority of these patients are in class 3 or 4. Quality of life also shows significant improvement. And if you compare to the various other studies, you can see it is actually quite comparable with a little higher success rate. This is the pacemaker rate was a bit higher with the trilogy system. But if you look at the residual AR as well as valve embolization rate, it is really actually very comparable to other clinical trials, or even have a better result. So to conclude, in this particular trial, in this group of population with symptomatic severe aortic regurgitation and high surgical rate risk, the treatment with this trilogy system actually have achieved non-inferiority results in terms of the safety outcomes at 30 days, as well as the efficacy outcome for all-cause mortality at 1 year. And I've mentioned this new pacemaker implantation rate of 24%, but I would expect this to decline as the operators get more use of to this system, and with a higher implantation depth and better technique in the future. And you can achieve actually a large EOA and low gradient at the end of the procedure, and very low paravalvular leakage. And echo actually also shows significant improvement in LV remodeling, and patients' quality of life as well as heart failure symptoms all improve at 1 year. So this is my take-home message. Treatment of aortic regurgitation with the TAVR device is challenging and is associated with poorer outcomes. AR patients who are ineligible or at high risk for surgical AVR was previously without any treatment options. And this result actually give confidence to the TAVR as a procedure for AR patients. These actually save lives and reduce symptoms of these patients. The design of the trilogy system actually presents a unique mechanism for positioning precisely a better securement and also sealing of the aortic annulus, giving rise to improvement in symptoms. In the Align AR trial, this trilogy system actually provides the first dedicated TAVR option for symptomatic patients with severe aortic regurgitation who are at high risk for surgery, and is well positioned to become the preferred therapy upon approval for this particular patient population. The first trilogy implantation in Asia in May last year actually confirmed that this transfemoral TAVR system for aortic regurgitation using the valve trilogy system is as safe and as effective in our Asian population as compared to the Caucasians. Thank you very much for your listening, and I hope I can join you next year and enjoy the rest of your meeting.
Thank you, Michael, for the excellent talk. We'll reserve the questions and discussion to the end of the session. I'll now call upon our next speaker, Dr. TCHETCHElll, just to change of schedule, but to share on transfemoral J valve system for pure native aortic regurgitation. Dr. TCHETCHElll, please.
Thank you very much for the panel. Thank you for Dr. Lee and Dr. Yin, the invitation. I'm pretty lucky as the last speaker, and I will make it quick. And also thank you so much for the opportunity for I give the design and the insight of the J-valve transfemoral.
The
Let's
distal end of
take
the
a look
device
at
is
the
positioned above the native aortic
animation
leaflets.
first before we talk
The operator controls the delivery device by advancing both control knobs. The valve and anchor ring move forward together, and the anchor ring is revealed from the sheath. The anchor ring continues to move forward and gradually opens up. When the device is advanced forward, the anchor ring will self-align with the native aortic commissures. The valve is placed at the final position. The sheath is then retracted to release the valve. Deployment of the valve is automatically guided and secured in its proper position by the anchor ring. Lastly, the anchor ring is disengaged from the delivery device. The delivery device is removed and the procedure is completed.
As we know, heart is considered a moving target. So as early as around 1999, around somewhere there, we see the first generation TAVI valves designed. We're all frustrated with the moving target and have a problem to line the valve accurately. Then there I'm thinking maybe we should have something to make a physician easier. So generally speaking, the moving target, either we stop the moving, see at the cardiac surgery, or we stop the heart with the pacing, or induce fibrillation. So sometimes nobody really happy with that. So I'm thinking maybe I should design a thing and to link with the heart together. Either move together or stop the motion. So that's the idea start from. At the beginning, I'm thinking I make the locator, then along the locator I send in the valve. That will be 2 devices. Then from the device, along the device, finally come up the idea within one device and crimp it in a separate location, which I mean the locator and the valve is crimped in the second separate location, just like you send a rocket. You go to the moon, the moon lander with the other rocket is all different location. Then in the orbit, we're resembling. So the same thing, in the aorta, we're resembling and get the locator into the sinus. That's the valve. According to the locator position, automatically make the position easier, because I leave some room for physician to do a fine adjustment. So that that way you can deliver the valve very accurately. I tried on the animal trial, and I tried a 16. I can make a 14 identical, not even off a millimeter. So that's a pretty accurate device. And also, here's some detail. And the left one, this is the locator. So we control the locator on the front locator. And that way, it's easy to maneuver, and it's a less chance to cut onto someone and not be able to off the situation. The second is the handle. The handle, I made the thing is as simple as possible. The first, the gray, here you cannot see the, okay, I got a cursor. Okay, now this knob, this device have an active curve. So when you turn, they can give an active curve all the way, can reach 270 degree. And the yellow knobs control the locator, and the last one, the green knob, is control the valve position. I separate the two motions. One's longitudinal motion, so control the valve clasper in and out. And the rotation motion is control the release, release those parts. Yeah, of course, those device and get a feature as a short stent. And also, actually, from the design point of view, why they make a longer design? Because the only reason is when in the tube, the short is hard to control to make it longitudinal aligned. So that's why they make it long. Make it long, it's never tilted. So this one, our J valve is short. And also I wanted exactly parallel along with the aortic the shape, and make the flow. And also even to cause the valve migration, actually, because the valve is tilted. Once it's tilted, you have a phase to see the blood stream. That's how the valve is being pushed forward. If it's perfect aligned, there will no forward force. So that's why J valve barely move. Yeah. And the valve is very, you know, the orientations commissure matched. And also the J valve is not a tubular valve on the, you know, very favors for the coronary. Yeah, basically, this valve have a pretty good features. One is it can deal with the AI and the AS. Even we have a lot of experience with bileaflet, not only a stenosis. So, and also our China trial, I'm not reject any patient. Whatever screening, I just take it in, 100%. So, and and also low coronary is good too. And so far we very, very low. I don't see pretty much there's no coronary occlusion, but very, very low. And also valvular leak is very minimum. And the valve, you know, and very easy to maneuver to the horizontal aorta. And also this valve with largest one all the way to 34. Yeah. And here's a give example. This is the very horizontal aorta. You can see the from left one, and for this one, you call the clasper, the middle one. Try to. You see the middle one, the clasper, how to get into the sinus. Yeah, the right ones end up with the valves deployed. Yeah, I had a lot of experience with the horizontal aorta greater than 85. I remember a couple of those is 90 degree. Yeah, we're pretty lucky, and also a lot of patients with the artificial heart and the left assisted device. They happen aortic insufficiency. So we had a couple of experience, a lot of from Hong Kong too. Once the patient have the aortic insufficiency, and J valve will be able to treat the patient very well. And I'm not here for the clinical data, but I just give some information. We completed China trial, and result actually is pretty good. Mortality is pretty low, less than 5, and the pacemaker rate is around 5, I remember. And the waiting, I'm not in the position to give any detail. And also, we already started an American trial. Early feasibility are completed, and I also got approved for the pivotal trial. Thank you so much.
Okay, thank you, Dr. Zhang-Ji. Indeed, this is very exciting technology. We'll open this time to some discussion, maybe for about 5 minutes or so. Any comments or questions from the panels?
Yeah, Dr. Mike Lee, presented that the permanent pacemaker implantation rate is a little bit high with the Jena valve, but Dr. Zhang, told us that the Jie valve has relatively low pacemaker implantation rate. So for me, two valves have very similar features. So what makes the difference in terms of the pacemaker implantation rate? So why Jie valve has lower pacemaker rate?
I think Dr. Yi have a better answer probably. Well, from me, I think first we don't need whole a lot of oversize. So we recommend somewhere around just less than 10. Yeah, because the locator prevents the valve down to a ventricle, and also you're perfect aligned. You don't have any force to make the valve moving forward. And also transfemoral valve have some features. They catch the tissue forward. It cannot go forward at all. Animal trial, I pulled the heart and a couple pounds you can take it, so it doesn't go anywhere. Even that's why I think a low radial force, probably that's the reason. And the second reason, and we don't go too deep. Yeah, because clasper and the valve, they already set the position. It doesn't go to more than 5 millimeters. Yeah.
Maybe a bit of technical question.
Sure.
How do you ensure coaxiality? Is it more important with the pushing forward motion or changing the curvature to make it coaxial for the Jie valve?
I think more just pushing.
So how about the access? Can this device can be used for the alternative access like from subclavian artery or carotid artery? Like
subclavian. Yeah, Dr. Yi have a couple of experience with subclavian, and also clinical trial we do have a couple subclavian. I never try carotid because lots of physicians choice, but that device is capable.
For the interest of time, it's been an exciting session. We had to close this session. This has been a dedicated session on dedicated AR devices. We hope that our centers would get this device and look forward to using this in our region. Thanks everybody for your attention.
Program. So I already invite Dr. Shih-Hsien cannot attend this meeting right now. So Dr. Shih-Hsien will co-chair with me. Dr. Shih-Hsien is from Qingmen General Memorial Hospital, and also we have the participant expert like Dr. Yung-Tsai and Dr. Daniel Tairun Chan. And he's from Primary Hospital, Hong Kong. Yeah, so probably only our four. So I'll invite the first speaker, Dr. Tsai Jia-Ti, to present the case. And Dr. Tsai Jia-Ti is from Jiangxin General Hospital. Dr. Tsai, please.
I'm Tsai Jia-Lu from Jiangxin General Hospital. And this is a case of 74-year-old man who had received mitral valve replacement in 2018. Positive valve degeneration with stenosis was found, and during follow-up, and the redo operation was suggested. Besides, he had congestive heart failure with RVEF about 25% and end-stage renal disease, and the mortality rate was about 35%. And this is his cardio echo, and cardio echo showed mitral valve thickening, and mitral valve thickening and with restrictive motion. Mean pressure gradient was about 30 milli of mercy. And the previous mitral valve was Edward magnet valve, 29 millimeter, and the true ID was 28. Current transcatheter valve selector is SAPIEN-3 29 millimeter. And MSCT showed the new LVOT was about 278 millimeter squares, and there is low risk about LVOT obstruction. So we are planning to do the mitral valve valves with 29 millimeter SAPIEN-3 valves from the right femoral vein with the transeptal approach. And this is then we do the transeptal puncture first and use the 12 millimeters PTA balloon for septal-rostomy. And however, when we try to assemble the valve at the IVC, we found the valve was displacement. Then we try to drop out the valve with the sheath from the right femoral vein. Then we use another valve, and the mitral valve procedure was smooth under repeat patient, and there was no paravalvular valvic or LVOT obstructions after the implantation. Then we try to repair to the femoral vein. we did a crossover first from the left femoral vein, and we put a 12 millimeter balloon for occlusion first. Then we try to remove the wire and the sheath from wire and the sheath. And venogram showed there is persistent extravasation was noted. So we used 30 millimeters valve bond for repair the right femoral vein, and there was no extravasation after the stent grafting. So the device was succeeded. The procedure was with the mitral valve involved was succeeded, and no valvular leakage. And the right femoral vein laceration was repaired with the valve bond 30 millimeter. This is a case. Thanks for attention.
Yeah, thanks for the case. So what is the cost of the vascular perforation, and how do you, because the valve bond, we normally we need a large size of sheath, so how do you insert the valve bond and advance the valve bond to the lesion side, perforation side? Use a large bore sheath, or just use a stiff wire, more stiffer wire to support the valve bond without any sheath?
Stiff wire is okay. Can implant the can implant the valve bond.
Okay, so what is the cost of the perforation?
Perforation. The valve, when we dropped out the valve was cut the femoral vein because the valve is displacement from the device. So the edge will cut the femoral vein.
Okay, thank you. Any questions?
Excuse me, because I'm not a surgeon. I just want to ask. That is a venous system. Is it possible we just do compression, then the laceration could?
I didn't mention because he also have a severe TR, so his venous pressure was relatively high. We have tried the compression first, but not in well. So we tried the valve bond stent to repair the vein.
I think that when you pull out the valve directly from the vein, is the part of the vein tissue trapped by the stent valve, and so it's just like the vein was avulsion from with the valve itself, so that we need a repair with the valve bond, but not direct compression. And when the most education one is when you do the assembling the valve, and sometimes it's not in the straight line. So when you push the pusher, and the pusher will open the valve stent a little bit. In the Aortic valve, we can realign the valve. However, when we do the transcatheter one, when we cross the septum, if the valve dislocation in the right atrium or left atrium, it's a catastrophic result. So that's why we need to pull out everything, so that it causes the vein injury at another moment. So that's when you have a resistance push the delivery caster, you should pay attention about the valve is opened.
So I got questions, Dr. and Dr. Lee. Do you use routinely the 12 millimeter balloon for the septotomy, or you use a bigger one?
That's we for the 23 or 26 we use the 12 only, and for the very sick and around when the patient receives the transeptal mitral replacement repair, the atrium is quite sick. That's we need 14 millimeter balloon. So the 14 is for 29 or the previous surgery.
But after this one, would you recommend a bigger one, just for safety, not to losing another expensive valve?
I don't know because in this case we use the is we retrieve the valve and then we use the 14 balloon to dilate the septum. And afterward, we need the occurred the ASD because they're quite huge, the power, the ASD over there, yeah, chargenic ASD over there. So we need to occur the ASD.
Okay, I think Dr. Tsai. Let's move on to the second case. Will be delivered by the Timothy Ka-Chun. Dr. Woon, he's from he's an associate consultant cardiologist from Queen Mary Hospital, Hong Kong. Please.
Thank you, Chairperson, panelists, and audience. So it's nice to talk to you guys all again. So this is our second case for related to a TAVI. So this is a patient of 76-year-old gentleman who have history of hypertension diagnosed early in 30 years old. So at that time, I guess probably not much for like investigation was done. So he has a severe mitral regurgitation related to the posterior leaflet, and he had a mitral valve replacement at that time with tissue valve 25 magna east, and also a tricuspid annuloplasty of a 28 CE ring in 2019. So he had one open heart surgery at that time. So he also have history of atrial fibrillation. So in the recent years, he complained of progressive shortness of breath and decrease in exercise tolerance. So this is his echocardiography. So you can see that there is a concentric LVH together with a preserved ejection fraction and severe aortic stenosis with a gradient of 85/42. So this is the, I suppose this is, if it is playing, you can see this is a severe aortic stenosis. And also from the echocardiography, you can see that it is a bicuspid aortic valve. So the mitral prosthesis gradient is okay. Seems like the mitral prosthesis and also the tricuspid are both okay. So this is quite reasonable for us to consider TAVI for this patient, given that he has a history of open heart surgery. So when we do the TAVI CT, something like unexpected happens. So it says that there is a coarctation of the aorta with the nearest lumen of around 5 mm. So this patient have coarctation of aorta undiagnosed since at the time of age of 30 with the history of hypertension, but he was not worked up, and until now, when he's 70-something years old, when he's presented for TAVI, and we now find a coarctation. The open heart surgery was done in another center, so we are quite surprised to see this happen. So he also had a history of type 0 bicuspid. So on the CT analysis, the annulus was around like 519 area, and the perimeter was 83.9, and minimal diameter was 21. So the consensus of our heart team at that time was that we are considering to do a coarctation stenting for the patient, and together with a TF-TAVI at that time. But given the coarctation there are maybe several options for us to consider. For example, if we put in a stent at the coarctation, and when we try to advance the TAVI system, there is a risk of dislodging the stent when the stent is freshly implanted. Otherwise, if we do not do anything on the coarctation, it may be impossible for us to cross the TAVI system. So before treating the coarc, it is difficult to do the TAVI. So there is a possibility for us to consider other alternative access. For example, if we really could not do the coarctation at the same setting, we may consider alternative access like right subclavian, carotid, transapical, other alternative access. So for this patient, for the CT analysis, we considered use of 34 mm evolute FX because of the sizing consideration. So as we said, we try to consider TF-TAVI. So we do the coarctation stenting first. In case anything happens, we may consider alternative access. So we first do a 6 French pigtail to the left subclavian artery. And you can see this is a very tight coarctation. And then followed by putting in crossing the coarctation with an MPA, and then we use a stiff to remove guide wire to cross the coarctation from retrograde approach. Afterwards, we exchange it with an M+ extra stiff. So we do the coarctation first. So we first predilate with a PTA of 8 mm balloon first. So we do not aim to be very aggressive, because you know that in adult coarctation, if we predilate very aggressively, then we will be a risk of dissection or even aortic rupture. So afterwards, we do an angiogram from the left side, left subclavian for the sizing, So from the measurement, we can see that the length of the coarctation we plan to put in the stent will be around like 35 millimeter. So we do not intend to cover the left subclavian ostium. And the diameter probably we would not expect to put in a very big stent because it is a very tight aortic stenosis coarctation to begin with. So we do not intend to put in a very big stent. Otherwise, there may be a risk of aortic rupture. So we put in a 16 mm cover CP stent on a 40 millimeter bib. So and then we try to after the stent dilatation, we would flare it with a 9 French coda. So you can see the cover CP stent have a significant shortening. So from the shortening chart, we plan to aim the stent at around like 35 mm. So we choose to have a 16 millimeter balloon in a 3.9 cm stent, and the shortening will be expected to be around like 3.5 mm, so that suppose it will be like accurately shortened to the length that we have desired. So we deliver it through a 14/4 French sheath, cross the coarctation, and then we withdraw it and then deploy the stent. So this is the stent of the new-made cover CP stent. So after the stent deployment, we use the coda balloon to flare up the lower part of the stent. So afterwards, after we treat the coarctation, we just do the TAVI in a routine manner. So we do the sentinel cerebral protection from the right radial artery, and then we do the BAV with a true balloon, remembering that the minimal diameter was 21 for the bicuspid aortic valve. So we do the bath with the 20 millimeter balloon. So afterward, it will be the most challenging part for the TAVI. So we advance the system of the EVO delivery system. So with some difficulty, we also with the manipulation of the wire, we try to keep the wire at the middle instead of the outer curve of the aorta to minimize the pushing effect on the stent. So fortunately, it can cross the coarctation, and then we can just proceed to the implantation of the TAVI. So this is the probably a desirable depth of the implantation. This is the result of our implantation. So after delivery, it will be another challenge when we try to take out the delivery system. It looks stuck a bit, but fortunately we can get rid of it. So and then afterwards, when we do the transcatheter echocardiogram for this patient, we can see that the valve is a bit oval shape, and the depth is seems okay. So afterwards, we have to post-dilate it with a true 24 balloon in order to optimize the shape of the TAVI valve. And this is the final result of the TAVI. So this is the final echocardiography. You can see the shape of the TAVI valve has been improved a lot to a round shape with a good flow and no significant gradient. So to conclude, there is a common association of bicuspid aortic valve and coarctation of the aorta. So this patient, he had a bicuspid aortic valve and also an undiagnosed coarctation of aorta for many, many years. So there is a complicated decision making at the time of when we see this patient, whether we should treat the coarctation first and then wait for several months until the stent to be stabilized and then do the TAVI, or we can do it at the same setting, or we just do the TAVI first and then treat the coarctation later. But this patient presented with probably symptomatic severe AS. The main reason for him to come to here is the symptomatic AS. So I think we have to treat the AS first by TAVI. Whether to consider to do the coarctation stenting would be another question. So we have to be mentally prepared to have alternative access in case we cannot cross the coarctation or there is high risk of touching the coarctation. So this is my end of presentation. Thank you.
Thank you for the very interesting cases. Any comment or questions?
Do you hope if you get the stent now open the aorta, do you have a bailout strategy? Sometimes if the stent is not open to enough sizes, got easier thrombosis. So there's you just forcibly dilate it or add another stent and use two stents strategy.
Thank you very much for your question. So it is very notorious that the adult coarctation is prone to dissection and also like rupture. So at the beginning, we put in a cover stent so that after we put in the stent, even if we do a gentle balloon dilatation, the risk of having like aortic rupture or dissection will be lower. But in case if after dilatation there is a evidence of any dissection, we will put in another cover stent to minimize the risk of aortic rupture. But I think in adult coarctation, we always think of a cover stent.
So is it possible to just dilate the coarctation of aorta first and then do the TAVR and then put a stent to the coarctation to minimize the impairment of the device advancement or retrieval?
Yeah, thank you for your suggestion. So at the beginning, as we do the balloon dilatation, after we use the 8 mm peripheral balloon, we are lucky that there is no dissection, no rupture, etc. So actually at that moment, we can consider to stop it and then just do the TAVI and then do the rest of the stuff. But then we think that it is easier for us to do in one go. After all the patient is under general anesthesia already, to it will be the optimal setting if the stent is well placed. So I think it will be a good option for us to choose if this initial balloon result is good. But there, we are always quite worried that after stent balloon dilatation, there may be dissection. So we always think of upfront stenting.
Okay, thank you, Dr. Wu.
Yeah, thank you.
Yeah, thank you. So I will invite Dr. Shi to chair the next section.
Yep. I would introduce the next speaker, Wu. He is the Chief Interventional Cardiologist from University Medical Center of Ho Chi Minh City, Vietnam. Dr. Wu.
Thank you, Chairman, for a kind introduction. So this is my case. This is the 80 years old male patient came to my hospital because of dyspnea on exertion within 2 months. And we found that this is the antiprotein P over 7,000 nanogram per ml. And the echocardiography showed that this is the severe aortic stenosis and also the severe aortic regurgitation. So the aortic valve is about 0.31. It's very severe one. And also we have the reduced EF about 40% in this patient. And the coronary angiogram showed that it's a medium intermediate lesion in the RCA proximal, and also in the LED middle we have the 50% stenosis. About the diagnosis, this is the symptomatic severe bicuspid aortic valve stenosis and also regurgitation, and chronic heart failure with EF about 40%, and CCS chronic coronary syndrome with 70% RCA and 50% of LED. And this patient, we take the CT scan. We see the very heavy calcify in the aortic valves, and also we have the horizontal aorta with 71 degrees. This is bicuspid aortic valve silver 1 and very calcified in the raphe RCC and NCC. And how did I treat? In this patient refused the open surgery, so we have to think about the TAVI for the patient. And how about the balloon expandable on self-expandable valves and risk of the both procedure? And about the femoral approach, is big enough. Even we have some calcify in the femoral artery, but I think it's enough for the femoral approach for the TAVI. But we see in this picture, we see the coronary height is enough for the valves, but we have the horizontal aorta, and also we have the calcification extended into the LVOT a lot, and also up into the annulus. So the big calcify here, maybe I don't know that we can break it or not. And we have some concern. If we use the self-expandable valves, maybe it's quite difficult to enter the LV with the self-expandable valves, and how to crack the very big calcification in the valves. And also we think about the risk of annulus rupture and also the risk of paravalvulic. At that time, we don't have the balloon expandable valve. At that time, we only one option, self-expandable valves, and we think about how to enter the valve into the LV. Also, we think about the paravalvulic because this is bicuspid and also heavy, very heavy calcify in the valves. And according to the parameter, we think about the 33, the biggest one. Absolute R in our country, we only have the average R right now. And how did I treat for this patient? We right femoral artery for the liver system, left femoral for the pigtail in the non-cuspid, and also the right radial artery for the snare. We think about the snare for this patient because we have to bring the valve into the LV. And also the left femoral vein for the temporary pacemaker. This is the self-expandable valves, 33 for 34, and because of the 34, so we have to use 20 seats with two per close, and AO2 to enter the LV confidel Y, and we pre-dilatation with the 22 balloon. And this is you see the Y bias in the aorta. This is confidel Y. We see that the Y have to travel a curve into the LV. So it's quite difficult for the self-expandable valve enter the LV. You can see this one, the confidel Y go all the way to the LV, and we have the very big rock in the aortic valves. And this is the procedure. We use a balloon first to facilitate the valve enter the LV. This is a confidel Y, and this is a balloon 22 tight sac balloon. This is semi-compliant balloon. And this is, you see the valve's behavior. The valve, this is a snare. The valve behavior is quite difficult. After 5 times of the attempt, we successfully put the valve into the LV. So this is the final result. We still see a lot of constraint in the valves, but we think about the risk of rupture. So we stop the procedure. This is the pre and post procedure measurement. Before the procedure, the mean gradient about 63. After procedure, is about 11. So about this case. Horizontal aorta is still a challenge in the self-expandable valves to enter the LV, and balloon expandable valve I think is a very good solution in this situation. In the case of self-expandable valves, snare, 1 or 2 snare is a good option to obtain the success for the procedure. Thank you for listening.
Thank you for your nice case. Anyone have comment? Do you think it's possible just pass the valve across the calcified valve? I mean, do you think snare is a must?
You mean the snare?
Yeah.
We with the horizontal aorta like this, we have some case that we use a self-expandable valves, but it's very difficult. So we usually use snare for this case to get into the aorta. So because I see some patient in another center when they try to use the self-expandable valve with the horizontal aorta, sometimes we have the dissection of the aorta sometimes. So I think the snare is a good choice for in this situation.
Thank you. Okay, so I think because of time, we just move on to the next speaker. Next speaker is Dr. Dinh Huynh Lin. He's a cardiologist from Vietnam National Heart Institute. Dr. Lin, please.
Thank you, Mr. Chairman. Thank you, everyone, for inviting me here, and I'm so happy to have the chance to share my case. We have done about more than 30 cases of SAPIEN-3. The total number of TAVR in my center is not so high, just about 80 cases, so we are still learning. So my case today is a 74-year-old lady admitted due to heart failure, and on the echo shows severe aortic stenosis with mildly impaired EF. On the multi-slide CT, you can see it is the bicuspid type 0 with mildly dilated ascending aorta. And you can see the LVOT is a bit smaller than the annulus, but the annulus will fit the 23 millimeter S3, but you can see the severe heavily calcification in around the aortic valve. So we decided to do the predilatation with the 80 millimeter balloon, and you can see if it is very tight, we can underfill the 23 millimeter S3 a little bit, and it is hemodynamic. Before the procedure, you can see the very high gradient here. It is a predilatation using the 18 by 40 millimeter balloon, and we do the balloon sizing. You can see that there's no leak here, so it is very tight, and I can feel the tight when I cross the valve with the balloon. So we underfilled 1.5 cc with the S3 23 millimeter, and everything went well. You see that I try to inflate very slowly so that the valve can adapt well to the calcium, and we keep quite long inflation so that we can crush the calcium there. And it is after the procedure, you can see the heavy calcium here, and the valve is a little bit recoiled here, but quite okay. Not so much AR, and everything is quite okay. We normally don't do TEE during the procedure, so we have the standby T transthoracic echo, and it is the pre-TAVI gradient, and it is a post-gradient. It's about 16 per 7 millimeter for the intraannular valve. I'm quite happy about that, and see, we can see the mildly intraannular AR here, but it is mildly due to the Y, and on the short assist you can see the very tiny leakage is the paravalvular leak, and that made us a little bit unhappy. I don't know if anyone here will stop, maybe all of you will stop, but no, we decided to make it perfect. So we post-dilated with the same balloon with plus one more 0.5 cc. Yeah, it's like that, and you can see the valve is a little bit more expanded. Yeah, quite good, and you can see here we have the perfect hemodynamic here. It's like normal. But yeah, now it happened, and but you can see you see some hearing here suggested AR, and on the transthoracic echo you can see a very severe intraannular aortic resuscitation here. Yeah, you can see that. Yeah, very clear that you have the severe AR. Of course, we did think that it is Y-induced. You see, we do the aortogram, and you see the AR is quite severe. Yeah, and we think it is due to the Y, so we take out the Y, we put the picture in, we check the gradient, we have 0 gradient, but we did see low diastolic pressure, suggesting a very severe AR, and The LV-EDP is elevated as well, but patient is quite stable. So we know that it was not Y-induced AR. So what can we do? Our TE was not available, and we had no idea what is the cause of the AR. We tried to use the wire and the balloon to touch the leaflet to try to manipulate a little bit to make it better. And I, a little bit desperate. I put the balloon in and I post-dilated one more time and another more time, so 3 times. And you can see here the final result is still ugly. You see the moderate to severe AR here. You can see the Doppler echo here showing the AR. Quite severe, but the patient was quite good. And after long discussion with my mentor on the TAVR team, decided to stop the procedure because the patient was quite stable. We had spent more than 2 hours doing this case. We don't want to make it so complicated. As long as the patient is stable, we are confident that everything would be all right. And we decided to do the TE after the procedure. So we stopped the procedure and transferred the patient back to the normal ward. Back to the ICU, I'm sorry. But at the ICU, the patient got worse after 1 hour. She had dyspnea, crackle and runs in pulmonary. We did the bedside TEE, and you can see on this on these images that there's some haziness here, and the leaflet did not function as well as it should be. We had no idea what it is. Maybe the tearing of the leaflet or the leaflet gets stuck. We had no idea. I think that the multi-slide CT might be a good option to see what really happened. But the fact is that the patient cannot tolerate the MSCT. We do see the severe AR here, and she definitely needed another valve. So we, after 2 hours after the first procedure, we transfer her back to the cath lab. And because the first one is the S323 underfilled and very severe calcification, so we don't think that the second one should be 23. So we chose the 20 millimeter S3. We overfill a little bit, and we inflated the second valve. Yeah, it is a gradient. At first, it was not very good. The gradient is quite high because we have 2 layers of valve here, and on the TE, now at that time we intubated her, so we put the TE in. A TE shows some leakage between 2 valve layers and high gradient. We are not happy with 30/17, so we did post-dilatation with the same volume, and we get better hemodynamic. See the gradient is 19/11, so I think it's acceptable, and the hemodynamic is all right. You can see the EDP now is much better, and the aortogram show very mild AR, so we are very happy. And it is the final result of the TE after the procedure. You can see that the valve is quite good now. You can see the leaflet function very normal, very mild AR now. Patient was extubated nearly immediately. No symptoms. She can lie on bed. She had a very good sleep that night. And post-procedure TTE, the next day show good gradient. It's good. Okay, so we did some literature review, and unfortunately we did not find so many articles or reports about that. It is only one case published on the European Heart Journal about a case with cardiogenic shock after dilatation. They used the S3, and they has standby TE showing the stacker on 3 leaflets, so the patient collapsed, but they put very quickly another valve, and the final result was good. So we found that something similar to our case. First, in this case, the patient had a very severe consume, and they used the same device, the S3. So we have no idea about that. So that's why I brought this case here to learn about you and ask for your advice. But what we have learned is that although we know that severe intravalvular AR after post-dilatation is rare, because just only one case reported, but we know that post-dilatation can cause tearing or deformation of the valve leaflet, especially in case of the heavy calcification. In our case, I think might be one explanation is that the leaflet was compressed between the balloon and the bulky consume behind the valve, so that caused the tearing of the leaflet. And in this case, the second valve is mandatory. You cannot wait for longer. And standby TE might be helpful, and I think very important to say when that we say no, yeah, it's stopped, it's good enough. Thank you so much for your attention. Thank you.
Thank you, Dr. Lin, for your excellent case. Anyone have comment?
My question is that what is the reason why not put in the second valve immediately when you find this severe aortic regurgitation?
Why we didn't?
Yes.
Okay, yeah. So it is a very good question, and I did regret that I did not do that because the patient is quite stable. You see here the gradient is. Can you show the presentation if you don't mind? Gradient is good. Patient is quite stable, and when I watch the aortogram, I see the AI just moderate, and we don't want to make it so complicated. We have no idea what is the mechanism of the, of the IR. So I think the best way is that we have the TE at that time, so we have a look. We did not have TE, so we don't really want to make it too complicated. As long as the patient is still stable, she can lie on bed, and that we do the sedation only, and she's quite okay. So yeah, we just want to learn what really happens, so we stop and to do the best TE. Yeah, but it's a very good education case for us. Thank you.
Thank you. I think the company won't mind to open you another one in case that one.
They subsidize for the patient.
Yes, yeah. I think you've well managed the patient. Thank you.
But my question is still that. Thanks for that. What is the mechanism of the AR? Do you have any idea about that?
We don't know because we do use a lot of post-dilatation on the S3 as well, so we never see that happen before. So Dr. Lee, what do you think?
We have one that's I heard about in China. They have several cases, and mostly happen in 20 sapien because 20 sapien is shorter. So that's an unknown reason that the Shih-Hsien is shorter, maybe weaker. And the second problem is mostly when the balloon was pulled out from the valve area, and then you push the balloon into the annulus. So that maybe is balloon is partially inflated or not smoothly. So it's caught balloon caught the defibrillator in the side of balloon, but not opening from the middle. So that's a balloon just open from the commissure or partly from the part of the defibrillator, so cause the damage to the defibrillator tissue. So at I think at this time that they pull the balloon out and enter the balloon again. So it's not in the valve fully open, so there's maybe caught the defibrillator by balloon. At our cases is we just pull out the balloon and check the hemodynamics. It have some problem, so we post-dilate again. So maybe it should be pay more attention when you post-dilate when the balloon was deep from the annulus side and re-enter to the annulus.
You remind me one practice we always do. I forgot about that because that might be when you have a partially inflated balloon. When you go in the valve again, you caught part of the leaflet going downwards, And so when you balloon up, that kind of a folding of that kind of part of the leaflet causes a tear. So that's why I remember every time when we do the re-balloon, we go in the balloon first, and then we retrieve the balloon back to the aortic side. So we don't just go in and inflate. We go into the LV and then pull out a little bit. Yeah, that's in the start we get used to this practice just to avoid this kind of a tiny bit of a complication. Yeah.
Thank you so much. Thank you.
Okay, thank you. Is there no other question? Let's go to the fifth case. So let's invite Dr. Kit Bamin-Mung-Han from Pharmaceutic University Hospital, please.
Thank you for giving me the opportunity to attend this conference. Our case is an 80-year-old man with symptomatic severe calcific bicuspid aortic stenosis. His comorbidity was COPD GOLD, and he come with dyspnea on exertion. STS score is 4.4%, and our heart team conclude that TF-THV should be done due to high surgical risk as age and comorbid disease. And his ECG saw sinusitis with LVH, normal QRS duration with 4-degree AV block, and NT-proBNP was 15,000 picogram per ml, and current medication as shown, including aspirin, beta blocker, and diuretics. And his TTE showed impaired LV systolic function. Ejection fraction was 20%, AVA was 0.25 square centimeter, and Vmax was 4.2, and mean gradient was 45, with my MAC with my MR. And his coronary angiogram show only insignificant stenosis of mid RCA. And this is his CT, and this show the bicuspid type 0 with anterior posterior leaflet type with severe calcification at the leaflet and through the LVOT. As you can see, the LVOT a lot of calcification, and the calcium score was 9,000, and area was 420, and the area diameter was 23.1 mm. And the LVOT area was area diameter was 24, and as you can see, the calcification down to the LVOT. The SOV is big, and STJ is big, and no relevant low coronary height of the RCA and LCA. From the Barwat's classification, intercommissural distance at the 4 mm above annulus plane was 21.1 mm. Annulus area at annulus level, diameter was 23.1 mm, so it's compatible with taper type. And from Y method, the mean diameter at Shingen path, smallest part of the this valve was 21.8 mm. And another sizing method, we use the circle method, implant the virtual valve 23 mm SAPIEN. So we conclude that we will use 73 size 23 mm minus 1 ml. So in terms of the landing, due to we plan undersize the SAPIEN 3 size 23, and the aim of implantation was high 90/10%. So we plan a little bit go high at the one marker above the annulus, because we plan under expansion as first. About the access, as you can see, the light access is a bit small, so we plan to go for the left. And for the aorta, it's no relevant kinking or toxicity of the aorta and the arch. In terms of deployment angulation, as you can see, actually the deployment angulation, because of the leaflet is anterior posterior Thai zero bicuspid, the deployment angulation very extreme. So we plan to use another view that the tilt of the C-arm can be possible. So we plan to choose LEO1 cranial tree from the S-curve. So our planning is use sentinel embolic protection device because he was bicuspid. And the access for the TAVI, we plan use the left femoral. And with the single P-cross per cross foci technique. And pacing via the light IJ with temporary pacemaker because concerning about the conduction abnormality due to bicuspid and severe calcification. And we plan balloon P-dilatation with Edward balloon size 20 mm minus 2 ml. And plan 7-3 size 23 mm minus 1 cc. So at the procedure, we cross the aortic valve with the AL2 catheter with the state Y. And this is angiogram that a bit confused that could we use that view to deploy the device because as you can see that we cannot see clearly that this is true alignment plane of the leaflet or not. So I try to probe another cast, but it's difficult to see. So we choose the IO10 cranial 12 because this view, as you can see, pigtail in, I support that pigtail in the one cast and why that I probe in the another cast. And in this view, as you can see, the calcification we can see clearly on the right-hand side. So we should this view to manipulate. And we P-dilatation with balloon size 20 mm minus 2 cc. As you can see with the balloon, and we inject the contrast, that show that a bit faint contrast leak in the LV. And after inflate the balloon, the calcification move a little bit. So we can choose the same side, the Sapien 3 size 23 mm minus 1 cc. And this is during TAVI deployments at the IO10 cranial 12. But as you can see, we pan one marker above annulus. But you will see that the device, the Sapien, is a bit parallax of the valve frame. So at the end, we, as you can see that after implant, the light cast, the light pass is like 3 mm below annulus, but on the left side is only 0, a bit high. But the angiogram show only mild leak. Then we do the echocardiogram to confirm and show only trivial or mild AR. So we check the another hemodynamic peak-to-peak gradient decrease from 55 to 0 mm mercury, and sentinel was removed and received a small piece of thrombus. So we stopped the procedure. At the echocardiogram day 1 after the procedure, EOA was 1.09 and with the MyPVL. And the patient came back at the 6 months, improved symptom, and his NT-proBNP decreased to 400 and improved LV function to 60%. And mean gradient of aortic valve was 10 mm mercury and EOA was 1.0 square centimeter with only MyPVL. So the learning point for this case is the bicuspid aortic stenosis with severe calcification, TAVI can be done successfully. In terms of sizing, various methods can be used in bicuspid anatomy, aim to balance risk of annulus rupture and optimal device expansion and anchoring. And TAVI placement height depend on how expansion of device that we expect, anchoring and chole access issue. And it's made difficult to select optimal deployment angulation, especially in Thai zero bicuspid anterior posterior leaflet type because it's extreme angulation. And before the TAVR device deployment, severe parallax of the valve frame should be corrected to avoid malposition of the device. Thank you.
Thank you. Nice case and clear illustration of a difficult case. Thank you. Do we have any questions?
May I have question to the panelists? About how to select the angulation of the bicuspid Thai zero at this time, the AP leaflet, because it's extremely to clarify the two leaflet apart.
I think there's we just use select angle to just to make the two cuspid line. Yeah, I think there's no particular way to do. I think
it's called a volcano view. That's just a volcano. So that sometimes is not a coplanar view, because when you put in a coplanar view, that's a very large angle about the IO or LO. So sometimes you must sacrifice the caudal or cranial. So that's tilting the valve just like this. So you can probe from this line. And when the best way is you have this kind of a volcano view in the coplanar view. So that sometimes the limitation of a machine, so that you can let more cranial or more caudal, and you can see the leaflet can open in the middle, and you can probe the valve quite clearly.
Thank you.
Thank you. Let's go to next case. May I introduce Dr. Thinakrit Sasiprafa. He's a cardiologist from the Ramathibodi Hospital, Bangkok, Thailand.
Good evening, ladies and gentlemen, and thank you for your kind introduction. Can I have my slide, please? Okay, thank you. I'm gonna make it quick. I know you are all tired and hungry. Okay, so let's go into the background of the patient. Now we have a 73-year-old woman, a small lady. Her height is about 150 centimeters. She presented with a dyspnea assertion, functional Ka-Chun without heart failure admission, and it echo showed a severe aortic stenosis with mild aortic regurgitation. You can see that this is a dry leaflet aortic valve with a mean gradient about 41 and Vmax is 4.1 centimeter over second. And we did a CT scan for TAVR planning. And you can see that we have a small annulus in the small patient. That area is about 387, and perimeter is 70.9, and derived parameter is about 22.2 millimeters for the annulus. And area derived diameter for the LVOT is 3.1, and SOV is quite small, about around 27, and STJ is 28 and 30. So we have a very small annulus, small SOV, and small STJ. Yep. And about coronary height, as you can predict, it's not uncommon in our Asian population. This is a borderline low of left coronary height about 9.3, and it's good for right RCA is about 13.7. So we plan to do TAVR after we go into the heart team and the patient deny of surgery. So we put something we have concern about this case. First is a very small annulus, which we have discussed all of the days about the hemodynamic gradient, about some much trial in the morning, and the risk of coronary obstruction in this case is very a very concern of us in that time. We did pay at a TAVR that day. So we plan to do a chimney procedure in this case before a TAVR, and we go with our S3 valve according to the size of area 387. And before we go into the room, we look into the CT again and we check we use the 33. The VTC is about 1.9 millimeter. And the leaflet is quite long, and you can see this above the LCA height. Okay, but the show must go on at the time. So we do angiogram in the 3-class view. You can appreciate a very small annulus. And we put the guiding catheter of 6 French with the wire, guide wire, or BMW wire. And normally we will put the guide extension into the coronary artery for protection. For everything happen, we can put a stent or a balloon into that, and then we do the TAVR. And you can see it's quite straightforward for TAVR. We put a S3 in without any complication or any difficulty, and then dilate in the full manner at the nominal pressure here. And I want you to focus on this in the left cuts here, and there's something might happen after this. We slowly deploy that, and you can see we pull back the guiding, and we leave only the guide extension here. And this is an aortogram after we deploy the valve, and you can see we did a good job without a significant AR. But after we do an angiogram, we are not sure something might happen. I want to ask about the comments or thought of our expert and panelists here. If you have any comments about this angiogram. We did an injection via a hand injection, but because there is a guide extension in the left ascending artery, so the flow is flushed into only in the guide extension. We cannot clearly see in this area. What will you do if you were in our situation?
I think we perform the IVUS. To check the left main if there's any protruding material like leaflet into the left main.
Okay, thank you for your suggestion. To be honest, we spend a lot of time into discussion more than we do the TAVR in this case, maybe about 15 or 20 minutes. And we agree that we should do IVUS, but if we want to do an IVUS, we have to pull back the guide extension. And the drawback of that may be if something compressed the left coronary artery already, it may be compressed and we cannot go into it, in the artery anymore. So we decide to put a stent first in this case. So one of my mentors, if you want to stent and you cannot, if you won't do that and you cannot sleep it that day, just stent it. So we stent it in this time. And you can see there's the full expansion of the 4O stent. And after that, we did an IVUS to see what happened. And this is IVUS pulled back from the left main, of the LAD here. And you can see the position of the left main is quite big, about 50 millimeter. And after that, you can see a compression in the between the valve and at the SCJ junction here. This is quite tight. So this is a picture illustrates the fixed frame of the compression here. This is about 5 millimeters long. So we post-dilate with the NC balloon at 16 millimeter and ATM, and this is the final result. Actually, the angiogram looks not bad, but the IVUS still shows some kind of compression at the junction area that I mentioned before. And echo show a good result of mean gradient about 4 millimeter, and along with the mean gradient along with the catheter. So I will let you see the IVUS again. This is the final, but I don't think we cannot do anything more than that. We just give her that, but the patient still well. This is about 6 months after the procedure already. So this is my learning points here. There are many risk factors of this case that can cause coronary obstruction, and shimmy technique with guide extension is useful for managing coronary obstruction in this case, and IVUS can truly identify the coronary obstruction. Actually, if you look back and we may tell the patient, it may be the good choice to do the TAVR, because if you want to do the TAVR in TAV, again, maybe it's very difficult in this case, and not to mention to re-access the choreotomies, which may be in the future. Thank you for your attention.
So what is the cause of the under-expansion of the stent?
We thought this is a calcified leaflet that is pushed back from the valve, the TAVR, because there's this very a small room between the valve and the left choreosteo. We thought that.
Maybe you can consider use the IVL to treat the lesion.
Yeah, I hope so, but we don't have it in Thailand, unfortunately. Oh, we have a question. Sure.
Thank you for interesting case. I had a nearly similar case, so there are a couple of questions I want to ask you and the panelists as well. First of all, do you think it is safer to put a longer stent, like a 24 something, so that it go up all the way to the aorta and it prevent, that in case of some compression, it is safer than a 60 millimeter stent? The second question is that, because I have no experience about that, should I put a stent with a better radial force, like the Megatron, rather than the Synergy? So does it have, I'm not sure about that. And the last thing is that I had a case with a severe calcification near the left main, and I was very afraid that it will obstruct the left main. But it happened totally differently, that the calcium will push our valve into the other side, to the RCA. So is there any way that we predict that the valve will push the calcium, or the calcium will push the valve? Is there any way that you can predict that based on multiplicity? Thank you.
Can I have a slide up into the? Okay. The first question is, do we need a long stent? I think we need, because it's not the mechanism that is obstruct at the ostium. It's beyond it, into the STJ, and maybe you can see that it's come from the ostia, and the obstruction beyond, not at the osteo, of the left main. So we need the longer stent to cover, like this picture in the last one. And the second, I think it's maybe better to choose the better strength of the stent in this case. But unfortunately, Megatron is not available in Thailand too. So we have limited option in country. But
the tip of the S3 and the STJ, not much you can do about it.
Yeah.
Because it's not the leaflet that, or the calcium that caused the stent to be malformed. It is the narrowest spot is where the stent passed the STJ on one side, and another side is the S3 frame. So I don't think we can do anything much about it.
Yeah, I think the wire is jailed between the valve and the STJ.
Yeah.
So probably you may need to rewire the left main from the caster through the strut into the left main.
You mean the snorkel?
Yeah, because the stent frame is quite big.
Mm-hmm.
You have a higher chance to rewire the wire from the strut into the left main. Then you can put the stent properly.
Yeah, like a snorkel, right, into the last frame and the sapien. Okay. We're not sure. I'm not sure about that, but let me guess. I think it depends on the calcium and the first, anything that we know about that, the coronary obstruction risk. And more than that, it depends on the angle, but we cannot predict, you mean we cannot predict correctly where the valve will go, right? It will tilt this way. So I think this depends on the calcification distribution in the leaflet. If it, let me explain this more clearly in the bicuspid. If it heavily calcified in the left way, so the valve will tilt in the other way. I think in some bicuspid, if the calcification is distributed more, not uniformly, maybe it act like a bicuspid in some way. I think I need some more comments from the expert.
Maybe that one would be a long discussion. We can have more discussion during
maybe
the
tomorrow.
dinner or something. So because of time, let's go to the last case.
Okay, thank you.
The last case is came from the Chen-Chi. He's from the National University Heart Center, Singapore. And he's a cardiac surgeon and well trained in Singapore. And then now he practices well in Singapore.
Hi, good evening. Thank you very much for having me here. I'm the only person standing between you and dinners. I will try to make everything simple. This is where I'm from. I'm from National University Heart Center, Singapore, and it's a very vibrant city. We have a lot of conferences, and we are all invite you to coming over. So I'm going to give you a little different perspective, and all the cases are challenging in terms of TAVI, small annulus, bicuspid aortic valve, small platelets. And we want to show you that from the surgeon perspective, this is also nothing easier for us. And see how we can do something to helping you guys and working through the journey of a patient in terms of a lifetime management of aortic stenosis. This is a 61-year-old Chinese male and females, and she's quite small, and BSA is 1.59. She has hypertension and dyslipidemia. The first time she presented to us is a fall and a syncope. And there was a history of reduced effort tolerance was not even noted by the patients. She's NYHA class 2, so we did a transthoracic echocardiogram. We noted that patient has a normal LVEF, concentric LV, remodeling, and a bicuspid aortic valve, 1 to 7 o'clock opening line. And his mean gradient is 38.6, and the aortic valve continuity is 0.85. You can see the right upper corner that she really have a lot of LVH, and the LV cavity was obliterated during the systolic phase. Voila, so this is the worst things for a surgeon when we look at the echo that we see the annulus of the aortic valve is only 18 millimeters. Then we're gonna scratch a hand and we realize that the upper ascending aorta is 41 millimeters. This is classical for bicuspid aortic valve with ascending aortopathies. And on the right side is the short axis for transthoracic echocardiogram showing this is bicuspid aortic valve. So this is the Doppler findings. When she referred to me, I also sent her for angiogram, and we noted that she has single lesion proximal LAD disease. So this is a CT scan we have done that we're showing her annulus is 2.04 cm, it's really small. And the ST junction is 2.63 cm. And we also can see that on the CT scan, the aorta is dilated. So she's at a borderline indication from surgical perspective. Usually we cut off is 45 millimeters. So this lady has a 42 millimeter diameter of ascending aorta. So in summary, this is 61-year-old lady with symptomatic severe bicuspid aortic stenosis with dilated ascending aorta and a small aortic annulus, single vessel LADs. And patient is not keen for long-term warfarin. So what should we offer? So severe aortic stenosis with small annulus creating both challenges for TAVI and the surgery as well. So it's a complex condition that poses challenges for treatments. So it's about the valve size, about the surgical risks, about hemodynamics. In terms of SAVRs, we have aortic root enlargement. This is not very simple operations, but it's very complex and high-risk surgeries. We can put in sutureless valve, but the durability is essential. We can perform bento procedures. And in terms of TAVI, we can have a design for small aortic annulus with relatively big EOA, but this lady is only 61 years old. How many TAVI you're going to perform for these ladies? So the key is patient-prosthesis mismatch. So I think this is well demonstrated in the early lectures. I'm not going to put it on anymore. So this is a meta-analysis that this is severe PPM is real, no matter what people are saying. So severe PPM is real. We need to avoid that. So this is a chart that most of the cardiology never sees. As a surgeon, we saw. So on the left chart, you can see there's a BSA and there is a EOAI. So this is how surgeon we're trying to put in at least a valve is in the green zones, but not even in the yellow or red zones. But you look at this lady is 1.5. Look at most of the average Asian people is about 1.5 to 1.7. So we need to put some kind of valve is 21 or 23. All right. Anything less than that is not going to work. Even 19, look at that, it's not going to work. So on the right-hand side is the mechanical valve and the biological valve. You can see the hepatic orifice area is very small compared to the valve design because you need place to sew. So this is a surgical view when you look at it. This is a small annulus. So we need to do annulus enlargement. So this is the very two classical annulus enlargements. They are all posterior annulus enlargement because it's more at the posterior part of the valve. But look at that. NICs can only increase by one valve size, but sometimes cannot even increase that. Monugin sounds promising, can increase by 2 valve size, but look at that monugin need to cut into the anterior leaflet of the mitral valve. Well, if you injure the mitral valve and you end up with doing 2 valves. Very high risk. Right, so this is a monugin, so you incise into the mitral valve, you put a patch over there, you hope everything will be all right for the mitral valve and hope there's no leak at the aortic root. But you can only increase by 2 valve size. This lady has 19, increased by 2 valve size is just barely 23, and it's not going to be good for the future TAVI valve in valve. Oh, this is the even worse corner procedure. Only pediatric patients, surgeons know how to do it. So much destructions open on the RVOT, open the ventricular septum, even though it can increase in size a lot, but it's seldomly performed by adult cardiac surgeon. So this is what actually was new in the last few years. In 2021, Professor Bo-Yang from Michigan, University of Michigan, and proposed this one incision aortic root enlargement. It doesn't involve in the mitrals. It cutting until the mitral annulus. So it going all the way down to the mitral annulus and follow the mitral annulus and doing the incision, putting a square patch over there. It can be easily increasing the valve size by 3 to 4, not causing any mitral valve injuries. Sounds very promising. So this is what we did for this lady. We did a aortic root enlargement is one incision, Bo-Yang techniques, Professor Bo-Yang technique. We putting an aortic valve replacement with 27 millimeter bioprosthetic valve. Remember that annulus is only 18, so now we increase to 27 millimeter bioprosthetic valve. We're putting an inspiris and hoping that resilient tissue can last even longer. And we also did a ascending aorta replacement, so leaving the ascending aorta out of the question in future in terms of TAVI valve in valve. And we also giving the best graph, Lima to LED, as a CHGH for his single LED coronary artery disease. So what we find out is a bicuspid aortic valve type 0, and the left and right coronary arteries are on ostium on each of the valve, on each of the caps. Native annulus is best is 21 millimeters. And it's a very thin aortic valve and a dilated ascending at a 45 millimeter intraoperatively, so we decided to replace it to preventing future annulus, aneurysms or dissections. So we did the aorta right atrium cannulation. We protect the heart with LV vent, antegrade retrograde cardioplegias, and we cool down the patient to 32 degrees. And this is to save the time and ischemic time for the heart. We did the unpumped beating heart for CABGs. So this is what we find out before she discharged, postoperative echocardiogram, her LEF 75% after relieving the aortic stenosis. Look at that mean gradient, single digit for surgical valve. Aortic valve by continuity equation is 1.8. Her BSA is 1.6. It's more than enough for her to do any exercise. There's no paravalvular leaks. We also did a CT TAVR after that. Look at it. This is a coronal views of the valve. There's no more dilated aortas. We also have a transfused view. We can see the right top corner is the right coronary artery. The distance is between 5 to 6 millimeter, and also to the left is 5. This is the valve to coronary distance. And on top of the valve, we can see that it's ample space to preventing coronary aortic root sequestration in future TAVI valve in surgical valve procedure. And she also have a patent edema to LADs. So PPM is real and is really related to patients' quality of life and morbidity and mortalities, and the pressure gradient accelerating structural valve degenerations. We need to think about a patient as a surgeon, but also as considered as a cardiologist, how to helping them in terms of lifetime management in the aortic valve disease, how to set up the TAVI valve involved after TAVR. As I say, everybody say the first incision is very important. All right, we set up the things so that patient can enjoy the life. So we also need to balance the surgical risk versus long-term outcomes for a patient with a small aortic annulus. All right, that's all my presentations. And the next year we are holding ASCVTS 2025. We have sessions on transcatheter valve, cardiology meet surgeons, heart team discussions. You're all welcome. And thank you, that's all.
Thank you. I think this is last but not least of the cases speak for the surgeons. And nowadays, just because of the TAVI, I think in the surgical community, we have performing the root enlargement much more common than before. So that's why in the recent comparative trials, you can see the surgical arm, the gradient and the EOA of the postoperative results is very comparable with the TAVI kind of a prophysis. Is there any other questions or comments from the audience or our panelists? If no, thank you very much. We have a very fruitful case discussion, and let's come again and join the discussion tomorrow. Thank you.